Can you see my slides now?
Yes, sir. Yeah. Just have to make it full screen, sir.
Right, I'll do that. How is it now?
Better, sir. Yeah. Yes, now it's full screen. Yes.
Right. Okay. Good morning, everyone. I'm Ravi Disanayaka from Aurelia. Thank you for letting me do this lecture in the first place. I'm going to talk to you next 20-25 minutes about seizures, mainly focusing on the acute management, as you're all going to be manning the wards, hopefully within days or weeks, as first contact doctors. My presentation, I'm going to touch upon a definition of seizure and a little bit of phases of seizure and the classification, the basic etiological factors and differential diagnosis when you are presenting with a patient suspected of seizure, and about a bit about diagnostic evaluation and on acute management of epilepsy or convulsive seizure. So how do you define a seizure? Seizure can be defined as a paroxysmal uncontrolled electrical discharge of neurons in the brain that interrupts normal function. I know you all have gone through med school training and learning on about how the neurons work and how the electrical activities work and all that. But if there is uncontrolled electrical activity which occurs as paroxysms that interrupts the normal electrical activity, that would be contributed to a seizure. Usually this is due to underlying illness. So then what is epilepsy? Epilepsy is a recurrent seizure disorder characterized by abnormal electrical discharge from the brain, often in the cerebral cortex. So in order to diagnose epilepsy, you have to have recurrent seizures, and you have characterized by this same or the abnormal electrical discharge. Or it can be also defined as a chronic seizure disorder with recurrent and unprovoked seizures. Why there are two different definitions? I'll tell you why. That is because the first definition will discuss about abnormal electrical discharges of the brain. So in order to define epilepsy, then of course you need to have a definition or describe the abnormal electrical discharge. In certain scenarios, you will not be able easy access to this demonstration of electrical discharge in the form of electroencephalogram or EEG, what we usually use as a shortened form. So in that case, how do you diagnose epilepsy if you don't have access to easy access to EEG? In that setting, you can use it. The second definition, there is chronic seizure disorder, and which with the recurrent unprovoked seizures. So coming to the phases of seizure, usual generalized tonic-clonic seizures. I am not going to discuss about all the forms of seizures, but the generalized tonic-clonic seizure has mainly three phases that's given in the three green bars. That causes oral phase, ictal phase, and post-ictal phase. However, in certain instances, you can clearly define some prodromal phase. The prodromal phase is a phase where you get certain signs or activities going up to like hours or even a day or two before the onset of a seizure, where the patients or the person experience uneasiness, maybe a bit of headache or abnormal behavior, which is not amounted to the phases of a seizure per se, but however, it is considered a prodromal phase. Those who have had epilepsy, or those patients who are diagnosed epileptic, certain type of epilepsy, they describe this prodromal phase, and they can tell that they're going to have a seizure by feeling these different sensations. But when it comes to the phases of seizure, there are these three classic phases we describe. That is the oral phase, which can go up to minutes or maybe sometimes beyond minutes, with some sensory warnings. And then the ictal phase, where is the true seizure or the convulsion occurs. And there is a post-ictal phase immediately after the seizure, they go into kind of low responsive or resting state, which we call a postictal phase, where the patient recovers back to the normal self after. Again, it can go up to hours sometimes. So going into the details again about the stages of classic seizure or convulsive seizure, where we call generalized tonic-clonic pattern seizures. The aura stages, the graphic representation on your left shows how they feel. They can get confused, bit of hallucination, feeling dizzy and numbness, or certain distorted emotions. So the patients will get these feelings going up to minutes or maybe an hour or so sometimes. And then they develop this tonic stage, where usually the patient's muscles go into a spasm due to this electrical activity I described earlier. With this tonic stage, patients usually get arched back. That is because of your spinal muscle or paraspinous muscles goes into a spasm. So patients very rigid, and they might get incontinence of urine and sometimes feces, and the body also gets into a stiff position, and certain instances you can get epileptic cry. The tonic stage usually lasts seconds to minute, but mostly seconds, and then they develop into this chronic stage. Chronic stage is where you get these jerky movements, classically described as a seizure in lay terms or lay people, as a fit or apasmara or whatever you call it in Tamil. So the jerky movements, there can be breath, frothing of saliva, and then blinking of eyes or rolling of eyes. The clonic stage again can go up to minutes in most cases, but however, if it goes beyond certain period of time, we consider it as a status, which we will come into later. And the last stage, or the post-seizure stage, is the postictal stage, where you feel the patient will feel very exhausted with the weak limbs, and patients usually feel sleepy or drowsy, and that can go up to hours. So, classification of seizures. There are several classifications which probably you have learned in the medical school days. I'm not going to touch on all that, but this is based on the 2017 International League Against Epilepsy criteria. They describe seizures as basically three types: the focal seizures and generalized seizures, and there are certain unknown categories they have classified. Based on the types of seizures, the epilepsy also can be categorized into focal, general, and then combined general and focal, and then unknown. In certain epilepsy types, there are syndromes described, but which are beyond our today's topic. So I'm not going to touch on any of those, and I'm just mainly focusing on the generalized seizure patterns and mainly management of generalized chronic conversions. Again, bit of etiology. Etiology there can be structural brain injuries or genetic factors, infections, particularly CNS infections, and metabolic conditions, immune, and there can be unknown conditions as well. So a bit again about the etiology. The common thing is the idiopathic epilepsy, where you can't find a structural abnormality, but you get the patients developing recurrent seizure disorder, mostly occurring diagnosed around the age of 20 or just before 20. And again, out of that lot, the first year of life, the highest incident, and at the time of puberty, you get people diagnosed with epilepsy. So the other factors just I mentioned earlier, genetic factors, then certain strokes, or as a stroke sequelae, people get seizures, brain hypoxia, brain tumors or structural lesions, again, intracranial infections, and head injury. Those are the common causes of seizures, and also there can be certain other things such as environmental or air pollution, carbon monoxide, lead, and the intrauterine life infections also implicated in certain type of seizure disorders. And seizures also can be caused by emotional disturbances and certain environmental stressors. And last but not least, the drugs and alcohol, which is, of course, a good chunk in our day-to-day clinical practice. You have to keep in mind that drugs includes all the drugs of illicit drugs as well as medications, prescribed medications, and also alcohol. In the case of drugs and alcohol, the intoxications or overdose can cause seizures, as well as withdrawal can lead to seizure development. Particularly in the case of diagnosed epileptic patients who are on treatment, you have to think about anti-epileptic drug withdrawal as a cause of seizure when you are assessing the patient. Okay. So what are the differential diagnoses of a seizure? And why is it important for you to know the differential diagnosis? Because as the previous speaker discussed, the book medicine and the hospital medicine is a little different. So one difference is your patient will not come like in the textbook with a label of diagnosis. The patient will come with a set of symptoms, and then you want to diagnose. So if somebody is coming with maybe a history suggestive seizure, there are certain differential diagnosis you have to think about, because they all can be overlapped. So one thing is the pseudo seizure, what we call the psychogenic non-epileptic seizures, and then the other common differential is the syncope. So there can be certain other things, and sleep disorders, and hyperperfusion, conditions of brain, cardiac arrhythmias, emotional outbursts, drop attacks, migraines, and then hypoglycemia can present as a seizure. So going back to these things, the first two differential diagnoses, I'm going to little detail about how do you differentiate an episode of seizure or epileptic seizure from a pseudo seizure or a syncope. So next slide, I'm going to discuss about the comparison of non-epileptic or psychogenic non-epileptic seizures versus epileptic seizure. So there are a few behavioral patterns and certain biomarkers we can use to differentiate whether the patient develops, whether the patient is having a true epileptic seizure or a pseudo seizure or a psychogenic non-epileptic seizure. So when it comes to eye behaviors, usually the epileptic seizures, patients tend to get frequency or eyes closed, whereas these pseudo seizures or non-epileptic seizures with the psychogenic seizures, their eyes open. And weeping, when you think about consider about weeping, the pseudo seizure people have weep, whereas epileptic seizures, it's very rare. Going to the ictal phase, there are a few things during the ictal phase which we can use to differentiate the pseudo seizures from epileptic seizures. First thing is the ictal movements. So the limb movements or the ictal movements. In the case of epileptic seizures, they are very stereotyped with a clear start and a stop. However, with the psychogenic non-epileptic seizures, they are multiform, very uncoordinated, waxing and waning. So it's not stereotype movements you get during the ictal phase. And then you might not see a clear kind of start-stop thing. It's going here and there and waxing and waning type. And then the ictal stuttering and post-ictal whispering, it is seen in post-pseudo seizures or the non-epileptic seizures, psychogenic ones, whereas it's very rare with the epileptiform seizures. Ictal hyperventilation, that is again the hyperventilation pattern seen commonly with psychogenic non-epileptiform seizures, whereas you won't see much in the epileptic seizures, so it's very rare. Then the post-ictal phase, again, there are few features we can use to differentiate from pseudo seizures or psychogenic non-epileptic seizures. Post-ictal cough and nose wiping and post-ictal stertorous breathing, it's not seen in the pseudo seizures on psychogenic non-epileptiform seizures, whereas you see it in the epileptic seizures. Particularly post-ictal cough and nose wiping is seen in the temporal lobe epilepsy. And then the post-ictal superficial rapid breathing, that is something you see in psychogenic non-epileptiform seizures, whereas you won't see it in the epileptic patients. And few other biomarkers we can utilize to differentiate whether it's a true epileptic seizure or a psychogenic non-epileptic seizures. That is to check the blood levels of lactate and prolactin. So those tend to be elevated in the epileptic seizure, but it's not so elevated in pseudo seizures, or it's not elevated at all in the case of prolactin. Also, you can use creatine kinase levels. Again, convulsive seizure disorders or epileptic seizures, you get the CKs rising rapidly compared to non-epileptiform non-epileptic seizures. So this is some clinical measures as well as some biomarkers where it's useful for you to identify whether the patient has a true epileptic seizure or a psychogenic non-epileptic seizure, which is very useful during your clinical practice. And next, coming to the syncope. So how do you differentiate whether the patient had a seizure or syncope? All these things are very useful when, particularly, even if you like say if you don't know this, or if you don't observe the seizure. If you observe the seizure, you will get more first-hand experience. But most cases you will come across a patient coming with a history of this kind of a collapse. So you don't know whether it's a true seizure. Ideally, you should either get a eyewitness to come and show you, or you have to get other modes of evidence, such as like a video clip. Nowadays, you can ask for, most people carry their video phones. You can ask them to video it and bring it, so that if you see that, particularly in the case of children, you can ask the parents, because they are always with the patient or with the child. So you can ask them to record that and bring it. So that can be very useful in order to diagnose this as a seizure or disorder, or seizure or epilepsy rather. So how do you differentiate seizure and syncope? There are a few features again, which in the history and also during the examination or during the phase of collapse. So lateral tongue bite, which has a very good or very strong factor in favor of a seizure. And the sensation of déjà vu sensation, that is where the patient experience something for the first time, but will feel that he had the same experience before. So that is called déjà vu sensation. So that is characteristic of seizure. And during the spell, the patient turning head to a side, that is also head turning, is considered a positive sign for seizure, and associated emotional stress, and also the posturing and unusual jerking. And then the post-ictal phase confusion, that is also in favor of a seizure. But in the patients who are having syncope, they will have associated lightheadedness, sweating, and also the history of prolonged sitting or standing. They will not have features suggestive of lateral tongue bite, all that. So that can be used in the clinical setting to differentiate whether patient had a seizure or syncope. Going in little detail, this is of course more or less an academic exercise. The same features you can be used in the basically on the research setting. How do you calculate based on the score system? You give points to each of the features and then add up to get the final score, summing up score to diagnose. Same features I mentioned before: lateral tongue bite, déjà vu sensation, emotional stress, head turning, unresponsive posturing or unusual posturing, and the post-ictal confusion. Each one getting positive marks in favor of a seizure, with the lateral tongue bite getting 2 points, whereas all the other features getting 1 point each. So the lightheadedness, sweating, and prolonged standing and sitting getting -2 marks each. So if you add all that together, and if the total or sum of points get a score of over 1 or more, then of course it's in favor of a seizure. Whereas if it is less than 1 or minus, then of course 0 or minus, then of course it is more in favor of a syncope. So that is how you basically differentiate a person who is coming with a seizure-like activity, whether they have had a non-epileptic form seizure, psychogenic, or a syncope. So how do you proceed with the diagnostic evaluation? I mentioned how to differentiate with the differential diagnosis, but the full diagnostic evaluation includes a complete seizure history with the normal history taking. So which, as a first clerking doctor, you should be thorough about how to document that and how to take a detailed history about seizure. So this would include sometimes even in the adult medicine about their childhood history of infections, trauma, and also vaccinations, and all that details about obstetric and during intrapartum, and all the complications, or if there had been any detailed details about history of childhood epilepsy or seizure disorder or any trauma. Then one little bit about physical examination. Physical examination, which includes a complete neurological examination, and also you have to describe the seizure activity. As I mentioned earlier, it's important for you to get as much evidence as possible and to see whether you can get details from a eyewitness or somebody who is close to the patient who had been there with their this seizure activity, or as maybe video records and things like that. Nowadays, of course, with these CCTVs and all that available everywhere, so you probably will be able to get some video evidence of the seizure happening if it happens in a public place. So you can just inquire about that with the patient possible if it happens in a safe or in a shop or a common place. There can be instances where you can get even CCTV footings about the event. So the next major diagnostic step is to get the electroencephalogram or the EEG, what we call, that is giving the records of the brain electrical activity. I'm not going to details about it, but however, it is useful for us to focus the abnormal electrical discharges if present, even during the interictal phase, that is when in between the phases of seizures, if they're having abnormal electrical discharges, which can be helpful in diagnosis of seizure disorder. And also, it can be useful in the identification of the type of seizure the patient is having. And further into the diagnostic evaluation, you got to do the imaging. Imaging includes CT scan of the brain and MRI scan where available. In most places, you will be having access to CT scans where you're going to be working, but I'm not sure about MRI. It is usually not readily available. But in the case of workup towards not in the acute setting, you will have to sometimes order MRI as well. Then in advanced imaging, the positron emission tomography or SPECT, that is single photon emission computer tomography, those can be useful, but however, it's not very readily available. So and also will be useful only in certain handful of patients who needs or who are considered for surgery in epilepsy can be useful. But in all cases, you need to do the lab investigations or lab studies, of course, within the scope of you as a house officer. You will be manning that part of it, and lab studies may be useful in the form of diagnosis, aid in the diagnosis, and also looking for complications as well as looking for etiology. So the major things in the diagnostic laboratory studies is to look for the sugar levels and complete blood count, renal functions, liver functions, and then in certain cases where you suspect infections, CNS infections, you will have to do a lumbar puncture to study the CSF parameters and also drug levels, particularly the anti-epileptic drug levels if they were previously treated with anti-epileptic drugs, or if you think about any toxicology things. So the toxicology screening nowadays, it's available in most centers. You can do urine or you can do blood levels to look for any illicit drugs, and also ethanol in certain instances, not in every case. Excuse me. So coming to the acute management, which is the main area of my topic today, I want every one of you to focus more on this acute management part of it, because you will be handling a major chunk of it, or maybe in charge of certain major chunk of it. So we talk about mainly the stepwise approach to acute or non-convulsive patient or patient having a fit. This could be your ward, or it could be the accident and emergency or admissions, acute admission unit, or it could be anywhere. It may be your post surgical patient, or it could be your obstetric patient, or it could be your baby in the neonatal unit, or wherever you're going to be working, you can come across the patient's fitting. So I'm going to mainly focus on adult point of view. So I'm afraid I am not going to touch on the pediatric doses and pediatric management. So the first step is the stabilization phase of acute management, which is from the onset to 5 minutes of the seizure. And then from 5 minutes onwards, we start the therapy phase. So therapy phase can be roughly discussed about 3 levels, which is the initial therapy level, where there is good evidence of benzodiazepines being the choice with a level A, and the secondary therapy and the third therapy where there is less evidence in the form of research. So I'm going to each step in detail. Stabilization phase, that is, I mentioned to you about from the start to 5 minutes of the seizure, there where you need to stabilize the patient and make sure that all the general measures are taken before you go for therapy or treatment phase. So how do you stabilize a patient? So the airway, breathing, circulation, and disability, I'm not going to go into detail of this. I know probably you have gone through this several times. So you need to check your patient's airway and check his breathing and then assess his circulation. And also maybe with the time permitting, you can go to the neurological examination to look for any disability because in your fitting patient. So one important thing in this setting is you got to get help of everyone. So you are team leader as long as you are alone with as a doctor. But when you get your senior help, then you can hand over your leadership to the senior person. But you need to get the help of all the other teams in the unit. That is your nurses, assistant staff, maybe sometimes the bystanders, to help with certain aspects of the patient management. So you need to lead, and in order to lead the team, you need to know what is happening in the situation, and you need to be thorough about how to handle the situation. So the first thing is the position of the patient. You keep them left lateral or semi-prone position with the head little bent forwards, or what we call a recovery position, to prevent the patient aspirating and prevent anything going in when they are fitting. And also it is important to note the time seizure from the beginning, because all this management protocols depends on the time or duration of the seizure, whilst monitoring all the vital parameters. And the oxygenation is a key in this patient who is fitting. So you need to give oxygen via a mask, and maybe consider other advanced maneuvers, including oral pharyngeal airway if you think there is, or tongue falling back, and all sorts of things happening to keep the patient airway. You might consider giving oral pharyngeal airway. But if the patients need to be going beyond that level, or if you think the patient intubation is needed, then of course you definitely need the senior help, because as intern house officers, you're not expected to intubate patients without supervision. So stabilization phase continued. So initial phase, you position the patient, you initiate the monitoring, and if ideally is available, you get the ECG monitoring continuous, and monitor saturation and respiratory rate as well. Then you need to get the IV access with wide bore cannulae, preferably 2 cannulae, about 18 gauge, and collect blood for investigation. So IV access preferably should be obtained within first minute of the first 5 minutes, and you collect blood for investigations, which includes electrolytes, hematology, toxicology, drug levels, and maybe blood sugar levels from the hospital lab. However, you can get a gas or blood gas analysis also from the same sample. Even before or same time, you can check the finger stick blood glucose, which is available now everywhere with the glucometer finger strip. If the sugar levels are less than 60 milligrams per deciliter, or some places you can take it as 70, or if it is less than 60, definitely you need to correct with intravenous dextrose. So one way of correcting is to give 10% dextrose via a peripheral line. You can give it about a bolus of 5 milligrams per kg bolus rapidly. Maybe an adult of 60 kilos, you can give 250 to 300 ml, 10% dextrose, and then you turn over to a 5 ml per kg per hour infusion. However, you need to continuously check the sugars every 5 minutes to make sure that the sugar levels come back to normal. Then one more thing to remember, if you're correcting hypoglycemia, you need to give thiamine intravenously about 1 to 2 milligrams per kilogram, again about 100 milligrams in an average adult, particularly in the cases of suspected alcohol excess, or anybody is possible at alcohol. You don't have to always have the history of alcohol, but if you suspect the possibility of alcohol in the background, give thiamine, or long-term alcohol user or suspected alcohol excess user, you give thiamine to prevent them developing wernicke's encephalopathy, because that can be a problem in the case of patients acutely fitting. Then next thing is this same period, you need to get somebody to prepare the medications. It's not your duty to do it, but the nurse assisting you can prepare your emergency medicines, which includes benzodiazepines, which I will come to the next step. So initial first 5 minutes, if the patient seizures terminates, then of course you don't have to proceed to the therapy phase. But if the person is still fitting after 5 minutes, then that is the time you consider to initiate the pharmacotherapy, or in therapy phase, where you start with the benzodiazepines, which is having the good level of evidence. You give diazepam, which is the commonest available drug in our setting, about 0.1 to 0.2 milligram per kilogram per dose. So you start with maybe 5 milligrams in average adult. You can go up to 10 milligrams if you're confident enough, but I would suggest you using 5 milligrams IV. You give it as a bolus, and maybe make sure that you flush the cannula with a normal saline after giving diazepam, and observe the patient. Continuous monitoring to be continued. But if diazepam is not available, or if it is the other alternate is to give midazolam, but in the case of midazolam, you're not supposed to give intravenous, but intramuscular. If you're giving intramuscular midazolam, it is about 10 milligrams for those adults about 40 kilos. But if somebody is between 13 to 40 kilos, you can give half that dose. So the other option is, if not for lorazepam or midazolam or diazepam, is to go for lorazepam IV. That is again from 0.1 milligram per kilogram per dose. You can go up to maybe maximum of 4 milligrams. It can be given IV again. And all these drugs, you give it and then continues to monitor, giving oxygen to the patient, and let 5 to 10 minutes. You can go up to 10 minutes and observe if the patient is settling. If the patient does not settle, or if the seizure does not settle beyond 5 minutes, or if the seizure is getting worse, or activity is going worse, you may repeat once at the same dose. Other option, if the above 3 is not available in the initial therapy, is to give IV phenobarbital. That is, of course, you don't give 2 doses, but you give only 1 dose, about 15 milligram per kg, or there can be instances where you have to give rectal diazepam, particularly in the pediatrics, but I'm not expert on pediatric use. And also sometimes there is praise for intranasal or buccal midazolam as an initial therapy if you can't give diazepam intravenously. So if you give 2 doses and the patient seizure terminates, then of course you proceed to the routine activity. But if does not settle after 20 minutes, maybe you have to consider the status epilepticus. Usually, and by definition, if the seizure goes beyond 30 minutes, you call it a status. But if it is more than after two episodes, like you give 10 minutes and then you do 2 doses and 20 to 25 minutes gone, then of course, if there is no response, or if the seizure is still continuous, you need to continue for a second line agent or second line therapy. In our setting, we use phenytoin intravenously, or you can even use it as intraosseous if you can't get IV access. There, you of course give a loading dose of 20 milligram per kg over 20-minute infusion. In the case of phenytoin infusion, you got to be very careful because this can cause cardiac dysrhythmias, particularly patients who are vulnerable in the medical setting in adult medicine. So you need to get ECG monitoring, continuous ECG monitoring during and after the infusion to look for cardiac dysrhythmias. Alternate would be to give phenobarbital. Again, you can give 20 milligrams per kg as a bolus, same way over infusion. Infusion just like the phenytoin infusion, but only thing is if the patients had been on phenytoin or phenobarbital as a long-term epileptic treatment or been given already previously, then of course you can't give the same loading dose. In that case, you halve the dose, maybe give 10 milligram per kg of the same drug. So now you manage the patient initial phase, you went into the second line and you gave loading dose of phenytoin. If the patient settles with that, that's fine, then you can proceed with the routine management. But for instance, there can be instances where the patient is not responding to your treatment despite the loading dose of phenytoin. So if it is not responding, what else you can do? So that is kind of third phase. So we call it like after 60 minutes of treatment, all three treatment, despite all that, if it is not responding, then we call it a refractory status epilepticus. In this phase, of course, there is no clear guidance or evidence. However, you can repeat the second line therapy again, but the main stay is next stay is to give a patient a general anesthetic and keep the patient under intensive care with basically intubation and mechanical ventilation with sedation. So if you give anesthetic doses of all the medications, you can give thiopental sodium or midazolam or phenobarbital, or in that or the propofol. This has to be under anesthetic guidance, and you intubate the patient and transfer the patient to intensive care. Of course, I don't want to go into details of that. That will be beyond the intern house officer level. So that's basically a therapy phase. Patients might need prolonged intubation, or not prolonged intubation, or intubation and ventilation for up to hours to days before they can gradually take them off ventilation and sedation. That's basically what the acute management is. But once the seizure is terminated, for instance, if the seizure terminates before the therapy phase, fine, within first 5 minutes, you just reassess the patient, or you in any other stage, maybe second stage, seizure terminates, or even third stage, seizure terminates. You got to reassess the patient's ABCDE as always, which we do. And then the patient continues to nurse the patient on the recovery position till they completely recover from their postictal phase. And then you got to revisiting the history and examination again to diagnose and also look for any complications of the convulsion or the status. So I'll come to the complications later. And in cases of patients who were previously diagnosed having epilepsy, you need to consider administration of their habitual medication or what medication they were on earlier. So you will have to restart them on their regular medications. Maybe sometimes if the patients are not alert enough to take the medicines, you might even consider giving them via an nasogastric tube or other mode of delivery other than the oral. So also you need to consider patient as a whole, so address the other concomitant health conditions. Maybe they're having infections, maybe head trauma, maybe diabetes. So you address their chronic health conditions or concomitant health conditions. And one word about pregnancy. If the patient is pregnant, then of course you will have to consider the seizure episode as eclampsia, and there is a place for magnesium sulfate administration in the patients who are presenting with seizures in pregnancy, but not in every case. But if you consider eclampsia. So what are the complications you look for in the medical following a status? So these are the common medical complications which can be seen after status, particularly if it is a prolonged or status epilepticus. First thing is the hypoxia. Patients can be hypoxic after a prolonged seizure, or they can be hypoglycemic. There is lactic acidosis, rhabdomyolysis, and electrolytic disturbances. You need to look for these actively and treat accordingly. Hyper and hypoventilation, and there's high risk they develop raised intracranial pressure, and they will develop sometimes they can get even temperature or hyperpyrexia. So you need to actively look for these, because particularly the patients will be drowsy after the seizure. They can be post-ictal phase. It could be the post-ictal phase, or it could be due to the medications you have used to treat the seizure. So they can be very drowsy, and you have to actively look for all these things. Otherwise, patients will have complications leading to further sequelae of your patient. I'm not going to touch how you manage each of these complications, because I know you all have had loads and loads of lectures on each of those, most of these complications. And how about one word about long-term therapy? So you have to consider long-term therapy, but if of course it is beyond your levels as an intern house officer. But however, patients, depending on their appropriate presentations, you have to consider. So for instance, if somebody is just coming with hypoglycemia and induced seizure, they probably not need a long-term anti-epileptic therapy. However, for instance, if a patient comes with a recurrent seizure with background multi-infarct dementia, so which is a structural brain injury, brain damage, so they will most likely a long-term or indefinite anti-epileptic therapy. So it has to be a patient-centered or patient-specific, patient-tailored treatment for anti-epileptic. So that is basically it. These are my references, and thank you.
Roshan, can I start?
Hello, Roshan.
Roshan, can I start now? Hello, Roshan, can I start now? Roshan, hello. Okay, since we are already running late, I'm going to start. Okay, the next lecture is on management of hypertensive emergency and acute heart failure. There are a lot of things I want to tell you, but since my time is limited to 30 minutes, I will do what is absolutely necessary as an intern only. Right, first we will look at the scenario, which is very common. Let's think about this patient, a 40-year-old male who presents to the emergency department with sudden severe chest pain, which started 30 minutes ago. He's on treatment for diabetes and hypertension. The initial assessment, which you can do within about a minute, shows that his saturation on room is 97%, his pulse rate is 120 beats per minute, his blood pressure is 200 by 110, and his random blood glucose is 280, and his chest is clear. This is a very common scenario. As an intern house officer, what are you going to do next? The first thing you have to do is to formulate a pragmatic problem list. It is very important in any emergency. What are the problems he has? There is sudden onset chest pain on background of diabetes, hypertension, which is most likely an acute coronary syndrome. His blood pressure is very high. He has tachycardia. His blood glucose is high. And in summary, it's a critically ill patient who has a high risk of dying within next few minutes if you don't do something very quickly. If you look at the most important problems he has, they are the fact that he has most likely an acute coronary syndrome, his blood pressure is very high, and that there's a risk of dying within few minutes to hours if you don't do something. This is a hypertensive emergency. If you look at the definition of hypertensive emergency, it is where the systolic blood pressure is 180 millimeters mercury or more, diastolic blood pressure of 120, associated impending or acute hypertension mediated organ damage or HMOD. The operative words here, which you have to put more emphasis is the level of systolic blood pressure, level of diastolic blood pressure, and most important, the fact that the patient should have impending or acute hypertensive mediated organ damage. Therefore, isolated severe hypertension without acute HMOD is not a hypertensive emergency. A patient who comes to you with a blood pressure 200 and 110, if he doesn't have impending or acute hypertensive mediated organ damage, it's not a hypertensive emergency. Then, severe hypertension with chronic hypertensive mediated organ damage is also not a hypertensive emergency. For example, a patient coming with chronic kidney disease related to hypertension and very high blood pressure is not a hypertensive emergency. What you have to think is you have to think if you don't get the blood pressure down very quickly, whether the patient will die or not. If it is not so, then it is not a hypertensive emergency. What are the examples of hypertensive emergencies? Those are when blood pressure is more than 180 to 110 in setting of acute coronary syndrome, pulmonary edema, aortic dissection, cerebral infarction, cerebral hemorrhage, hypertensive encephalopathy, acute kidney injury, pre-eclampsia and eclampsia, and malignant hypertension. As you can see, all these conditions are very serious conditions, and if you don't act quickly, the patient will die. Although there are a lot of examples of hypertensive emergencies, what is common are acute coronary syndromes, pulmonary edema, cerebral infarctions, cerebral hemorrhages, and pre-eclampsia. Usually, the underlying hypertensive mediated organ damage is easily diagnosed by clinical features and few investigations. For example, in a patient coming with chest pain and very high blood pressure, you do troponin and ECG, then the diagnosis is clear. So in the case of a patient with cerebral infarction, cerebral hemorrhages. A malignant hypertension, in other hand, is somewhat difficult to diagnose. Therefore, I'm going to tell you a few words about malignant hypertension. Malignant hypertension is severe hypertension, that is blood pressure more than 180 to 110, associated fundoscopic damages, which are flame-shaped hemorrhages and papilledema with microangiopathy and disseminated intravascular coagulation. The hallmark of this condition is small artery fibrinolysis in kidney, retina, and brain. That is the reason for microangiopathy. It can be associated with encephalopathy, acute heart failure, and acute deterioration of renal function as well. Although this is categorized as a hypertensive emergency, it is different from other hypertensive emergencies because the need to reduce blood pressure is slower in malignant hypertension. There are a lot of things that you need to know about management of hypertensive emergencies, but if you know the following, you can save the patients. The busy interns must know in hypertensive emergency, you need to reduce the mean arterial blood pressure by 15% to 20% within minutes to hours, depending on the condition. And the target blood pressure should be around 160 by 100. These patients are very ill, therefore frequent monitoring of blood pressure, mean arterial pressure, pulse rate, and oxygen saturation must. Therefore, monitoring the patient with the multi-parameter is absolutely necessary. You must be worried now, how the hell I am going to check the patient mean arterial blood pressure. However, most monitors give mean arterial blood. Look at this. In these patients, blood pressure is 80 by 50, but mean arterial blood pressure is 60. It's given in the monitor. It's easy for you. And another thing that I want to tell you, which I see very frequently in the wards, that you have to adjust the monitor's vital signs so that it checks the blood pressure, pulse rates, and other things at least every 15 minutes. There's no point of checking the blood pressure every hour or every half an hour in a hypertensive emergency. You have to set the machine so that it checks these vital signs very frequently. And you always have to set up upper and lower limits of the upper and lower limit alarms of the parameters that you want to check. There are a lot of drugs that are used in hypertensive emergency. However, what are available in Sri Lanka are IV labetalol, IV glyceride trinitrate, and IV hydrolysine. And using these three antihypertensive drugs, you can manage almost all hypertensive emergencies. A word of caution here is, if you see various guidelines on management of hypertensive emergency, you will see different targets and rate of reduction. This is because there's hardly any evidence in management of hypertensive emergencies. Therefore, you shouldn't worry too much about these different rates of reduction and different blood pressure targets. Drugs used in hypertensive emergency which are available in Sri Lanka, a few more details on that. Labetalol, glyceride trinitrate, and hydrolysine. The doses I have given here, you don't have to remember. You can always check in a book. You should know about indicated clinical situations. For example, labetalol is indicated in aortic dissection, neurological emergencies, pre-eclampsia and eclampsia, and malignant hypertension. And glyceride trinitrate is used in acute coronary syndrome, acute left ventricular failure, and hydrolysine is used in pre-eclampsia and eclampsia. Let's go quickly through various specific situations. Acute coronary syndrome. Acute coronary syndrome becomes a hypertensive emergency if acute coronary syndrome presents with blood pressure of more than 180 by 110. The target blood pressure is systolic blood pressure less than 140. That should be your aim. However, you have to take to your mind that acute coronary syndrome may get completed by cardiogenic shock. The patient may come with very high blood pressure, but within minutes, he may go into shock. So you have to be aware. You have to monitor the patient very carefully and see whether the patient goes into cardiogenic shock. The drugs that I use, the drug of choice is IV glyceride trinitrate. However, as second line drug, IV labetalol can be used. Then pain control by using opioids can also influence blood pressure. Control of pain is very important, so because it helps in reducing the blood pressure. Acute pulmonary edema. In acute pulmonary edema also, the target blood pressure is less than 140. Here again, the first line treatment is IV GTN, IV sodium nitroprusside, which is not available in Sri Lanka. It can also be used. Loop diuretics is also another drug that can be used in pulmonary edema, as you know. Obviously, you should not use labetalol in acute pulmonary edema. Aortic dissection, unlike pulmonary edema and acute coronary syndrome, aortic dissection will be difficult to diagnose. You need a high degree of suspicion to diagnose. Always check inequality in blood pressure in two arms in those who present chest pain. If the blood pressures of two arms are different, then you have to suspect aortic dissection. Echocardiogram, CT angiogram are helpful in diagnosis. They can have concomitant STEMI. The reason you know, it is very important to rule out aortic dissection, because if you give thrombolysis for patients with aortic dissection without diagnosing properly, it ends up in catastrophic sequences. The target blood pressure here is lower. The systolic blood pressure should be lower to 120 millimeters mercury, and the pulse rate should also be reduced to less than 60 beats per minute. And IV labetalol is used, it causes bradycardia and reduce blood pressure as well. When you come to neurological hypertensive emergencies, cerebral infarction. In a patient coming with cerebral infarction, and if thrombolysis is not planned, then the blood pressure needs to be treated only if it is more than 220 to over 120. You need not, even though hypertensive emergency, is defined as a blood pressure of 180 to 110. Cerebral infarction, if thrombolysis is not planned, you should not treat blood pressure unless it is over 220 to 120, because treating lower blood pressure may increase ischemic area. And the reduction of blood pressure is, the target is reduction of mean arterial pressure by 15% over 24 hours, slowly. And IV labetalol is the first line treatment. In cerebral infarction, if thrombolysis is planned, then it is different. You have to treat the blood pressure if systolic blood pressure more than 185 and diastolic blood pressure more than 110. And you have to need this blood pressure below 120 to 105 for 24 hours because it reduces bleeding. IV labetalol has to be used. In acute intracerebral hemorrhages, the target mean arterial blood pressure is 110. You have to keep it like that for first 24 hours. However, if there's increased intracranial pressure, then mean arterial blood pressure should not be less than 130 for the first 24 hours. You have to see whether there are any evidence of increased intracranial pressure. If so, you shouldn't reduce the blood pressure too low. IV labetalol again is the first line treatment. In acute subarachnoid hemorrhage, the target systolic blood pressure is 160. You have to keep this blood pressure until an aneurysm is treated and IV labetalol is used. In summary of the things I have told you up to now, you must have noticed acute cardiovascular emergencies, blood pressure can be lowered relatively safely. Patients with cardiovascular emergencies tolerate a lower blood pressure more safely. However, in acute cerebrovascular neurological emergencies, lowering of blood pressure needs to be done more carefully. The target is higher and you have to reduce the blood pressure also more slowly compared with cardiovascular emergencies. Malignant hypertension. Malignant hypertension, which I described earlier, is when blood pressure more than 180 to 110 with papilledema, retinal hemorrhages, and microangiopathy. Here, mean arterial blood pressure should be reduced to 20 to 25% within 24 to 48. You have to go slow. IV labetalol is the first line treatment. In hypertensive encephalopathy, usually associated with malignant hypertension, patients have cerebral edema, therefore they have drowsiness and seizures. Here it's different. The mean arterial blood pressure has to be reduced to 20 to 25% or diastolic blood pressure to 100 to 110 within an hour. Here you have to reduce the blood pressure more quickly because increased intracranial pressure will lead to catastrophic sequences. After that, there should be gradual reduction until the blood pressure is normal within 24 to 48 hours. Here again, IV labetalol is the first line treatment. Preeclampsia, eclampsia, and HELP syndrome. You have to reduce the blood pressure immediately so that systolic blood pressure is less than 160 and diastolic blood pressure less than 105. You may have to consider delivery or termination of pregnancy. IV hydralazine and IV labetalol are the drugs that is used. Acute kidney injury. A word about acute kidney injury. Acute kidney injury usually associated with hypotension. However, acute kidney injury can be associated with malignant hypertension. It has to be managed as above. In rare situations where acute kidney injury is associated with high blood pressure, pheneldopan, which is a dopamine agonist not available in Sri Lanka, is used. Swapping to oral treatment. This is also an important area. Early introduction of oral therapy is recommended. You will have to monitor the patient and start oral therapy as soon as possible. You may need to consider secondary hypertension in these patients who comes with hypertensive emergencies. Usually, you can simply restart the usual anti-hypertensive regimes the patient was already on. And you have to maintain the IV treated blood pressure initially and slowly titrate to individualized targets. In summary, the definition of hypertensive emergency is when systolic blood pressure is more than 180 and diastolic blood pressure is more than 120 associated with impending or acute hypertensive mediated organ damage. You have to identify what is not a hypertensive emergency. Blood pressure needs to be reduced within minutes to hours to prevent death. Cardiac and cerebrovascular emergencies are common, and intravenous labetalol, glycerol trionitrate, and hydralazine are used. And with use of these three antihypertensive agents, many hypertensive emergencies can be managed very easily. There's another part. This is management of acute heart failure. This also will start with the scenario is very common. A 55-year-old man who presents with worsening dyspnea for 2 days is a diagnosed patient with diabetes, hypertension, coronary heart disease, and heart failure. Ejection fraction when it was done last was 40%. Initial assessment, again, you can do this assessment within a minute. Saturation on room air is 89%, pulse rate 100, blood pressure 130/90, respiratory rate 28. There is bilateral leg swelling up to mid-calf level. There are fine crepitations up to mid-zone and random blood glucose 220. What is the diagnosis? Is acute heart failure. A very common presentation. What is acute heart failure? It can be practically defined as rapid or gradual onset of symptoms and or signs of heart failure severe enough for the patient to seek urgent medical attention. There are 4 major clinical presentations of acute heart failure. They are acute decompensation of existing heart failure, cardiogenic shock, acute pulmonary edema, and isolated right ventricular failure. You should try to fit your patient into one for easier decision making. The scenario that we talked about, of course, falls into acute decompensation of existing heart failure. However, there is a considerable overlap between them. These are the 5 types of acute heart failure, where I have described the main mechanism, main cause of symptoms, onset, hemodynamic abnormality, and main treatment. And you will see why it is easier if you can fit your patient into one of them. If you take acute decompensated heart failure, main mechanisms are left ventricular dysfunction and sodium and water retention. And main cause of symptoms are fluid accumulation and increased intraventricular pressure. Onset is gradual. Hemodynamic abnormalities, increased left ventricular diastolic pressure, low or normal systolic blood pressure, and cardiac output. Main treatment is diuretic. However, if there is reduction of blood pressure and cardiac output, vasopressors and inotropes needs to be used. This is the commonest type of acute heart failure. Cardiogenic shock is also not uncommon. The main mechanism is severe cardiac dysfunction, which can be due to acute MI or myocarditis. Main cause of symptoms is systemic hypertension. Onset is usually gradual. In here, there's always reduced systolic blood pressure and reduced cardiac output. The main treatment here is inotropes and vasopressors, not diuretics. Acute pulmonary edema, on the other hand, there's increased afterload, diastolic dysfunction, and valvular problems like mitral stenosis. The main cause of symptoms is fluid redistribution to lungs. Patient may not have peripheral edema, but only pulmonary edema. The onset is also rapid. There's increased left ventricular diastolic pressure. However, systolic blood pressure is usually high or normal. The main treatment is diuretics and vasodilators. Rarely, a patient can present with isolated right ventricular failure, where the main mechanism is right ventricular dysfunction or precapillary pulmonary hypertension. The main cause of symptom is increased central venous pressure. The onset is gradual or rapid. There's increased right ventricular diastolic pressure. Systolic blood pressure and cardiac output is usually low. That is because of increased venous return actually. Therefore, even the systolic blood pressure and cardiac output is low, the main treatment is diuretic. However, vasopressors and inotropes also needs to be used. Now you see why it is important. So important to try to fit your patient in one of these. Then the treatment, which is what is important for you as an intern, it will be clear. However, you have to bear in mind there's considerable overlap between these 2 and these 4 causes, and a patient presenting with one type of acute heart failure can later go into something else. Drugs used in acute heart failure are oxygen, diuretics, inotropes, vasopressors, and vasodilators. Oxygen and ventilator support is very important in patients with acute heart failure because the main ultimate cause of the death of the patient is hypoxia. Many patients with acute heart failure are hypoxic. However, you have to use oxygen with caution. Use oxygen only when saturation is less than 90% because, as you know, oxygen causes vasoconstriction, which may increase heart failure. Non-invasive ventilation is indicated respiratory rate is more than 25 and saturation is less than 90. However, you have to monitor your blood pressure very carefully in patients with non-invasive ventilation because blood pressure may drop during non-invasive ventilation due to increase in intrathoracic pressure. You have to use non-invasive ventilation with caution if blood pressure is low. In case non-invasive ventilation fail, you should not hesitate to start intubation in a patient with acute heart failure. Diuretics are the cornerstone of treatment except in cardiogenic shock. Loop diuretic furosemide is used and it has to be used intravenously. The usual dose is 1 to 2 times the regular oral dose. If the patient is new to diuretics, start with 20 to 40 milligrams. You should give it in IV boluses or IV infusion. There's not much of a difference between using boluses and infusion. However, you have to give it, if you give it as boluses, 2 to 3 times a day. Once a day is not recommended. How do you know whether your diuretic treatment is effective? You have to measure your hourly urine output. The target is 100 to 150 milliliters per hour, which indicates a good response. If the response is not good, then you can up titrate the dose. Many people are scared to give diuretics if blood pressure is lowish. However, using IV furosemide, even if in condition with low blood pressure, will not reduce the blood pressure. Inotropes are used in acute heart failure with low cardiac output and hypertension. For example, cardiogenic shock. You have to use inotropes if systolic blood pressure is less than 90 millimeters mercury because otherwise it will affect perfusion of vital organs. However, using inotropes increase oxygen demand and induce arrhythmia and can make matters worse. Dobutamine is the most commonly used inotrope in Sri Lanka. The dose is 2 to 20 micrograms per kilogram per minute. The low dose dopamine is an alternative. Vasopressors are used in acute heart failure with hypertension, again in cardiogenic shock, for example, and acute heart failure in patients with compensated chronic heart failure with blood pressure is low. You can use vasopressors. The aim is to do peripheral vasoconstriction to preserve perfusion to vital organs. However, if you know your physiology, you can understand vasopressors increase afterload and can further reduce cardiac output. Therefore, they are usually used with inotropes. Noradrenaline is the preferred vasopressor use. The dose is 0.2 to 1 microgram per kilogram per minute. Dopamine, the higher dose, is an alternative. Inotropes and vasopressors should be used with extreme caution. Using inotropes and vasopressors in patients with heart failure is like whipping a tired horse. If the horse is very tired, however much you whip it, the horse will not work. You may rather kill it. However, therefore, you have to use vasopressors and inotropes only for correct indication. Use the lowest dose and stop as soon as possible. Vasodilators are used in acute heart failure associated with increased afterload and pulmonary edema. You can use vasodilators only if systolic blood pressure is 110 millimeters mercury. Glyceride trinitrate is the one available in Sri Lanka. It's used in IV infusion. The dose is 5 to 200 micrograms a minute. It has a very wide therapeutic range. Other drugs and procedures used in acute heart failure are opioids, which I am not going to discuss in length. Opioids are important in acute coronary syndromes and cardiac conditions, which is associated with chest pain. Digoxin is used in acute heart failure if that's associated with rapid atrial fibrillation. Thromboembolism and thromboembolism prophylaxis is very important. I mean, these patients have an increased risk of thromboembolism. They are bedbound. Therefore, it has to be used. And short-term mechanical circulatory support like intra-aortic balloon pumps are used in acute heart failure, but hardly any in Sri Lanka. Therefore, I'm not going to discuss in this lecture. What is most important management of acute heart failure? Treatment of the precipitating cause. If you don't treat precipitating cause, for example, in a patient coming with cardiogenic shock due to a MI, if you don't revascularize the patient quickly, however much you treat the patient with inotropes and vasopressors, patient will succumb. So prompt diagnosis and correction of the precipitating cause is of utmost importance. All the other things that I have discussed earlier, only by this time. You have to find the cause and treat. Okay, in summary, acute heart failure is defined as rapid or gradual onset symptoms and signs of heart failure severe enough for the patient to seek urgent medical attention. There are 4 types: acute decompensated heart failure, cardiogenic shock, acute pulmonary edema, and isolated right ventricular failure. Using diuretics, inotropes, vasopressors, and vasodilators, the acute heart failure can be managed. However, treatment of the precipitating cause is very important. I have 2 minutes. I don't know, Roshan, are you there? Can students ask question, 1 or 2 question? I can answer. Hello, Roshan. Okay, then I am leaving for the next lecture. Indika, I am leaving.
Yes. Okay. I think there are a few questions in the chat box.
Okay, let's see.
If you want.
Yeah. Let's see.
Yeah.
I finished in 28 minutes, so I think I have time for 1 or more. Yeah. I will ask 1 question. I will answer 1 question. What is target blood pressure in a non-patient hypertension who has been on hypertensives? You mean regarding acute hypertension emergency? Of course, after treatment of hypertension emergency, the target is the same. The target depends on the hypertension emergency. The target depends on the hypertension emergency, which I have described earlier. After the hypertension emergency is resolved, then you have to start oral treatment and get the blood pressure back to the individualized target. You can do it slowly. There's no target blood pressure. The target is, of course, depends on the individual. It's not something that we can discuss in this lecture. In chronic hypertensive patients, the mean arterial blood pressure is higher than normal people. So is it okay to reduce such amount of mean arterial initially suddenly? The next question is asking whether reduction of blood pressure initially is safe in chronic hypertension. Yeah, that also depends on the cause. In hypertension emergency, depending on the hypertension emergency, you have to reduce the mean arterial blood pressure either slowly or fast. For example, if a patient presenting with aortic dissection, even in chronic, many patients with aortic dissection are actually patients with chronic hypertension, you have to reduce the blood pressure within minutes to 120 because the emergency will kill the patient. In cases, in a case like ischemic stroke, you have to reduce blood pressure more slowly. Indika, can I answer 1 more question?
Yes, please.
what is the blood pressure target in SAH? I have discussed it earlier. This issue, you should keep it less than 160 until the aneurysm is treated, or until the patient becomes stable. What is the role of nimodipine in SAH and when to consider? Yeah, nimodipine is not used as an antihypertensive agent. Nimodipine associated with subarachnoid hemorrhage, there is cerebral vasoconstriction. Therefore, nimodipine is used to reduce cerebral vasoconstriction and reduction of the complication of cerebral ischemia. Can troponin I positive acute left? Yes, definitely. Question is asked whether troponin can be positive acute left ventricular failure. Of course, in acute left ventricular failure, because there's some sort of myocardial damage, troponin can be elevated. Therefore, you have to consider the level of elevation of troponin and associate ECG changes also to diagnose acute coronary syndrome. I think that's the question. That is very important. Patient coming with acute left ventricular failure, the precipitating cause can be a acute coronary syndrome. So you do troponin. However, troponin may be elevated due to left ventricular as well. Therefore, you have to consider the level. If the level of troponin is slightly above normal, then you can ignore it. And you can repeat it later to see whether there is an increase. And you have to do repeated ECGs to see whether there is dynamic ST segment changes. One more question, then I will hand over to Indika. After managing acute heart failure, which drug should be given on discharge? And what about long-term follow-up? I answered this question in the lecture. After managing acute heart failure, after managing acute heart failure, depends on the precipitating cause. For example, if acute heart failure is due to a MI, then the management is different. Then regarding long-term follow-up also, it depends on the cause. If the patient with chronic heart failure presented with acute decompensation due to, let's say, new atrial fibrillation, then you have to manage that. It can't be answered simply. Okay. I took about 3 minutes of a time.
It's okay, yeah.
Okay, then okay. Thank you, students.
Okay.
Thank you, Roshan, and thank you, Indira.
Yeah, you can unshare the screen.
Yeah.
Roshan, are you there? Can I start?
Wait till I stop sharing. Yeah.
Hello, Roshan, can you hear me? Hello?
Indika, I think Roshan is not there. I think you can carry on. Roshan didn't answer me also.
Yeah, now can you see my screen?
Yes, Indika, we can see.
Sanjeev?
Yeah, I can see.
Yeah,
I can see you and hear you. You can continue.
This one stuck. That was the problem. 1 minute, please. Some technical problem is there.
Indika, I was able to see your screen earlier, not now. Earlier I could see it.
Shall I go out and rejoin and see?
Indika, earlier I could see your screen, but not now.
Yeah,
You can't. You are a co-host. You should be able to share, isn't it?
yeah.
Roshan is not responding, and his mic is also muted. I think he's not there
Yeah.
at the station.
My presentation got stuck with this thing, so that's what I'm just thinking
I
what to
see.
do. Okay, yeah.
Can I call Roshan?
Yeah, please. You can.
Yeah.
All right, now it's working. Can you hear me?
Yeah, I can hear, but I can't see the shared screen.
You can't see. Okay, I'll try it. Yeah. Can you see
No,
now?
yeah, okay, yeah, can see.
Yeah, yeah. Yeah, but once when it is shared, it is not working.
Oh, you mean you can't go do the?
Yeah.
Now it's okay.
Yeah. Now it's
okay.
working. Now it's, yeah. Good morning, everyone. Sorry for the technical disturbances. At the outset, I would like to thank Dr. Lal Panapitia, DDG, Minister of Health, and Dr. Roshan and Dr. Tushara Matthias for arranging this, organizing this very important program for pre-interns. And we'll start straight away. Come on. Yeah. So we'll discuss few medical problems related to pregnancy, hyperemesis gravidarum, hypoglycemia in pregnancy, hypertension in pregnancy, liver disease in pregnancy, dengue in pregnancy, and COVID-19 pregnancy. All these conditions, they have very unique management with regard to pregnancy. Yeah, in hyperemesis gravidarum, we have to understand two important terms. One is nausea and vomiting in pregnancy, and other one is hyperemesis gravidarum in pregnancy. What is this? Why this is important is that we have had several maternal deaths even due to hyperemesis gravidarum. So nausea and vomiting in pregnancy, as you all know, it is the onset is in the first trimester without other cause for nausea and vomiting like UTI, peptic ulcer disease, or cholecystitis. And hyperemesis gravidarum is defined as nausea and vomiting in pregnancy with having a triad of more than 5% pre-pregnancy weight loss, having features of dehydration, and having electrolyte imbalance. So we have to make sure even the patient coming with nausea and vomiting in first trimester, whether there are any other underlying other causes for these patients, which could be the management could vary depending on the presenting cause. I'm very sorry, this technical problem is there. Sometimes it's not working. The slides are not running. Roshan, the tries are not that running. I don't know why.
So shall we switch it off and start again? Sometimes maybe stuck due to internet connections.
All right. So
If it doesn't go, so we go on this, that format. Yeah.
okay, right. You can see it now,
Yes, sir, we do.
but still it's not running. Yeah.
So shall we go to the other mode then? We'll
Other
exit
mode,
from.
yeah.
Yeah. Yes.
So we'll go in mode.
Yeah,
You can see, no? Yeah, okay.
we can, sir. We can.
Okay, hope you all can hear me.
Yes,
And
sir,
then
can.
we have to assess the nausea and vomiting in pregnancy using a pregnancy unique quantification of emesis score, which can be found in even in our internet, where we categorize these patients vomiting according to their severity. So if the severity is more than 12, the highest score is 15. It is very severe nausea and vomiting. If the patient is having severe nausea and vomiting, then the patient needs to come in. And if the patient is having more severe vomiting, nausea and vomiting, more than 12 in the PUQE score, then it can be hyperemesis gravidarum. Then you have to assess for 5% weight loss, dehydration, and electrolyte imbalance. You have to see whether there's any hypokalemia, because those patients can have arrhythmias, and then the patient can have fatal outcomes. And these patients first line of therapy for antiemetics is prochlorperazine. In the world we found it as Stemetil, and or promethazine. Those are the first line, and then that is Penagan. And second line is metoclopramide, domperidone, or ondansetron, which are available in suppositories, IV, and as well as oral. And third line is actually hydrocortisone and prednisone can be used under consultant's opinion and consultant's guidance. Make sure to correct dehydration and to correct the imbalance of electrolytes. And please watch out for blood sugar, because these patients can become hypoglycemic frequently. We have to monitor the urine output and see whether there's any significant dehydration, and monitor the vital functions, especially the blood pressure can go down. And please start oral thiamine or IV thiamine 100 mg per day if the patient is having prolonged vomiting. Then what we should not do in hyperemesis gravidarum is better not to give iron containing preparations, because it can worsen nausea, vomiting, and diazepam is contraindicated in the first trimester. And do not give phenothiazines and metoclopramide, if the patient had previous history of extrapenual side effects for those drugs. And don't start dextrose haphazardly without checking the blood sugar, and especially without giving thiamine. So make sure you start IV thiamine 100 mg per day if you want to give IV dextrose. And hypnotic therapies are involved in other countries, not in Sri Lanka much, but anyway, as per guidelines, it is not recommended for nausea and vomiting in pregnancy and hyperemesis gravidarum. Then hyperglycemia in pregnancy, we will discuss the main key issues. The patient, even before being pregnant, can have type 2 diabetes, maybe type 1 or type 2. And then there can be gestational diabetes mellitus, which can occur during the pregnancy. And you have to remember that pregnancy is a diabetogenic state. With the progression of the pregnancy, your hormone secretion is high in mothers, and then that can cause more diabetogenic state in the mother. So even the patient is having type 1 and type 2 diabetes on good control, the control can go off with the progression of the pregnancy. So pre-existing diabetes is a risk factor for pre-eclampsia also. So because of that, aspirin 150 mg at night is indicated after 12 weeks of period of gestation for these mothers to prevent pre-eclampsia. And gestational diabetes, actually it is diagnosed by a 75 gram oral glucose tolerance test. where we ask the patient to come 8 to 12 hours fasting, and fasting blood sugar we take cutoff as 92, and after 1 hour value we take it as 180, and second hour value we take as 140. So blood sugar monitoring is done by the blood sugar series, as you can see here. Blood sugar series is very important to monitor these patients, and the blood sugar cutoff values are not similar to the non-pregnant women. So for these patients, we expect we want to keep the fasting blood sugar less than 95, whereas in non-pregnant women we may be okay with less than 126. And for pregnant mothers, fasting we expect is less than 95, and postprandial blood sugar, that is 2 hours after main meal, should be less than 120 after each main meal. But if the patient is having polyhydramnios or macrosomia, then our ppbs values we bring it down to 100, so that those mothers should have ppbs values less than 100 milligrams per deciliter. So keep that in mind. Blood sugar control targets, since it is different to that of non-pregnant women, you may have to keep this, remember, when you practice maternal medicine. Metformin is the only oral hypoglycemic drug recommended in pregnancy. Other oral hypoglycemics are contraindicated in pregnancy, and we can start either metformin or insulin for patients having hypoglycemia in pregnancy, depending on the mother's first choice. But guidelines say now the trend is to start insulin for the mothers having pregnancy-induced GDM or else for type 2 or type 1 diabetes. And hypoglycemia in pregnancy, if you found to have the mother is having fasting blood sugar more than 126 milligrams per deciliter, then that is itself an indication to start insulin alone. And if the 75 gram oral OGTT value is more than 180, or ppbs value is more than 180, again we may have to start insulin, because with oral medications and lifestyle modifications, we may not be able to control that high values to our target. And if the blood sugar, fasting blood sugar, is remaining around 100 to 125, we may consider starting metformin with lifestyle modifications like medical nutrition therapy. And if the fasting blood sugar is between 92 to 99, that is less than 100, or if the OGTT value or the ppbs value less than 140, we may start first with non-pharmacological management, that is medical nutrition therapy, and see how patient goes and add on pharmacological therapy. If we happen to start insulin, the principle is and the main recommendation is to start a basal bolus regime, where we give basal insulin as well as bolus insulin to counteract the postprandial hyperglycemia. So we can ask the patient to have pre-meal short-acting soluble insulin 3 times per day before each main meal to counteract the postprandial hyperglycemia, and to give basal insulin at night before going to bed to counteract the fasting hyperglycemia, and to have the insulin throughout the day. Then once the patient is baby is delivered, insulin and the metformin requirement may not be there for patients having gestational diabetes. But for type 2 diabetes and type 1 diabetes patients, we will have to continue medications. So if the patient is having gestational diabetes mellitus and then following delivery, we have to stop the medication appropriately. So if the patient was on metformin alone, we can stop metformin after delivery. If the patient was on insulin, if the requirement was less than 0.5 units per kg per kilogram per day, then we can stop insulin. And if the insulin requirement is more than 1 international units per kilogram per day, then we will have to reduce the dose from 50% from the antenatal insulin requirement. Then what are the things we should not do in hyperglycemia in pregnancy? So we should not give oral hypoglycemics except metformin even in pre-pregnancy periods, because it is teratogenic. So other oral hypoglycemic drugs should not started on patients who are willing to get pregnant. And do not use HbA1c for blood sugar monitoring after 12 weeks of period of gestation, because there's a dilutional effect of anemia, and HbA1c is not that reliable to monitor blood sugar control in pregnancy. And do not allow the blood sugar targets to fall below 80, because it can cause fetal hypoglycemia. And we have seen patients in the wards, the house officers are doing blood sugar series after delivery, but after delivery blood sugar series is not indicated, and we can stop doing blood sugar series. But if you want to do, you can do fasting blood sugar and PPBS after lunch. And during after delivery, during breastfeeding, should not give any other oral hypoglycemics other than metformin. If you have to give any oral hypoglycemic medication, metformin is allowed, but other oral hypoglycemics also not allowed during breastfeeding. If the patient's blood sugar can't be controlled with metformin alone, then you will have to start on insulin for these mothers who are breastfeeding. Then we will discuss about hypertension in pregnancy. So there are few types in hypertension in pregnancy. A patient who is having hypertension before pregnancy can become pregnant. So that is chronic hypertension. And there can be pregnancy-induced hypertension, which is PIH, as you know, which occurs after 20 weeks of period of gestation without urine albumin. And then there can be preeclampsia, which is again starting after 20 weeks of period of gestation with albuminuria. And there can be patients with chronic hypertension who develop preeclampsia on top of chronic hypertension, which is called as preeclampsia superimposing on chronic hypertension, and which again or preeclampsia, which can progress into eclampsia, which is fits due to preeclampsia, seizures. So the blood pressure targets, of course, if you measure the blood pressure of a patient, pregnant mother, if it is more than 140/90, it is very strict. Then you have to measure it again after 10 to 15 minutes. And if it is still more than 140/90, either value, you have to start treatment. So you have to discuss with your senior colleague and then start treatment, because in pregnancy, hypertension is very, very important, because the hypertension can kill mothers and can have high maternal mortality rate in Sri Lanka. So because of that, if the blood pressure is more than 140/90, start treatment with other supervision. And for blood pressure control, our target is to keep the blood pressure less than 135/85 and more than 110/70. So we have to keep the blood pressure in that range. There are several antihypertensive drugs can be used in pregnancy, and there are some drugs which can't be used in pregnancy. What are the drugs we can use in pregnancy? Those are actually dihydropyridine calcium channel blockers, which is nifedipine and amlodipine group of drugs. Nifedipine, of course, you can go up to 60 milligram per day, maybe 20 TDS or 30 BD. And we can use labetalol, available in IV preparations as well as oral preparations. Oral preparations, you can go up to 200 milligram 3 times per day. We have methyl dopa oral, you can go up to 750 TDS, and which is now going out of practice, and guidelines also not that promoting for methyl dopa. And hydrazine, we have IV preparations as well as oral preparations, and IV GTN. Make sure to start aspirin 75 milligram daily for chronic hypertensive patients from 12 weeks of period of amenorrhea to prevent developing preeclampsia. Then if you have a mother with high blood pressure, which is more than 140/90, make sure that the patient is having preeclamptic toxemic features, which are just which are features of getting eclamptic fits just before the fits, right? So those are if the patient is complaining of headache, blurring of vision, double vision, or else right hypochondrial pain, or difficulty in breathing, reduced urine output. So if those features are there, that is the patient is having preeclamptic toxemia. So if those features are there with elevated blood pressure, then straight away IV treatment is recommended to bring down the blood pressure, because we can't allow the patients to have seizures. If the blood pressure is more than 180 by 110, even without pre-eclamptic toxemia, then you can start IV therapy. But if the patient's blood pressure is less than 180 by 110, without PET symptoms, then we can try oral therapy and monitor the patient. So if we happen to start IV medications, we have two main drugs, which is one is labetalol and one is hydralazine. If the patient is having history of asthma or active asthma, recently labetalol is contraindicated. Then you have to start hydralazine. If you are starting labetalol, you can give IV 20 to 50 milligram bolus and see whether the blood pressure coming down, and can give boluses maximally up to 200 milligrams. If it is not responding, then you can start a IV infusion 20 milligram per hour, which can go up to 160 milligram per hour. Then if you are going to start on hydralazine, you can start with 5 to 10 milligram bolus over 2 minutes, and the maximum would be 20 minutes, right? Maximum would be 20 milligrams. Then if the patient is not responding to the two boluses, then you can start a maintenance infusion 2 to 3 milligram per hour. Then if the patient is having PET symptoms, it is very important to start IV magnesium sulfate bolus to prevent eclampsia. And if the patient had any eclampsia, we have to start IV magnesium sulfate bolus followed by infusion. And we have to look for secondary cause of hypertension, maybe renal artery stenosis, acute renal failure, or thrombocytoma. So watch out for those also. And these patients need close monitoring in the presence of severe hypertension or PET symptoms. So what are the things we should not do for patients having hypertension in pregnancy? Don't start ACE inhibitors, angiotensin receptor blockers, diuretics for patients having chronic hypertension in pre-pregnancy period. If the patient says that I am going to be pregnant, please stop those drugs if the patient is on those drugs, because they are teratogenic. Then do not start beta blockers other than labetalol during pregnancy, because beta blockers can cause fetal growth retardation. And if the patient coming with preeclampsia and following that having eclamptic fits, don't give diazepam to control the fits. So it is contraindicated. We have to use magnesium, IV magnesium sulfate for eclamptic fits in eclampsia, right? And do not use angiotensin receptor blockers, thiazides and thiazide diuretics during breastfeeding. But in breastfeeding, ACE inhibitors, mainly Enrapil, is recommended. I mean, if you want, you can use it, and it's not contraindicated, but ARB is definitely contraindicated. Then we will discuss a little about liver disease in pregnancy. There are a few types of liver disease in pregnancy, which is intrahepatic cholestasis in pregnancy, which can occur in late second trimester or early third trimester. The patient can complaining of itching of soles and palms, and then can have nausea and vomiting and loss of appetite. So make sure you do liver function test, mainly SGOT-PT and bile acids. So if they are elevated, the patient is having intrahepatic cholestasis in pregnancy. So in those patients, the risk is to the fetus. There can be early IUD if the patient is having, if the mother is having intrahepatic cholestasis in pregnancy. And acute fatty liver in pregnancy, we diagnose using the Swansea criteria. This is a detrimental condition in pregnancy, acute fatty liver. In these patients, mainly the bilirubin will be high, so the patient will be icteric and will give history of loss of appetite, loss of appetite, vomiting, and nausea, and maybe abdominal pain and itching, pruritus. So those patients, if the bilirubin is high and SGOT-PT may be high but not up to the level of the bilirubin level, there can be a disproportionately elevated bilirubin levels. So those patients, you have to bring these patients to notice of your consultants immediately. And the HELP syndrome, which is hemolysis and elevated liver enzymes and low platelet syndrome, diagnosed with the Tennessee or Mississippi Health diagnostic criteria. Here, of course, more than the bilirubin, SGOT-PT is elevated disproportionately to the bilirubin level, and there can be history of elevated blood pressure also and preeclampsia also. These patients also need to get immediate attention, and will have to terminate the pregnancy as soon as possible. And there are patients with chronic hepatitis B and C infections during pregnancy. So if you suspect a patient having nausea and vomiting and loss of appetite and having elevated liver enzymes, then send blood for hepatitis screen. And acute hepatitis in pregnancy also common, hepatitis A mainly, and watch out for those. If the patient is having past history of connective tissue disorders and features of autoimmune diseases in the past, may come with elevated liver enzymes, may have autoimmune liver disease also. And we have had several mothers with cirrhosis with and even without portal hypertension. So be mindful and look for those mothers also. Then what are the things we should do in these patients if you find? So if you find intrahepatic cholestasis in pregnancy, make sure that your team delivers the baby early before 37 weeks of pregnancy, because otherwise you will end up with the intrauterine death, IUD, right? If you find acute fatty liver in pregnancy and HELLP syndrome, the delivery should be done immediately if mother's life is not under control. And make sure that the platelet transfusions to be done for LSCS for these patients, because most of these patients platelet counts are low. So preserve platelets, and for LSCS we need platelet counts more than 50,000, and for epidural analgesia and spinal anesthesia we need platelet count more than 80,000. Please watch for hypoglycemia, where these patients with liver disease can develop frequent hypoglycemia and cause have a detrimental effect to the mother as well as the fetus with the fetal hypoglycemia. And what are the things we should not do? So please don't, in liver disease in pregnancy, do not give hepatotoxic drugs like paracetamol and antifungals and antibiotics. Be careful. Read what are the drugs hepatotoxic, and don't continue on those drugs on these patients. And please don't give IM injections if platelet count is low or INR is high. Please do not overhydrate with normal saline in these patients, because anyway the fluid retention is a problem. Especially don't give excess salt, and which can cause water retention. And do not allow them to get constipated, because it gives a risk of getting hepatic encephalopathy. So now we'll discuss about cardiac disease pregnancy. Just a important note out of this, acute medicine, because now if you find a patient, a woman having these conditions, cardiac conditions, please do not allow them to get pregnant, because these cardiac conditions are contraindicated for pregnancy. What are those? If the patient is having pulmonary arterial hypertension, if the patient's systolic function is low, less than 30%, with or without history of postpartum cardiomyopathy, if the patient is having mitral stenosis or severe mitral stenosis or symptomatic aortic stenosis, or systemic right ventricle with reduced ventricular function, or history of aortic dilatation, Ehlers-Danlos syndrome. So those patients, actually we need to get cardiologist opinion before they get pregnant. So if you find them in your gyn clinics, please don't allow them to get pregnant, and offer them proper contraception, assess them and send them for assessment, and then after that they can get pregnant. So if you get a mother in your clinic or in your ward, they can complain of chest pain, palpitation, or difficulty in breathing on exertion. So be mindful. There are patients coming with pregnancy and congenital heart disease, pregnancy and prosthetic heart valves, and patients can have acquired heart disease like ischemic heart disease, or patients can develop peripartum cardiomyopathy during pregnancy. So we have to get a proper history and direct them for cardiology opinion and multidisciplinary meetings, and then assess them for their suitability and for continuation of the pregnancy. And a little bit about dengue in pregnancy. I think you must have seen the adult guideline for dengue. And in pregnancy, actually, we have to be careful about few things because now the hematocrit, usually we go by the hematocrit in adult dengue, but in pregnancy, hematocrit can be low compared to non-pregnant women. So because of because of the dilutional effect, there's fluid retention during pregnancy, especially towards the third trimester. So we have to be careful when we are interpreting hematocrit in dengue in pregnancy. So keep that in mind, and then please be careful about the interpretation of the pulse pressure, because pulse pressure can be wider than expected in pregnant women, especially in first trimester and second trimester. Their diastolic value can be low. Because of that, they can have wider pulse pressure. So for adults, we non-pregnant adults, we take 20 as cutoff for the profound shock, for the impending shock. But for pregnant women, we take it as 25 for impending shock. And some patients, in critical phase, we are not going to deliver the baby, either LSCS or vaginally, we are not going to induce in the critical phase because it's a hemorrhagic phase, which is detrimental to have the delivery at that stage. But sometimes we have seen the patient can go into delivery, and patient even can develop preeclampsia while on hemorrhagic phase. So be mindful about those, and these patients has to be managed in an ICU setting. And sometimes the timing of the leaking is very difficult to identify with the ultrasound with the gravid uterus, because the gravid uterus, especially in the trimester, it's difficult to find any hepatorenal pouch, and any other pelvic fluids, very difficult to find. So just those are some challenging points in pregnancy and dengue. So COVID-19, actually, if you find a mother with symptoms of COVID-19, just explain them that the infectious risk for pregnant women is similar to that of non-pregnant women, and please ask them to get vaccinated. About two-thirds of pregnant women can have symptoms, may not have symptoms at all, but even a few proportion of women in pregnancy can have symptoms, but those symptoms can be not that pronounced. So that is the key message. Now, if the patient is having myalgia may be very minimal compared to non-pregnant women. But when you come to the disease, severe disease or critical disease, pregnant women is more likely to get severe and critical disease compared to a non-pregnant women. So explain them, and because of that, even they feel a minor symptom, ask them to get admitted and assess, get fully assessment, and then discharge after that. And there's a risk of being on a ventilator for pregnant women with COVID-19 is 26 times higher than a non-pregnant woman. So just explain that to the patient. Right. So this brings us to the end of my talk, and thank you for listening. I will try to answer any questions you have put there. Roshan, are you there?
Yes, I'm here. So shall we start with the last question? Is there a place for glibeclamide in the hypoglycemia in pregnancy?
Yeah, there is no place for glibeclamide in pregnancy, but in American guidelines they use. But in our guidelines, Asian guidelines, and NICE guidelines, RCOG, we don't use glibeclamide because it can cause hypoglycemia, and then can affect the fetus also, and some teratogenic effects also can be there. So it's not recommended. Only oral hypoglycemic drug is the metformin during pregnancy, and even in during the preconception period.
Right. Next question up is in brief. Is there an indication before 12 weeks?
Which one?
Sorry, is there a place of aspirin before 12 weeks?
No, there's no place for
Indication to
aspirin.
start aspirin before 12 weeks.
No,
Rather, yeah.
there's one trial done where it has shown after 12 weeks there's effect of there's a effect of reducing the pre-eclampsia. So the aspirin we are giving to prevent pre-eclampsia because which is higher in incidence in type 2 diabetes and type 1 diabetes patients. So to prevent, the trial evidence says it's after 12 weeks, not before 12 weeks.
Right. Next question is, sir, how to advise breastfeeding in COVID-19 mother?
Yeah, COVID-19 mother, actually, we have to explain her that the breastfeeding is more beneficial than stopping breastfeeding to the baby, and even the baby gets COVID-19, giving breast milk is more valuable and it will give more benefits than not giving breastfeeding. And so ask her to wash her breast before feeding, and have the face mask and wash her hands, and then breastfeed the baby, and then she can keep her on the cot. So that's what we advise. And that's we have not come across increased risk of getting infections to the fetus while breastfeeding. So all around the world now we are promoting breastfeeding rather than not breastfeeding for patients with COVID-19.
Next question in brief, sir. Non-epileptic mother, pregnant mother comes with a fit at 32 weeks of POA. What should we give? Mag sulfate or diazepam?
So we had to give IV megsulfate 4 gram bolus followed by 1 gram infusion. Usually these patients they respond very well to IV megsulfate, and then as we discussed in the early talk, we have to keep the patient in hospital and oxygen and other monitoring vital parameters and blood sugar and those things. And then the blood pressure control is very important, and once the blood pressure is control is done, and we have to arrange for early delivery of the patient, of the baby.
Right. There are some questions. I can go on one or two questions. Let's see. Why metformin only during breastfeeding, not other hypoglycemics? That is one question. In brief, sir.
Yeah, that's of course because other drugs excrete via the breast milk and can cause fetal hypoglycemia. So because of the hypoglycemia in the baby. So because of that, we are not giving other anti-hypoglycemics.
Right. What is the implication of COVID on a fetus?
That of course earlier we thought there's no much effect, but now the evidence is there can be more early fetal early deliveries as well as some IUDs. So it is increasing incidence is there for mothers with COVID-19, especially in the second and third trimester. So if a mother gets COVID, that is risky for the fetus also with the current evidence. So better get them vaccinated without delaying.
Right. I think there are a few other questions. So we'll wrap up the session with Dr. Indika Boteju, consultant physician at DMH Colombo. Thank you very much for your informative and in-depth lecture on this.
I'm at Castle Street.
Sorry, sir. I'm sorry. I beg your pardon. Castle Street.
Okay, thank you, Roshan.
Thank you, sir. Next up is lectures on leptospirosis by Dr. Vimalasiri Uluwatta, senior consultant physician. Over to you, sir.
Good morning, Roshan.
Good morning, sir.
Good morning, everyone. And I'm going to share my slides with you.
Right. Can see, sir. Can start.
Can you see my slides?
Yes, we can. We can start, sir. Yeah.
Good morning, everyone. Thank you very much for inviting me to this important program organized by the Ministry of Health and College of Internal Medicine. My topic today is leptospirosis, and let's start with an introduction. Yes, leptospirosis is the most widespread zoonosis in the world. It presents all over the world except Antarctica. Now, it can infect more than 1 million people. This is the average, 1 million people around the world, and cause 60,000 deaths per year worldwide. According to the WHO study recently published in 2015, Sri Lanka has been identified as a hyper-endemic country associated with associated high mortality due to leptospirosis. As in turn, why should we bother about, or why should we pay attention to this particular infection is because it's a common cause of acute febrile illness in our country. Wherever you go, you will come across this infection in our country. And also, you can contribute in a big way in diagnosing these patients quite early and initiate treatment. This is one of the instances where house officers are allowed to start treatment, allowed to start antibiotics for patients with infection, especially in leptospirosis, because early treatment saves lives. So as a house officer, you will come across this infection quite often in your practice, and also you can contribute in saving lives. So that's why it's important for you to learn about and pay some attention about this infection. What is your role as an intern? Now, it's very important that because history plays a very important place in diagnosing leptospirosis, because it's essentially a clinical diagnosis initially. Because of that, taking a proper history to diagnose leptospirosis is very important. If you take a proper history, that will help you to identify a suspected case of leptospirosis. I'll go into detail of what it is. And then also in the initial stages, it's very important to differentiate. You must have the ability to differentiate leptospirosis from other common febrile illnesses, because its identification of leptospirosis as a leptospirosis case in initial stage do a lot of goods if you identify it correctly. And also, it's very important to order relevant investigations initially, and thereby you can guide. It will guide your management. And also, the proper monitoring is very, very important in detecting severe cases of leptospirosis. So it's actually your responsibility to arrange this monitoring and do this monitoring so that you will recognize, you will identify severe cases of leptospirosis, because severe cases are associated with high mortality. So at the same time, you have to look out for dangerous complications of leptospirosis. If you can if you can identify complications, dangerous complications early, you can intervene and reduce mortality. And also, as I told you before, you can initiate treatment, so that early treatment is important. And last but not least, the confirmation of the leptospirosis as the confirmation of leptospirosis needs a special investigation, that is microagglutinin test, which is a serum test done at MRI. So it's your duty to send those samples for confirmation to MRI. And also, it's very important to do the notification, because it's a notifiable disease. So going into a case scenario, this is a 14-year-old schoolboy admitted to teaching hospital Karapiti. with fever, arthralgia, myalgia of 3 days. And on examination, apart from being febrile and mildly tachycardic, he was otherwise well. And on investigation, apart from his low platelet count, which is 78,000, and high CRP, which is 56, the other investigations were essentially normal. Now this is a very common scenario where a young patient coming with acute febrile illness, and commonest other most important other common differential diagnosis is dengue, as you all know. Now, how are you going to differentiate this patient, whether it's having leptospirosis or dengue? So in history, so that's why his history is important. The history of exposure to muddy water or contaminated water, or not only water, it may be wet soil even, or working or walking in a rat-infested area can be taken as a positive exposure history of leptospirosis. So that is, looking for that bit of information in the history is quite important. And also, myalgia is a common feature for both dengue and leptospirosis, but in leptospirosis, the myalgia is mainly lower back, thighs, and calves. And in in dengue, it's more generalized myalgia. The headache is a common feature in dengue, but it's not very common, though it's not a dominant feature in leptospirosis. And investigations, if the very early rise of serum creatinine is a quite characteristic feature in leptospirosis, and also rise in CRP is a quite frequent finding in leptospirosis. Microscopic hematuria and proteinuria also favors the diagnosis of leptospirosis rather than dengue. So that's how you differentiate a common conditions like dengue from leptospirosis. Going back to the case scenario, now having seen this platelet count of 78,000 and CRP of 56, it was in more favor of leptospirosis, and going even though he was a schoolboy of 14-year-old, we didn't suspect any exposure history initially. But with this suspicion of leptospirosis, we went back and found back to the history and found that he had an exposure history. He had exposed to muddy water. He has, according to his father, this child has briefly stepped into the paddy field where father was working. So that was a very brief exposure. Even the boy could not remember, and even the father also could not remember at the initial stage when we were taking the history on admission. So investigation, following the further investigation further confirms our diagnosis of leptospirosis. His creatinine went up to 156 and CRP rose to 110. So our working diagnosis at that stage was suspected case of leptospirosis. So what is a suspected case of leptospirosis? Now, any patients who is coming with acute febrile illness with a history of high risk exposure to contaminated water, and together with two of the following features, such as myalgia, headache, arthralgia, meningism, anuria, oliguria, jaundice, or any of two plus acute febrile illness and history of exposure, positive exposure history, you can call it as a case of suspected leptospirosis. Why it is important to define a case as a suspected leptospirosis? Because the leptospirosis, as I told you before, is a clinical diagnosis. Initially, it's a clinical diagnosis because, as you know, confirmation takes time. But you can't wait until confirmation comes to start treatment, because early diagnosis and early treatment is important to prevent many of the complications of leptospirosis. So the importance of exposure history is an essential component of diagnosis, as I told you. And please don't just confine to yourself to asking about traditional modes of exposure, like working in the paddy field and blah, blah, blah. Now, you need to suspect every time when you come across a febrile lineage in Sri Lanka, and keep that in mind that anybody, virtually anyone can get infected with leptospirosis. So not only the high-risk groups, we have come across a lot of unsuspicious groups in the society being infected with leptospirosis. For example, a grade 8-year student came with severe leptospirosis. His exposure history was he has cleaned his school classroom with his friends. So that was one of the, and there was a temple cleaner who came with leptospirosis, but we could not find anything positive, but later on revealed that he has cleaned a shrine room which was infested with rats. And another case, a software engineer was working at, so usually he's an office-based person. His work is involved with mainly office in Colombo, but he has at home he has exposed to some sort of suspicious exposure has been there. So like that. So it's very important go into a little bit of detail of this bit of his part of the history, and that will do a lot of good to the patient. So coming back to the case scenario, 24 hours after the this patient's admission, he reduced his blood pressure to 150 ml per during 6 hours. His urine output was 150, and his blood pressure from 110 to 10/72, it reduced to 90/60, and his saturation dropped to 92. So at that time he was tachypneic, and we did the chest X-ray, and that time chest X-ray looks normal. But later on, the 40 hours after the admission, he dropped his saturation further from 91 to 75, and he needed the inotropes to maintain his blood pressure. 48 hours, 2 days after admission, that was on the 5th day of his illness, he started coughing out blood. His chest X-ray showed the bilateral changes, and also the blood gas at that time showed arterial hypoxia. So this was the X-ray which was done initially on admission or within 24 hours after admission. And this was the X-ray by the time he produced hemoptysis, which is showing bilateral small nodular shadows, which are mainly more on right side than left side. And these shadows are called alveolar shadows or cotton wool shadows. The radiologists call it cotton wool shadows. And these are very likely features of pulmonary hemorrhage. So the diagnosis we reached, taking all these into account, was leptospirosis complicated with pulmonary hemorrhage. So according to traditional complication of leptospirosis, as you know, the milder form of leptospirosis, the commonest form, where it consists of 90% of patients who are mainly having very mild symptoms, and they recover without any complications. And those are usually, those patients are usually anicteric. The severe form considered to be icteric, which is called Weir's syndrome with this classical triad. But now the trend is this anicteric and icteric leptospirosis are not very, not very useful, because we have, according to our experience, often the clinical diagnosis, the clinical features of leptospirosis depend on the organs that are involved. If it is renal, it's the patient, or it's only renal, if it will be renal dominant symptomatology. If it is hepatic involvement dominant, it may be hepatic, or it may be a combination, or it may be pulmonary, which is dominant, where patient can develop hemoptysis, tachypnea, and hemoglobin drop, and all these things would be a particular manifestations which are very much particular of that organ involvement, or if it may be a combination of all these, the renal, hepatic, and pulmonary. So it's very important to remember that patient with severe leptospirosis may or may not be icteric. So the one other important thing to remember is no system or organ in the body is immune to leptospirosis. Any organ virtually any organ can get affected. And however, the higher mortality is associated with when there is a pulmonary involvement, which is the recorded mortality rate for pulmonary hemorrhage is more than 70%. And also the mortality can be higher if it is associated with the renal and cardiac involvement. So it's very important to know something about pathophysiology of renal, cardiac, and pulmonary leptospirosis. So now at the same time, so it's very important to differentiate mild cases of leptospirosis from severe leptospirosis. As I told you before, the severe leptospirosis consists of 10% of cases and has associated with very high mortality. So what are the features of severe leptospirosis? If your patient is having reduced urine output, if the patient is having hyperkalemia, and if the patient is showing persistent hypotension, it's a sign of shock. If the patient remains in shock and needing inotrope to maintain his circulation, so those are the features of severe leptospirosis. It can happen in any organ, severe leptospirosis organ involvement. And if the patient is having tachypnea, evidence of arterial hypoxia, hemoptysis, chest X-ray infiltrate, and hemoglobin drop in the blood are the features of pulmonary involvement. So it's very important that it's your responsibility to monitor these patients and look out for these symptoms and some of these special investigation findings. So what are the important parameters to monitor to identify severe cases of leptospirosis as a house officer, what you can do in the ward? As I told you before, the pulse and blood sugar become very important because if you detect the evidence of shock, you know that it's a common finding in severe leptospirosis. If you monitor their respiratory rate, saturation, and if you detect that patient is having coughing out blood, if the patient is X-ray showing changes suggestive of hemorrhage, so that's a case of pulmonary hemorrhage you are dealing with. So you can monitor their urine output, you can do a serial UFR, you can do serum creatinine, you can do serial creatinine monitoring, and also electrolytes. And if you do this, it's easily you can diagnose acute kidney injury. And also ECG and troponin, if you can do cardiac enzymes and ECG, that will help you to diagnose myocarditis. So those are the important parameters that you need to remember to monitor in these patients. So what is the pathophysiology of acute kidney injury in these patients? These are mainly of two types. The acute tubular necrosis, which happens quite early in the disease of leptospirosis. That's why you get early rise in serum creatinine in leptospirosis. This can happen in the first day itself. So that if you do serum creatinine on the first day itself, you might see or the following day, definitely there will be a rise in serum creatinine that you can notice. This is due to direct toxic effect of the leptospira toxin to the tubules in the kidney. So leptospira can be found, you know this fact, leptospira can be found adhere to the epithelial surface of the renal tubules. So this is where the using antibiotics become very important. If you use antibiotic quite early in the disease, you can kill these bacteria and you can prevent this happening, and you can prevent or you can retard the establishment of acute kidney injury. The later on, again, the kidney can get affected by developing acute interstitial nephritis, which is an immune-mediated injury, which takes time, and usually it takes 1 or 2 weeks to develop immune-mediated acute interstitial nephritis to cause renal failure. As you all know, dehydration and rhabdomyolysis can also contribute to acute kidney injury. So myocarditis in lepto. How are you going to diagnose myocarditis? So the presence of leptomyocarditis is evident by ECG changes. This is very common, and you can you might find various ECG changes: AV conduction defect, ventricular reposition abnormalities, various arrhythmias such as atrial fibrillation are common findings in leptomyocarditis. The echocardiogram might show regional wall motion abnormalities, but the negative echo is not a exclusion criteria for to diagnose myocarditis. So elevated cardiac enzyme also will help to confirm the diagnosis of leptomyocarditis. But exact mechanism of cardiac involvement is not known. And coming back, moving to the pathophysiology of pulmonary hemorrhage, this is a normal, a cartoon of normal alveolus. And this is a more of a histological sort of diagram. The pathophysiology of pulmonary hemorrhage is there's a linear deposition of immunoglobulin and complement on the alveolar surface of the epithelium, which causes direct damage to alveolar capillary membrane. It's something like this: the linear deposition of complements over the alveolar surface of the epithelium, and which can directly affect the alveolar capillary membrane. As a result, the alveolar capillary membrane damage and bleeding occurs from capillary to alveoli. So that is the end result will be alveolar hemorrhage. This can be very severe. Pulmonary hemorrhage can be very severe. And one of the patients actually we managed at Karapitiya. He came with severe pulmonary hemorrhage and evidence of pulmonary hemorrhage. This is how his chest X-ray looked like. Bilateral extensive involvement of due to bleeding into lungs, and he was lucky to survive. And this is another patient who came with severe pulmonary hemorrhage, where he coughed out blood and he went into respiratory arrest. We had to intubate him in the ward, and this is what we found in the when we intubated. Actually, blood was coming through the ET tube into the ambu bag. So this was another patient who was not so lucky enough to survive, and he died of leptospiral pulmonary hemorrhage. And this is how the lung looked like when it was cut open at the postmortem. So it can be very severe. It is a very serious illness. It can be very severe, and it can cause life. The management of leptospirosis, the most important first step in the management of leptospirosis, identify dehydration and correct it. You can use normal saline, but remember, especially in the leptomyocarditis and in pulmonary hemorrhage, do not overload. So you inform your seniors and get their advice. But initially, you can start correcting dehydration. You can start rehydration, but remember not to overload them. Again, it's very important to monitor the essential parameters or vital parameters throughout the illness, course of the illness, and pulse, monitoring pulse, blood pressure, urine output, saturation are very important, regular monitoring. So starting antibiotics, you can take your own decision to start antibiotic if you're suspecting a patient with leptospirosis. And in mild case, if you think that your case, a patient have mild symptoms, you can start oral antibiotic, doxycycline 100 mg BD or azithromycin. And if you are dealing with a severe case of leptospirosis, they need IV antibiotics such as penicillin or ceftriaxone. Now, please, if you think that you are dealing with a severe case of leptospirosis, inform your senior and get their help and advice. The management of severe leptospirosis, again, I have to highlight that it is essential to continue close monitoring, because once you suspect a case of severe leptospirosis, that is not the end of the story. And still, you need to continue monitoring these parameters: urine output, saturation, looking for evidence of hemoptysis, serum creatinine, serum electrolytes, and doing blood counts to detect hemoglobin drop. So, and at the same time, if you come across a patient with severe acute kidney injury, you can do the other basic management of acute kidney injury, and failing that, if the patient's condition is deteriorating, you can go for hemodialysis. And in pulmonary hemorrhage, if you have this evidence of pulmonary hemorrhage, there you have few options. But the one important medication that is available to use treat this condition is IV methylprednisolone. It has some evidence to support this. It is effective in pulmonary hemorrhage, but the evidence is not that robust. But we have been using this methylprednisolone, but when the patients are in the acute critically ill and when they go to ICU setup, patient need very intensive care. This methylprednisolone can cause increased sepsis. So that is, you have to be very careful in using this methylprednisolone, and you have to use the maximum 1 gram daily, not more than 3 doses for each patient. So one of the most effective way of treating pulmonary hemorrhage is plasma exchange. The study we have done at Teaching Hospital Karapiti showed that it is quite effective. Now this modality, this treatment modality, plasma exchange, is being used widely around the country in many centers around the country, and it has saved many lives of patients with pulmonary hemorrhage. IV immunoglobulin is another option, but which is not really available, has been shown to be effective, but the evidence against supporting this use of IV immunoglobulin is not all that strong. Apart from that, as a house officer, you need to arrange blood transfusion and platelet transfusion for these patients, especially whenever it is indicated. And the most important thing is that as the patient's disease progresses, you have to make a confirmation your diagnosis, because it's very important to document these cases confirming the diagnosis. For that, you need to send serum samples at the end of 1 week of illness to MRI, so that you can get the confirmation by doing asking for microagglutination test for leptospirosis. And apart from that, it's your duty to notify this, do the notification of the diagnosis. Now, this is how you do therapeutic plasma exchange, and it's a simple machine that we use to do this plasma exchange. This machine is widely available in most of the blood banks in our country. So it's simple to operate this machine. One doctor and one nurse is enough to operate this machine. And this is the result we received. And this was the X-ray we started with. Actually, this is the same patient that I described in the case scenario, same patient. And this is his X-ray before starting plasma exchange. And this is what we saw after 3 plasma exchanges. So that shows very dramatic and very effective improvement of his condition. And also he made a very uneventful recovery following plasma exchange. So in summary, leptospirosis is a common cause of acute febrile illness, and exposure history is very important for early diagnosis. So you know the importance of making early diagnosis, because early diagnosis helps you to start treatment early, starting antibiotic early, and also if you start treating early and use antibiotic early, you can prevent complications. The important to identify severe cases is also highlighted, and you know what is the features. What are the features of a severe case of leptospirosis? How to diagnose? And it is very important that you continue close monitoring of essential parameters. And early treatment again is I want to highlight. And plasma exchange is an effective treatment of pulmonary hemorrhage. So that's all I have to tell you. And thank you very much for your patient listening. And Roshan, I am happy to answer any questions.
Yes, sir. Thank you very much. Sir, can you explain So can you explain prophylaxis depending on the situation?
Prophylaxis of? I couldn't hear you clearly, Prashant.
Sorry, sir. Can you explain the prophylaxis depending on the situation?
So is the question is not, I mean, it's not clear, but I think that the role of the prophylaxis is in leptospirosis. Actually, what we use as prophylaxis is doxycycline 100 milligram to 200 milligram weekly, given for high risk patients. And there are not much of strong evidence to support this, but it's the current practice, and it is being used in high risk groups, especially in farmers. Yes.
So I think that's all the questions. Thank you very much, sir, for that informative lecture. So next up is
Thank you.
so next up is approach to AKI by Dr. Batulan, physician. I think so. You're there.
Yes, I'm here. Can you hear me?
We can hear you, madam. Just yeah.
Yeah.
Just might have to do it full screen, madam. Yes, that will be okay.
Can you see my slides?
We can. Yes.
Yeah. Good morning, all. I'm Dr. Sujanita, Senior Lecturer and Consultant Physician from University Medical Unit Teaching Hospital, Jaffna. So for next 20 to 25 minutes, I will be talking about the general approach to acute kidney injury. I'm sure you all are well aware about acute kidney injury during your MBBS course. So this is just going to refresh your knowledge. Okay. So I will be talking about AKI under a brief introduction, the types of acute kidney injury, the clinical features in general, and investigations and management, again, a general management, and something about hyperkalemia, because as an intern, everybody should know how to manage hyperkalemia, and a few case scenarios. So this is going to be very brief. So talking about acute kidney injury, you all know this is defined as an abrupt deterioration in the renal function, which can occur over days or even over hours. Okay. Oliguria is often a feature, but remember, patients can have acute kidney injury even in the presence of normal urine output, where you call it as a non-oliguric AKI. Generally, the AKI is reversible, but in rare instances, it can progress to develop chronic kidney disease as well. AKI is very important because many medical emergencies can be associated with acute kidney injury, like hyperkalemia, metabolic acidosis, fluid overload, and so on. So as an intern, we all should be able to identify these emergencies and able to give the immediate treatment. So AKI, generally, some uncomplicated AKI have a very good prognosis, but sepsis-related or any other organ failure, especially the cardiac failure-related acute kidney injury, will have a high mortality. So before going into the types of acute kidney injury, let me talk a few things about what is this oliguria, anuria, and non-oliguria. We all know by definition, oliguria is defined as a daily urine output less than 400 ml per day. And of course, this has a worse prognosis, and commonly this is caused by some pre-renal causes or even a hepatorenal syndrome. Anuria is the urine output is almost absent or less than 100 ml per day, and is usually abrupt in onset. And if it is an abrupt in onset, always suspect an obstructive cause like a bilateral ureteric obstruction, or even it could be some catastrophic injury to both kidneys, like in rapidly proliferative glomerulonephritis or bilateral cortical necrosis. So anuria is quite dangerous, and again, it has a worse prognosis and it needs a timely management. Non-oliguria, where the urine output remains reasonable, above 400 milliliter per day, and it is often caused by some acute interstitial nephritis or ischemic acute tubular necrosis, or sometimes contrast-induced AKI or rhabdomyolysis-induced AKI. So remember, they can have complications, but the patient may not complain reduced urine output. So before going to the types of acute kidney injury, it is always good to know some classification system based on the severity of the AKI, where you use creatinine as well as the urine output. So there are two classification systems. One is called as rifle criteria, and the other one is called as a KDIGO classification. So as a house officer, you don't need to remember all these things, but it is always good, because when you pick up the AKI at the risk stage, where you have a marginal increase in the creatinine and the urine output is actually less than 0.5 ml per kilogram per hour for last 6 hours. So in a stepwise, the risk progress to injury and then failure. And if you don't intervene, you may lose the functioning nephrons, and it may result in end-stage renal disease. So this is one of the classification you use for AKI. And the other one is KDIGO, where you use it's called as a kidney disease improving global outcome classification. Again, the same parameters are used, like serum creatinine and the urine output, and the severity is graded in as 1, 2, 3. And it is actually assessing how severe the AKI and how quickly you need to attend to the cases. So the types of acute kidney injury is very simple. We all are aware about these causes. The pre-renal acute kidney injury. The next one is the intrinsic AKI and the post-renal AKI. It is easy to remember. Usually the history and the examination will help to differentiate whether patient is having a pre-renal AKI or likely an intrinsic or a renal type of AKI or a post-renal, where mainly the obstruction causes the AKI. So we will go through one by one, just an overview. So before going through that, the causes of AKI under these categories like pre-renal and renal and post-renal, those are very common. The pre-renal, we all are aware, whatever the causes which will result in hypovolemia can cause pre-renal failure. Likewise, the organ failure with the hypoperfusion of the kidneys also can cause pre-renal type of AKI, mainly the heart failure and the liver failure. The renal causes are mainly either it could be glomerular pathology, tubular pathology, or interstitial pathology, and so on. So rapidly proliferative glomerulonephritis is one of the common and the dangerous cause. And then acute tubular necrosis and the interstitial nephritis are the common causes. Post-renal is due to any obstruction or any neurological dysfunction. So obstruction can be caused by any calculi, prostatic enlargement, or strictures or stenosis, and any spinal cord diseases with the sphincter disturbance can result in neurological bladder as well. So talking about the pre-renal acute kidney injury, as I discussed earlier, it is either due to a change in the intrarenal vasomotor level or either changes in the general circulation, which will ultimately lead to a reduction in the glomerular filtration rate and acute kidney injury. So remember here, the main problem is in the circulation, and the nephrons or glomerulars are usually structurally normal. Okay. And it is the most common form of AKI and is usually a preventable cause as well. But if you don't treat it timely, it could lead to intrinsic acute kidney injury because of the resultant acute tubular necrosis. So it is very important as a house officer to identify the AKI and identify whether it is as pre-renal, and then you need to treat the underlying cause appropriately so that the acute kidney injury can be treated. So the causes in general, we went through the causes of hypovolemia. So any condition which could result in volume depletion can cause pre-renal failure. So as you all know, it could be either from GI tract or the renal loss, or it could be from the skin like burns and other skin diseases. It could be some blood loss, either external or internal blood loss, or even a third space loss as in pancreatitis. So remember, all these conditions can complicate with acute kidney injury. Then the other common cause is a decreased cardiac output, mainly because of the heart failure or pulmonary embolism or acute myocardial infarction, where it could complicate with the cardiogenic shock, and then the renal perfusion can be very much reduced. And then the other conditions like sepsis and anaphylaxis, where it is complicated with the shock, can cause AKI and so on. So how do you treat the pre-renal AKI in a nutshell? Always treat the underlying cause. So if you think the cause is due to the cardiac failure, treat the heart failure appropriately. That is very important. Fluid resuscitation is very important when there is a hypovolemia. So if the patient is having either diarrhea or vomiting, make sure that you replace the fluid loss by giving the appropriate fluid. So usually we generally treat with the crystalloids. So either you can give normal saline. But in AKI associated with other organ failure, make sure that you need to give a very careful fluid resuscitation, because it can further exacerbate the underlying organ failure. If you are not sure about the fluid status, very difficult to assess clinically, you may give a small amount of fluid challenge, like 250 ml of fluid, and see whether the patient is fluid responsive. Make sure that you keep on monitoring the blood pressure, because as I said, hypotension is very common, and the heart rate and the urine output, to see whether patient is improving from the pre-renal AKI. So before going through the intrinsic type of AKI, I will talk few words about the post-renal AKI. As we discussed, it is due to the obstruction. The obstruction can occur from the renal calyces to external urethral orifice. So anything in between can cause obstruction. So common ones we have discussed. And if you suspect there is an obstruction causing acute kidney injury, always do a detailed examination. Sometimes you can feel the bladder. Sometimes you may be able to get a palatable kidneys because of the bilateral hydronephrosis. But if you are not sure about the examination, always perform an ultrasound of kidney, ureter, and the bladder to exclude or look for any causes of obstruction, as well as to confirm the obstruction. Because the moment you find the obstruction, the treatment is just to relieve the obstruction by getting the appropriate specialty. Okay. So now moving on to the intrinsic acute kidney injury, it is somewhat different from the other two types, because in pre-renal, you have a structurally normal nephrons, and mainly because of the hypovolemia. Post-renal, you have obstruction. But in renal parenchymal AKI, here you have some structural and functional damage to the nephrons. The common variant is the acute tubular necrosis, which can occur due to either ischemic changes, cytotoxic changes, or inflammatory insults to the kidney. Okay, and remember, as I said earlier, if any cause of pre-renal AKI is prolonged, it could lead to ischemic ATN. Always remember that. So the causes of intrinsic AKI, there are several causes. It could be due to vascular abnormalities like renal artery occlusion, renal vein occlusion, some microangiopathic conditions like hemolytic uremic syndrome or thrombotic thrombocytopenic purpura or DIC, malignant hypertension, and so on. So these causes can result in intrinsic type of acute kidney injury. Glomerular causes, I think you all are well aware about the common glomerulonephritis, which are either immune complex mediated, or it could be ANCA-associated vasculitis, or Goodpasture syndrome like anti-GBM disease. So these are very important, though they are rare, but they are very important because they need specific treatment. Tubular causes are generally due to drugs, or sometimes heme pigments in rhabdomyolysis could be due to crystal deposits like in tumor-lysis syndrome. Interstitial, again, it is commonly due to some medications or infections or some systemic diseases. So that is about the classification as pre-renal and renal and post-renal. So it is very difficult to go through one by one. So in general, I will go through what are the common clinical features and the investigations. So as we discussed, they generally have low urine output, but mindful, they can have a reasonably good urine output as well. Some patients can have hematuria and proteinuria, mainly patients who are having glomerulonephritis, or hematuria can occur in obstructive causes as well. Carefully, as a house officer, you need to assess the volume status. You need to identify whether the patient is having dehydration or fluid overload. Dehydration, you can assess from the history and the examination showing dry skin, dry mucosa, tachycardia, and hypotension. As opposed to the dehydration, fluid overload can occur as a complication of AKI, or it could be due to the underlying heart failure or other organ failure. Again, you need to assess the lung basis, elevated JVP, or generalized edema. So you need to carefully do this examination to find out the fluid status, because it matters a lot in your management. So patients can have hypertension, mainly in intrinsic type of AKI where they have the glomerulonephritis. Some patients, when the AKI is very severe, they can have uremic features like pruritus, nausea, vomiting, confusion, seizures, or coma. And always look for a cause of AKI from your history and the examination. So whatever we have discussed under pre-renal, renal, and post-renal, you need to get a careful history. So arranging appropriate investigations is very essential. First of all, to confirm your acute kidney injury, where you need the renal functions. So you need to ask for an urgent urea, blood urea, serum creatinine, as well as the electrolytes. And make sure you keep on repeating the renal function test until you see the clinical improvement, at least daily. But if there is significant electrolyte imbalance, you may have to ask for electrolytes quite frequently. ABG is very helpful because most of the patients will have metabolic acidosis, and also you may be able to pick up hyperkalemia very early before you get the laboratory result, because if hyperkalemia is very severe, you have to treat immediately. Urine full report is helpful again in infections like pyelonephritis, glomerulonephritis, where you will have red cells, red cell cast, and the proteinuria as active sediments. UPCR is again one of the important investigation for your glomerulonephritis. Inflammatory markers are helpful for infections, as well as when you are suspecting any vasculitis like SLE and other ANCA-associated vasculitis. You need to ask for an ECG, mainly to look for any hyperkalemic changes. Hope you all know what are the hyperkalemic changes you see in the ECG. Chest X-ray, pulmonary edema you can pick up, but remember the pulmonary edema is a clinical diagnosis. You don't need even chest X-ray, but you can see the changes. And also some other renal pulmonary syndromes can have localized infiltrates like ANCA-associated vasculitis. You may be able to see some localized infiltrates or even hemorrhages. Urine electrolytes and the osmolality will be helpful sometimes to differentiate pre-renal and the renal failure. Blood and urine cultures, again, when you are suspecting infection as the cause. So these investigations, as a house officer, you should be able to request on your own. You don't need anybody to instruct. If you are suspecting AKI, make sure that you ask these basic investigations as an urgent basis. Now, there are some specific tests to identify the causes of AKI. So renal ultrasound is very useful when you suspect any obstruction. And also it is very useful when you suspect any pyelonephritis, where you may see some changes with some complications. But generally in acute kidney injury, you may see a swollen kidney. So that is the advantage of having the renal ultrasound. Sometimes you may be able to see a background chronic kidney disease changes also, because often the CKD patients can come with an acute or chronic kidney disease. Blood picture in selected cases like TTP or HOS or DIC, where you suspect microangiopathic hemolytic anemia, you will request the blood picture. If you suspect multiple myeloma as a cause for AKI, you can ask appropriate serum protein electrophoresis and the immunoglobulins. If you suspect rhabdomyolysis due to any cause, you can ask for serum creatine phosphokinase. Autoimmune screening, especially when you suspect SLE or ANCA-associated vasculitis, as for ANA, ANCA or anti-GBM antibodies when you suspect Goodpasture syndrome. HIV, hepatitis serology, and renal biopsy all are important when the patient is suspected to have glomerulonephritis. Now, a few words about this renal biopsy, because as a house officer, you all should know how to prepare a patient for renal biopsy and also how to care a patient following a renal biopsy. Of course, the indication, I think you can brush up your knowledge. So it's usually, it's very helpful in identifying the intrarenal causes, mainly the glomerulonephritis. So before the procedure, because when the patient gets admitted, it is your duty to make sure that you get a full blood count and a PT-INR done, just to make sure that the patient is not having any bleeding risk. You need to make sure you send a blood grouping and cross-match in case if you need to transfuse because of the bleeding. Make sure you exclude the contraindication, and also you have to get an informed written consent. Mindful, the informed written consent is not just getting a signature. You need to explain the patient why you are performing this renal biopsy, what is the indication, who will be performing the renal biopsy, either radiologist or the nephrologist, and what is the likely complication patient can have, and what are the post-procedure observations that patient has to undergo. And also, if the patient is not willing for the renal biopsy, what are the other alternatives? So you need to explain all to the renal biopsy for patient with renal biopsy, and then get the written consent. So this is one of your duty as a house officer. And the procedure, as I said, will be done as an ultrasound guided one by the nephrologist or the radiologist. But following the procedure, patient will be under your care again. So you have to make sure the patient is in rest at least for minimum of 8 hours. Patient has to take enough fluid, because there could be microscopic hematuria or even a clinically evident hematuria where patient could develop clot colic. So you have to make sure that the patient takes enough fluid. You need to keep on monitoring the pulse and the blood pressure to observe for any evidence of complications. And you need to advise the patient to avoid any heavy work at least for 2 weeks. So this is something I wanted to tell you as a house officer, how you care a patient for renal biopsy. So moving on to the management of AKI. So it is going to be a general management, nothing specific to a particular type. So as a house officer, you need to monitor the fluid balance, how much they take and how much of urine output daily, how much the daily weight, the blood pressure, and so on. So these are essential that you monitor the patient. And make sure you withhold the nephrotoxic medication that you can do as a house officer, because most of our patients could be on analgesics, like especially NSAID, which you need to stop. Patient could be on AC inhibitors or ARB. Patient could be on metformin. So all these medications you need to stop temporarily. And if you identify that the patient is hypovolemic, you have to hydrate the patient adequately. And sometimes patient may need vasopressors also if they are not responding to IV fluid treatment. You have given adequate treatment, still they are not responding, you consider vasopressors. But of course, that is with your senior opinion. If the patient is identified as fluid overloaded, you need to restrict the fluid. You need to identify hyperkalemia and treat it. I think we will discuss that later. If there is acidosis, you can treat with IV sodium bicarbonate. Fluid overload with the pulmonary edema can be treated with furosemide, either bolus or if necessary infusion. If the patient is not responding for your furosemide treatment, patient will be considered for dialysis. Infections needs to be treated appropriately, mainly pyelonephritis or leptospirosis. You need to identify based on your history, examination and investigation and start on appropriate antibiotic. You need to restrict the sodium and the potassium mainly. And the hemodialysis, of course, this will be decided by the treating team with you all. And you all know what are the indications for hemodialysis. Generally, symptomatic uremia, either uremic pericarditis, uremic encephalopathy, or other symptoms. Hyperkalemia, where it is not responding to the medical treatment, you need to consider hemodialysis. Pulmonary edema, again, if patient is not responding to medical treatment, you have to go with dialysis. Severe acidosis, and in some cases, not because of AKI, but for removal of the drugs which are causing the AKI, you can perform dialysis. So it will be decided by the physician or the nephrologist which mode of hemodialysis we are going to provide. Either it is an intermittent hemodialysis or hemofiltration, or continuous renal replacement therapy, or very rarely PD. PD, of course, peritoneal dialysis, we don't perform much, but some in case where you don't have any facilities, as an interim measure you can consider. Of course, these will be decided by as a team. So you need to get the urologist help when you suspect any obstructive pose. You need to get an early nephrologist input in cases where you are mainly suspecting a renal type of acute kidney injury. And rapidly proliferative glomerulonephritis, of course, will be treated by the seniors, but it is our task to identify this as an RPGN, and it will be treated with the pulse therapy, either with methylprednisolone or cyclophosphamide or sometimes biological agents. Now, as a house officer, there is always a tendency, if you see in the medical wards, if you see a patient with reduced urine output, they always give furosemide, but don't practice that. You can give furosemide when you are suspecting AKI with the fluid overload only. It will be very dangerous if you give furosemide in a patient who is having pre-renal AKI due to a hypovolemia. It would make all these AKI more and more worse. Okay, so remember that furosemide is not the treatment for any case of reduced urine output. So when the patients are appropriately managed, they will go into a recovery phase, which will take roughly around 1 to 3 weeks, and renal functions will improve slowly. And also you would see the urine output may increase and it may go into a polyuric phase with the large volume diuresis. Okay, this is very general when the ATN, because the pre-renal type or the pre-renal type leading to ATN, when it recovers, you may get a large volume diuresis. At that point, patient may have to take more fluid, and if necessary, you have to give IV fluids as well. But generally, it lasts for a few days and patient recovers very well. So the prognosis mainly depends on the cause of the injury and also presence and absence of the pre-existing kidney disease and the timing of your therapeutic intervention from the time of renal dysfunction. That is very important. That is why we went through all these courses, because you need to timely start the treatment to have a better outcome. So remember that as a house officer, if you identify acute kidney injury early, then always the prognosis is good. So few things about hyperkalemia. As I said, Hyperkalemia needs to be identified by you all, and it should be treated by you all without any help. Okay, so you will have your laboratory blood reports, and also you will have the ECG, and you have to look for any changes in the ECG. So what you have to do, immediately you need to stop all the potassium containing medications like AC inhibitors or ARB or spironolactone and so on, and reduce the potassium containing food. And if the ECG is showing hyperkalemic changes or potassium is very high, above 6.4, always you need to give calcium gluconate to stabilize the cardiac muscles. These dosages you should remember by heart. Okay, so calcium gluconate is 10%, 10 ml, and it is given over 5 minutes, and you can repeat it until your ECG changes disappear. Remember, this will not reduce the potassium level. So how you can reduce the potassium level? You can give the insulin dextrose infusion. Again, you should know, you give 50%, 50 ml dextrose with 10 units of soluble insulin over 10 to 15 minutes, and you can repeat it as needed. And also mindful about the blood glucose. Patients with diabetes may have a problem with the diabetic control, so you need to closely monitor the blood glucose. You can again reduce it by giving salbutamol nebulization. Here the dose is different from the bronchial asthma treatment. So here you have to give a large dose of 10 milligram and you can nebulize the patient. Sodium bicarbonate may be useful when it is associated with acidosis. And also if there is fluid overload, you treat with furosemide. If the hyperkalemia is refractory to all the above management and it is very high, you may have to go ahead with the dialysis as we discussed. Okay. If it is a persistent hyperkalemia, you may consider some oral potassium binders like calcium resonium resins, but remember it will not reduce the potassium immediately. Of course, treat the underlying cause appropriately. So this management of hyperkalemia, you all should know because it is very essential. If you don't treat it, patient may go into a complete asystole with a cardiac arrest. So you have to be very careful. So few words about acute on chronic kidney disease, because this is very common. Patient may come as an acute kidney injury. How to suspect whether there is an underlying chronic kidney disease? Again, based on your history, the duration of symptoms. If you have a previous renal function test, that will indicate there is already a chronic kidney disease. And from that available renal function, if there is a rapid change in creatinine or GFR over days or weeks, always suspect acute kidney injury, and always look for the causes of acute kidney injury on the background of chronic kidney disease. So you can do an ultrasound KUB again to look for any chronic kidney disease changes. You can look for anemia of chronic disease or features of renal osteodystrophy or hyperparathyroidism to give more evidence for underlying chronic kidney disease. But remember, acute on chronic kidney disease also needs to be treated vigorously, because most of the time the cause of the acute deterioration could be reversible. I think that's all about my presentation. I will take you all through 3 cases based on what we have discussed. It is very easy. I'm not testing your knowledge. It is just to remember the important 3 courses we have gone through: pre-renal and renal and post-renal AKI. So here we have a patient, 50-year-old male with diarrhea and vomiting of 2 days duration with oliguria of 12 hours duration. On admission, patient is drowsy, tachycardic and hypotensive, and your initial investigation shows blood urea is high, creatinine is high, and sodium and potassium are in the lower side. So how will you manage this patient? So obviously we could conclude this one as a pre-renal type of AKI with some electrolyte imbalance because of the GI loss. So here you need to treat with adequate hydration with the correction of the electrolytes. Okay, so that is the summary. Of course, you know what to do. You have to assess carefully for the volume status, you need to ask for some other investigations, and you need to manage mainly with the fluid treatment. So the second case is a 65-year-old male with preceding symptoms of bladder outflow obstruction features, present with anuria of 18 hours duration, blood pressure 150/90, lungs are clear, and there is suprapubic tenderness and swelling noted, blood urea 20 and creatinine 430. So it's very straightforward. You have a palpable bladder, you have to suspect there could be an obstruction, and you need to relieve that obstruction. Okay, so that is very straightforward. So you, as a house officer, you can do that on your own by doing a simple urinary catheterization, because here the bladder is palpable. The last one is a 25-year-old female, a non-patient with SLE with predominant dermatological manifestation on hydroxychloroquine, presented with reduced urine output, hematuria, and shortness of breath. On admission, she has a malar rash, pulse is 96, and blood pressure 150/100, and there are basal crepitations. So how will you assess her initially and manage? Of course, for this patient, you have to take a detailed history to look for other features of active SLE and other complications. You have to do a detailed examination, and you have to do early investigations to look for all the renal derangement as well as any other complications for SLE. The management, of course, is a combined decision. So your seniors and the physicians and other rheumatologists will be helpful to decide on the treatment. But as a house officer, at least you should be able to pick up, now this could be a likely lupus nephritis, and you need to act early. You need to have your investigations early. Patients should be monitored very carefully. So all those things as a house officer, you need to do. So in summary, as an intern, you should be able to recognize acute kidney injury from a detailed history and examination. And also you should be able to request appropriate investigations to confirm acute kidney injury and its causes, and make sure you institute prompt early therapeutic intervention to have a better outcome if necessary with the help of the seniors. Okay, so this is all about the acute kidney injury. Of course, this is a vast topic with some individual syndromes and other diseases, but at least at your, as a house officer, if you know all these basic, I think you all can make sure that the patients are safe and they are correctly managed for acute kidney injury. Thank you.
Right. Thank you, madam. We can take one question. Do we start treatment for hyperkalemia?
Roshan, it's not clear for me. Can you repeat it, please?
Okay, madam. If potassium less than 6.4,
yes,
don't we need to start treatment for hyperkalemia?
Of course, you need to start on treatment for hyperkalemia. What I said is about giving calcium gluconate. So calcium gluconate, if there are ECG changes, you will give, and usually if this potassium is very high, you will give. But the other modality of treatment will still apply. You stop the potassium containing drugs. You can give the insulin dextrose infusion, salbutamol nebulization, all you will continue to give.
Like last question, madam, in brief, how to correct oliguria in a heart failure patient with normal MAP?
Okay, so that is so that is a very difficult scenario we would encounter, a patient having oliguria with heart failure. So here you need to assess the volume status. Of course, most of the time they will be having a fluid overload stage with the wet lungs. So your fluid, you cannot give much fluids in this condition. So you need to adequately treat the underlying heart failure, which will automatically correct the acute kidney injury. So the fluid balance is very important. You have to have a strict input and output, urine output daily. And also here you have to use carefully diuretics to treat the underlying heart failure. But remember, it would be a difficult scenario with the fluid balance. But if you treat the heart failure carefully, most of the time the acute kidney injury could be treated.
Right. I think that's all the questions, madam, with the time. Thank you. That's Dr. Sujinta, Senior Lecturer, Jaffna. Thank you very much, madam. Right. Next up is a very crucial lecture by Dr. Nanda Dikmadugoda, consultant physician at CSTH Kalubowila. Important topic is acute headache. Over to you, sir.
Hi, can you hear me?
Yes, sir, loud and clear. Yes.
Hello. Can you hear? Can you see my slide?
Can hear, sir. Can hear. So need to share the screen. Yes.
Okay. That's all right, no?
Yeah.
Yeah. Okay. So good afternoon now. Naughty, maybe you are having headache also now.
Yes.
So I hope you will not get headache when I finish my lecture also. It's not actually lecture, right? Right. So hope, yeah. So first of all, I must thank Sri Lanka College of Internal Medicine. I welcome all of you to the medical department. If you happen to do the internal medicine, you will be a consultant in internal medicine, where we do the holistic approach for the patient. Kayika Vaidya Roga Vidya Vaidyavarunge Vidyayatana. That is Sri Lanka College of Internal Medicine. Thanks to the SLSIM. Right. So before starting my proper thing, there are a few general rules in medicine training. If you come to the medical ward for 6 months appointment, not only for the medical appointment, even anything in your life, if you know why you are doing it, it's very easy, right? So why you are trained? You have finished your MBBS, long course, now you are going for the internship. So you finish the MBBS and come out as a senior house officer in medicine. So that is the aim. So then if you know what your boss wants from you, it's easy. There are certain do's. That means there are some routine works you have to do, like clerking the patient, monitoring the patient, looking after the logistic things in the ward. Maybe you have listened to the previous lecture, you have to do certain things by yourself, which may not be the medicine, but say some other logistic things. Then there are few things you should not do in a medical appointment, which we call don'ts. The most important thing a boss wants from... Hello.
Sorry, sorry to interrupt. So do you have a PowerPoint presentation?
Yes, PowerPoint, yeah.
So we can't see it, sir.
So you are not...
might have to share it, sir.
Sorry. I'm sharing, no? You are not getting the slides?
Not yet, sir.
Can you hold on?
Sure.
So I am yeah.
Headache.
Yeah, still no headache, no? Are you getting this thing?
Yes, sir, not yet. Share screen sir, මොකද්ද laptop එක මේ I Mac එකද sir?
No, it's
normal
normal this Aspire one. So you are not getting the
no sir.
So do I get the slide sharing option?
slide එක open කරලා ඊට පස්සේ share එකට යන්න.
Now it is open in my computer. Yeah. So where can I get the slide sharing option? It was there in the. I'm a technology moron, right?
That is somewhat difficult to, yeah, but it's not coming.
Do you get it?
No. I think it's coming. Should come.
I stop the video.
share screen කියලා තියෙන sir. ඒකට press. Okay. Right. Now it's coming, sir. Yes. Oh, let's see. So it's now it's okay, sir. Yeah, my time to make it full screen.
All right. Okay. I get it now.
Yes. All right. Okay, sir.
So, no? Right.
Yeah.
Sorry. Right. So I was telling there are few things you should not do in the medical ward when you are doing the internship. The most important thing, not to kill a patient. So the doctors are not killing the patient. Yeah. How can you kill a patient as a house officer? So if you do a drastic mistake, a patient need a urgent management, and if you miss it within few hours, patient can die. So most of the time as a house officer, you are alone, especially in the middle of the night. So you should take urgent decisions, take necessary management steps, and prevent patient dying. So how can you escape killing a patient? That is the best thing, is to know the acute medical emergencies properly. So in a given time, there will be only about 3 to 4 patients, very sick patients in the ward. Others will not be very sick. So if you attend to those 3 or 4 patients in the medical ward, that is actually more than enough. That is what I want from my house officers. You have to do everything in and out for those very sick patients. Other patients anyway will recover. Right. So for the next 25 to 30 minutes, I was given the topic acute headache. So I'm going to discuss what is acute headache, then what is chronic headache. If there's acute headache, there should be a chronic headache also. Then there are different types. You know, there are different classifications, different types of headache, because all the headaches are not similar. Then there are myths or misconceptions. Even among the medical community, there are so many myths and misconceptions. So we'll discuss that also. Then how to approach a patient with acute headache. That means if you do the proper approach, you can escape from your boss. Otherwise, you will be penalized, right? So there are a few interesting cases also. I just want to show you a few, right? So what is acute headache? The pain or discomfort in the head and neck area. So not only the head. So that may start suddenly and get worse quickly. That is what we call acute headache. The headache is a very common problem in the medical wards. So if you get acute headache, this is what we call acute headache. There's a term called thunderclap headache. What is thunderclap headache? So that is when you get a headache, we can measure, right? So in other blood pressure, you can measure with the mercury millimeters. But headache, there is no meter to measure the headache. So we usually say scale 0 to 10. 0 is no headache. 10 is the maximum headache a person can have. So in between that range, you can have, so if you ask the patient, patient will say, I have about grade 5 or 7, 6, like that. So what they say is onset 0 to 7, less than 1 minute. Patient comes and say, suddenly I got a severe headache, less than 1 minute, I got the severe headache. This acute headache can last even 4 to 72 hours. Sometimes they say, this was the worst headache in my life. If you ask all the participants, everybody has got a headache. But some will say, this was the worst headache in my life. So that is also significant in acute headache. Right. So then what is the chronic headache? Chronic headache is any type of headache that occur very frequently. For the definition purposes, they say it's generally at least happening 15 days per month. That means half of the month you have the headache. Then it lasts for a period of 6 months or more. So this is called chronic headache. And most of the time, remember, most of the time, chronic headache is benign. That means there can be serious conditions as well, even in chronic headache group. So what are the types? So there are different classifications and subcategorization of this thing. If you know this thing, the primary headaches and secondary headache, that is more than enough. What is primary headache? Primary headache is there's a headache, but there is no demonstrable pathology. Fortunately, it is most of the time it is benign, nearly 54%. That means majority of the patients will have primary headaches. So if you think of the main categories, there are this tension headache, migraine, and cluster headache. Those three groups come under primary headache. That means we can't find a demonstrable pathology. So the tension headaches are the most common one. Maybe you think migraine is the most common one. No, migraine is the second most commonest. Then the cluster headache. So those are actually the chronic headaches, and it is we are not going to discuss it here. Then the secondary headache, that means the patient has the headache, they have a demonstrable pathology. It's the minority, nearly 42%. Now, this is what you want to know when you work as a house officer. If you know whether it is a primary headache or secondary headache, that's more than enough. Now, if you are going to study this more deeper or in neurology, there are different classifications. There's something called International Headache Society. It's really a headache because they have categorized this into, if you go to this classification, there are about more than 300 subtypes. So don't worry about this. It's a real headache, but you should know there are different types of headache, large number of headaches. The most important thing you to know whether this is a benign or a serious condition. If you can differentiate that, that is what we want to do in your medical training. Right. So with the onset, like the headache, some patients get headache. So if it is acute severe headache, what are the categories? If you know these conditions, then you can think patient coming with acute severe headache. So maybe one of these things. One is subarachnoid hemorrhage. Then the pituitary apoplexy, dissection of carotid, meningitis, and carbon monoxide poisoning. Now these headaches, they come with sudden severe headaches. And if you miss that, that is also a big issue, right? So you should know these are the main group. There are some other small categories, but this is the most important thing. So you remember them. Then there are this new onset persistent headaches. Patient will come and say, I got this thing recently, about 2-3 days back or 1 week back, but it is persistent. So what are they? One is giant cell arteritis, then the venous sinus thrombosis, idiopathic intracranial hypertension, spontaneous CSF leakage, again meningitis can present as the acute one as well as new onset persistent headache. Then the brain abscesses, brain tumor, then the hemorrhages, subdural hemorrhage or extradural hemorrhage. All these are also very significant ones you can't miss. So new onset persistent headaches also, you should know the etiology. Then the chronic headaches come, migraine and what we call the cluster headache, tension headaches, like other primary headaches. Then what are the myths and misconceptions? These myths are there even among the patients as well as among the doctors also. First one is the severe headache, always a serious pathology. Is it correct? No. You can have a severe headache, but may not be a serious pathology. As example, migraine patient, sometimes sometimes tension headache patient, they try to commit suicide because it is a very severe headache, but it is not, serious pathology. Even if you miss it, the only thing is the patient will suffer, but patient will not have further sequel. Then the acute headache. If the headache comes suddenly, you think it is a serious pathology? No. Sometimes there can be sudden headaches. They are not very serious. Like subarachnoid hemorrhage, it is a serious condition. It comes thunderclap headache. But you can have these cerebral vascular spasmodic conditions. They come with sudden headache, but they are not serious. Then the opposite of that, the gradual onset headache. Patient comes and say, I had the headache for a few months. Then your attention goes away. You think, no, don't worry. This is a small benign condition. No, that is also wrong. So it is again a myth. So there can be serious conditions with gradual onset headache. Then the patient comes with the headache and he goes to the doctor and get the treatment, and there is a good response. Patient comes and say, I have good response to the treatment. So is it good or benign? No, still there can be serious condition underlying, right? So remember. Then, all of the patients, if they get headache, their first request is, Dr. Mata, scan ekak karaganna bari weyda. They will ask for a CT scan. So that also you have to decide who needs CT scans, not each and every patient with headache. But with the commercialization of this medicine, everybody goes in the private sector, everybody tends to do the CT scans. CT scan normal, don't do. That is again wrong. There can be serious conditions with the normal CT brain. So remember that also. As a rule, in medicine, nothing is always. There can be exceptions. Right. So those are the myths and misconceptions. When you manage the patient, remember those. Right. So how do we approach a patient? Now, all this we know the etiologies, we know the myths and misconceptions, not to miss it. Then how, if you get a patient with acute headache, how to approach? 1, 2, 3 is history, examination, and investigation. Like that, the gold standard, your best way to manage the patient is history, examination, investigation. So as a house officer, what are the things you are going in the history? What are the things you are going in the examination? What are the things you do in the investigation? That is what we want to discuss. So the idea of this history, examination, and investigation is to diagnose the patient, what is the condition, then relieve the patient of the headache, and last thing, not to miss a serious condition. First, relieve the pain. Then only you can take the history. Because if the patient is in severe headache, he will not give a proper history. In the history, you are going to ask the symptoms and the clues. Now, if you know what are the conditions possible, then you look for those conditions in the history. Ask the patient specific questions, direct questions, and go for the symptoms and clues. So what are the important symptoms? What we call sinister symptoms. Patient might come and say, I had the early morning headache, vomiting, or some kind of a focal neurological sign. That means the weakness of one side, sensory impairment on one side, or dysarthria. Sometimes the patient might not tell. Sometimes the relations come and say he had a headache and he had some behavioral changes. So those are we call sinister symptoms. The sinister word means in Latin left-handed. So the left-handed people, the sinisters, right? The opposite is the dexter, and but it from the Latin it turns into English evil. So the evil features. If the patient has headache and those sinister symptoms, we expect some bad thing will happen. If you are interested, you can see the film, the sinister film, the horror film. That is also showing the evil, the things which can happen in a bad way. Then you ask from the patient onset, how did you get it? Whether it is a thunderclap headache, sudden headache, or gradual onset. All these features will tell you something about the diagnosis. Then you have to ask the prior headache history, whether it is a chronic headache or acute headache. So the prior headache history is important. Then the history, the site. You know, the site of the headache may be unilateral. As an example, in the migraine, sometimes you get the unilateral headache, but it can be bilateral also. If you get a headache in the occipital area, that is bit significant, because usually it's said to be some due to the intracranial pressure increase, occipital headache. And you can get the frontal headache. Sometimes the sinusitis or tension headaches, you can get the frontal headache. So the site is important. Then you ask the patient, when do you get this headache? Develop with exertion or sexual intercourse or with valsalva. These are also important. If you get the headache with the exertion, could be migraine, not in the tension headache. With the valsalva maneuver, that indicates you have increased intracranial pressure. There are headaches, sometimes you get with the sexual intercourse, not before the sexual intercourse. Most of the girls get the headache before sexual intercourse, but this is not that. While having the sexual intercourse, some patients get the headache. Then the quality of the headache. So you have to ask what type of headache. You are getting band-like headache, pressing, or sometimes say if it is trigeminal neuralgia, you get pinching like electric like current going like in the head. So those are neurological origin. So quality of the headache is important. Then you ask for the associated features. When you get the headache, what else do you get? Did you have fever? Did you have neck stiffness? Like and then the loss of weight, like generalized symptoms, associated symptoms of this. Now we ask the patient about the history of previous headache. Same time you have to ask the previous medical history, because it is very important. Say if this patient's headache, if the patient is having a cancer or history of AIDS, HIV, then you are thinking of kind of an immunosuppressive state. So they can have the infections related to the immunosuppressive states and causing lesions in the brain, causing the headache. So that is the things more important in the history taking. Right. So in the examination, what are you going to do? Again, you have to relieve the pain. Then only you examine the patient. Look for focal neurological signs, including behavioral changes. So in a patient coming to the medical ward with a headache, your examination part, first thing, you do the general examination, then you have to do a full CNS examination. So what are the CNS examination component? As a house officer, you have to chart in the BHT, the conscious level, then the motor system, sensory system, cerebellar system, and the level of consciousness, right? So those parts you have to document, full CNS examination. In that, you are going to look for any focal neurological sign. What are the focal neurological signs? Maybe one side weakness, one side numbness, or even cerebellar signs. Those are important, right? So then you have to look for the eye. Eye, you look for, say, if the patient has Horner syndrome, that may be a sign of a dissection of internal carotid artery. You know the Horner syndrome. Horner syndrome is getting everything low. That is small pupil, ptosis of the eyelid, and you get the sweating, right? So it could be a sign of a dissection of internal carotid artery. Then when you do the cranial nerves, the third cranial nerve palsy can be there. So third cranial nerve is significant. It may be indicating aneurysm of the posterior communicating artery. Then you look for papilledema. Nowadays, the medical students and doctors, they don't practice papilledema because of this COVID, because you have to go very close to the patient. So earlier, we were asked to do the papilledema and look for the, if there's papilledema, so it's suggestive of increased intracranial pressure or SOL. So you are thinking of something inside the brain, increasing volume, either brain parenchyma, blood vessels, or bleeding somewhere. Right. Then you can do the visual field. Actually, you can do it as a gross test. If you have bitemporal hemianopia, maybe pituitary lesion, like pituitary apoplexy. Right. So those are the things you are doing in the examination. Then specifically, you have to go for look for cerebellar signs. If you don't do it actively, you might miss it. So for you to do the cerebellar signs, there are a few things also you should know as a house officer. The patient should understand your commands. If he can't understand, he will not obey your commands, and you can't do the cerebellar signs. And he should have a normal muscle power. If he can't stand up from the bed, he will not do it. And then he should have a normal sensory function. Like what are the tests you are doing? You do the heel shin test, finger nose test, dysdiadochokinesia, all those things you can do and look for any cerebellar signs. So could be a sign of hemorrhage in the cerebellum. If it is a cerebellar hemorrhage, it is very significant, because if you miss within days, he can develop increased intracranial pressure and die. So it's a specific examination technique we have to do. Then you look for fever, rash, and other things, the associated features, which can be indicative of meningitis. Right. Then you have heard of this meningismus. So as a clinician, you are doing on the wards the what we call nuchal rigidity. The neck, they can't lift up. The neck is very rigid. Then the Koenig sign. So you should know how to elicit it. So you do the flexed at the hip, and then you extend the knee passively from the lifted up position. Then they get the tightness of the leg. Then the Bruce-Skin signs, again this neck rigidity. Then there's another thing, a test called jolt accentuation test. You rotate the head 3 to 4 times a second, then their headache gets worsened. Actually, these signs explained in most of the medical examination books. They are not very specific, but if they are there, you know that this could be meningitis. The percentage of this positivity may be 10 to 20% likes. That means if you get 100 meningitis patients, only 10 to 20% of meningitis patients will show these signs. So you can't rely 100%, but if it is there, you know that this could be a possibility of meningitis. Right. So there's a mnemonic. Again, I think it is again headache. So sometimes you remember only the mnemonic. SNOOP 10, which shows red flags or the warning things for the secondary headaches. What is this SNOOP 10? SNOOP is SNOOP. There are 10 P's, right? Actually, if you know only the SNOOP, that is enough. So S is if the patient is having systemic features. I told earlier also fever. If the patient is immunosuppressive, patient is on prednisolone for a long time, or patient is a malignancy patient, so they are immunosuppressed, they will have systemic features. Then the neurological deficit, that is what we look in the examination technique. Then the onset, whether it was sudden. Then the age, onset age. If you get the headache before 5 years of age and after 65 years of age, those are significant red flags. Then there are 10 P's. One is the pattern change. Patient will say, I had the headache for about a few months, but recently my pattern has been changed. That is a red flag. So there are other P's also. Position. Some patients say, when I lie down, I get the headache. or when I sit down, I get the headache. So positional, that is also important. Then the progressive and atypical. We said now that the patient can have a new onset or persistent headache, and if it is worsening progressively, and if it is different from initial headache, that is also important. Then the papilledema is definite. If there's papilledema, you know that patient is having increased intracranial pressure. Then the post-traumatic. Post-traumatic ones usually miss. If the patient is admitted to a ward, post-traumatic, what we do the, if you do the surgical appointment, you know there's a head injury observation chart. At least 24 hours we observe patients. Sometimes you can miss. Even later they can have problems with the post-trauma. Right? So that is again traumatic patients, a red flag. Then the pathology of immune system. If they have some immunity issues, then they can have lesions inside the brain related to this. Then there are this painkiller or other drug use. There are certain drugs also then that can cause headache. So the headache relieving pain medicines also, they can give the headache. So that is again a red flag. So you might miss it. Then especially in the pregnancy and puerperium, so you can't miss. Most of the time when the pregnant mothers complain of headache, so most of the time we say, don't worry, that is usual. But don't think of like that, because they can have a serious problem, which you might end up in the maternal death and even the inquiries. So pregnancy and puerperium, if they have severe headache, could be a venous sinus thrombosis. So you need to exclude it. In the observed, sometimes we have to go for the CT scan of the brain to exclude the venous sinus thrombosis. Then if you have painful eye with autonomic symptoms, that could be again a serious condition, because there's autonomic nerve involvement there. Then the phenotype rare ones, again, they are taken as red flags, like cough-induced headache, sex-induced headache. So those are the SNOP 10. Just remember this mnemonic, and you can think of this as red flags. Then investigation. So if the patient is coming with acute severe headache, what are the investigations you are doing? CT or MRI of the brain. So especially as a house officer, you might not decide actually. We are not doing all the patients the CT or MRI brain. That has to be decided with your senior colleague's opinion, either sector, registrar, or consultant. They will decide who need, because these tests are expensive, and as a CT scan, it is a very it's a radiological procedure which need X-ray exposure. It's like you're doing a one CT scan, maybe like you are exposing a patient to 100 X-rays. MRI is not that like that. So you know how to do the MRI and the contraindication, those things you should know as a house officer. So we need to decide whom we need to do this investigation. When you decide CT, usually we do the non-contrast CT scan. And if you are suspecting a subarachnoid hemorrhage, we discussed this thunderclap headache. To do the non-contrast CT scan, you might see this CT scan as a normal, but remember, you have to ask the radiologist's help, and ask especially, we are looking for subarachnoid hemorrhage. So then they have the special technique. They put these things, CTs in their console, and they go through these things. Sometimes there were cases we have missed just looking at the CT scan, but when we get the radiologist's opinion, they say this the subarachnoid hemorrhage. So it's an important thing. Then the contrast enhanced CT scans, when what patients you need to go for that. Basically, if you are thinking of a SOL or some intracranial pressure increase, you do. Then the MRI. MRI actually we don't have everywhere. So that is again for especially for the chronic headache patients, not for the acute headaches. And there's a headache protocol in MRI, which is never done in Sri Lanka, because there are about 8 to 10 components. So it takes about 1 to 2 hours. So As you know, the CT scan is a short duration investigation. MRI takes longer duration. So MRI scan, there's a headache protocol. The specific patients in the neurology wards, they do when all the other tests are negative, you look for the specific test in the headache protocol. Right. So those are the investigation. And one more, the lumbar puncture. As a house officer, you should be able to do the lumbar puncture. So first you learn under the SHO's guidance, then you will be able to do alone. So if you think of subarachnoid hemorrhage in a place where you can't have the CT, maybe in a peripheral hospital based hospital where you don't have. So you can try this lumbar puncture, where it called xanthochromia. If this bleeding has happened about 12 hours back, then when you get the CSF, you might see the xanthochromia, yellow discoloration of the CSF. Or you can do the RBC count or serial tubing. You take the lumbar puncture, the CSF fluid into 4 tubes and see whether this 4 tube from the first tube to the 4th tube, the color is diminishing or color is same. If the color is diminishing, that means you have hit a blood vessel and you are doing a traumatic lumbar puncture, right? So if the color, the red color is same in all 4 tubes, you can think this is subarachnoid hemorrhage. And even sometimes they say the RBC count is better if it is more than 2000 red cells per ml or something. So you don't need to know these numbers, just the idea, right? Then the lumbar puncture, you are asked from your bosses or the seniors will say, do the lumbar puncture, we are suspecting meningitis, because you can't miss the meningitis and you can't delay the treatment for meningitis as well. And there's this belief that if you do the lumbar puncture in a patient with increased intracranial pressure, they can form. So how do you know whether the patient has increased intracranial pressure? Then you need to do the CT scan. If you don't have CT, what to do? You're not going to do the lumbar puncture. Now say in a base hospital, peripheral hospital where you don't have CT. Even sometimes in the teaching hospital, the CT machines are broken most of the time. So are you going to miss it or delay it? No. The rule of thumb or the practice point is if the patient's DCS is normal, if the patient has no focal neurological sign, and if there's no papilledema, you can safely do the lumbar puncture, right? Still you can have problems, but this is the rule of thumb. So remember it, right? So meningitis, you do the lumbar puncture, then you send for the analysis and you can diagnose, right? Then the carotid Doppler scan to detect the dissection. We said the neck pain also part of the acute headache. So carotid Doppler can detect it, the dissection of the carotids. The specific test is the digital subtraction angiography that will help to diagnose SAH and even the dissections. Then there are only few blood tests you are doing for the acute headache, like blood count, CRP, that is to actually exclude any associated infections. And ESR is very high in patients with giant cell arteritis. Those are the chronic headache conditions. So all this history, examination, and investigation, you diagnose the condition, then you relieve the pain, and then you are not going to kill a patient who is having a serious condition, right? So that is what I want from you to learn from this. Then there are a few case histories. The 45-year-old woman who had migraine and she had hypertension as well. She was on treatment for migraine. She had some relief of headache, but she said there is a recent change of headache pattern. So, and vomiting in the morning. So I put this only the change of pattern as red, but the vomiting in the morning, again a red flag. The hypertension was there, blood pressure was 180 by 100. And the general practitioner who has seen this patient, he thinks that this is due to the high blood pressure. Now remember that hypertension is not a very common cause for blood pressure, right? So if the patient has headache, that can increase the blood pressure because of the stress. But hypertension per se is not a very common cause, that is a misconception here again. So this is the CT scan. If you see the CT scan, you can see the blood in the subarachnoid hemorrhage, the subarachnoid space. Sometimes you might not see clear. This is a very clear picture, but sometimes you might not see it. So this is how you go ahead with the investigation. If you suspect subarachnoid hemorrhage, you ask the radiologist, we are suspecting subarachnoid hemorrhage, please report this CT scan. Right. Then the next case, another 55-year-old male who was a bike rider and had a fall 3 days back. And he had a fall, I think he was not wearing the helmet and no external injuries. 24 hours, his head injury observation was done in a surgical ward. He was okay, that means non-significant, then discharged. So it's a post-trauma, again a red flag. Then he presented with persistent headache a few days later. Then the CT scan was done. So what do you think? This CT scan looks normal, but you can see in the left side, this side, this is actually the subdural hematoma, which is isodense with the brain parenchyma. If you look carefully, this ventricles, this is bit shifted to the right side. So this you might pass as a normal CT scan, but it is not normal. So it's very important to look the CT scan with the suspicion. And if you are not sure, you can get the help from the radiology department. Okay. Then one more case, the 58-year-old female, again, she had the history of migraine. She had undergone coronary artery bypass graft. During that procedure, she got hypotensive episode. That means blood pressure going down. 2 days later, she presented to the medical ward with a severe headache and blurred vision. So all these are, red flags. She had severe headache, blurred vision. So why you are getting a blurred vision in a patient with bypass graft, ischemic heart disease, right? So the visual fields were done. It showed bitemporal hemianopia. So this is the chart you are seeing, even though the Hutchison's show the nice half-way chart, but this is the one you get in when you do the test in a proper way. So she had bitemporal hemianopia. So where is the lesion? That is in the pituitary, So how did you get a pituitary lesion after bypass? Right, this is the condition. So what you call pituitary apoplexy, or the patient had a benign tumor in the pituitary. During surgery, she had the infarction, or even in the bleeding into the pituitary that can cause this thing. So the patient can present as the persistent headache, right? I think the case, there's one more case. Another 19-year-old male, he had a headache and fever. So the history examination were normal. Then he was discharged after treatment. The analgesics were given, he was discharged. He presented again severe throbbing headache. And he was explaining that he gets the headache when he leans forward. So this is actually a rare thing. So you should know the rare things also happen. Common things are common, but rare things also happen. So the CT was done and it showed this thing. The colloid cyst of the third ventricle. It's a benign and rare, and most of the time asymptomatic, sometimes can present as this headache. Right. So those are the cases, and I think finishing this. And thank you very much for listening to me. And if there's any questions, if the time permits, I can answer. Thank you. Hello. Hello. Hello.
You're talking to me, or?
Yeah. Finish. Yeah. Yes, Tushar, finish. Is there any questions? Yeah.
Yes, sir. I think they have not typed in any questions. Probably they are hypoglycemic or
Yeah. Okay, right.
some of the others, so maybe migraine.
Right.
Thank you very much for that informative and profound lecture on acute headaches. In brief,
Okay,
thank you once again.
Okay.
So next up is anaphylaxis, another interesting topic we encounter daily basis, done by Dr. Chaminda Kotegota, consultant physician. Over to you, sir. So can you hear?
Thank you, Roshan.
Yeah. So your mic is bit of echoing, I suppose. It's all right. Yeah.
What about now?
It's okay. Can hear. Yeah.
Oh, all right, isn't it?
So, okay.
Roshan, can I start now?
Yes, sir. Please. Yes, can start. Yeah.
Good afternoon to everyone. So I'm going to discuss about this anaphylaxis, which is very common and underdiagnosed as well. So this is the outline of my presentation. I'm going to discuss about the definition and the common causes for this anaphylaxis and the pathophysiology, and how to diagnose and manage the patient with anaphylaxis and few case scenario with regard to anaphylaxis. So this is the current guideline, current definition of this anaphylaxis, because the definition has been changing for several years. So this is the 2021 the guideline which was issued by the Registration Council UK. According to that, it is a serious systemic hypersensitivity reaction that is usually rapid in onset and may cause death. At the same time, severe anaphylaxis is characterized by potentially life-threatening compromise in airway, breathing, and not circulation. Please keep in your mind the life-threatening compromise in airway, breathing, and circulation, and may occur without typical skin features. Other thing I want to emphasize that anaphylaxis is a clinical diagnosis. Anaphylaxis is a clinical diagnosis. The precise definition is not important for the management of patient. But I want to emphasize that anaphylaxis is a clinical diagnosis. So let's see what are the common causes for this anaphylaxis. Usually the common causes are foods, medications, and some insect stings. The foods like peanuts, tree nuts, and the cow milk are more common causes for anaphylaxis. When you go to the medications, antibiotic, especially penicillin group, cephalosporin group, and some NSAIDs, diclofenac, celecoxib, like that. And then at the same time, patient might be get anaphylaxis following this contrast media with using this radiology department, and following some snake bites. At the same time, bees bites. So insect stings is other common cause of this anaphylaxis. So what is the pathophysiology behind this anaphylaxis? Activation of multiple inflammatory pathways causes this anaphylaxis. That will cause airway, breathing, circulation problems. Activation of multiple inflammatory pathways are responsible for these airway, breathing, circulation problems. So what will happen there? There will be IgE or IgE non-IgE mediated mechanism. Whatever the mechanism is there, then they will degranulate mast cells and basophils, which release large amount of histamines, neurodegenerative leukotrienes, prostaglandins, platelet activating factors. Those things are responsible for these airway, breathing, circulation problems. So in this diagram, you can see how these things are creating their problems. When you look at the upper airway, you can see that histamine is there, which was released from these mast cells and basophils, which is responsible for our upper airway problems. They can be having rhinorrhea, sneezing, angioedema, stridor. When you go to the again lower respiratory, they may be having cough, wheezing, dyspnea, bronchoconstriction, hypoxia. So these are the various histamines and cytokines which involved in pathophysiology for this anaphylaxis. When you go to the abdomen, digestive tract, they will be having the nausea, vomiting, abdominal pain. These symptoms will be there when you are taking the history of anaphylaxis, history from a patient with anaphylaxis. When you go to the cardiovascular, they might be having hypotension, tachycardia, vasodilatation, and when you go to the skin, very common, they may be having flushing, and they may be having urticaria, they may be having angioedema. So all these symptoms and signs are secondary to these immunomodulators like histamine, platelet activating factors, and prostaglandins. So the next in this slide, you can see that a patient may be having fluid extravasation and vasodilatation secondary to these mediators. The ultimate, they may be having the airway edema and reduced venous return, and they may be having reduced cardiac output, and they may be having bronchospasm because of this airway edema, and ultimately they may be having the reduced pulmonary flow. So ultimately, the patient may be having the hypoxia and the hypotension, which leading to shock. That is what we are saying, that anaphylactic shock. So start from the beginning, because of various cytokines, histamines, they are losing a lot of fluid from intravascular to extravascular, and there will be vasodilatation. So that will reduce the venous return, it will reduce the cardiac output, and therefore various, at the same time releasing various fluid away from the intravascular compartment. They may be having bronchospasm and reduced pulmonary flow. Because of this bronchospasm, airway edema, they may be in hypoxia and the hypotension. So ultimately, anaphylactic shock. This is the pathological mechanism which is behind the anaphylaxis. Then when you look at this diagram, on your left hand side, this is just anaphylactic reactions. On right hand side, this is going to be anaphylaxis. Because from definition, we mentioned that if the patient is having airway, breathing, circulation problems, we will call it as anaphylaxis. In the absence of airway, breathing, circulation problems, we are not telling it as anaphylaxis. It may be just allergic reaction. When you go to the left hand side, patient might be having mild localized skin symptoms and swelling of the lips, face. Then later might be having generalized skin reactions, but they do not have airway, breathing, circulation problems. Therefore, this is not anaphylaxis. When you go to right hand side, they may be having airway, breathing, circulation problems, and they may be having skin problems. 80% will be having the skin problems, but 20% will not. However, if the patient is an airway, breathing, circulation problem, in the background, when you are suspecting the allergen or anaphylaxis, if the patient is airway, breathing problem, so you have to manage it as anaphylaxis. So now you have some idea about this anaphylaxis. So in diagnosis of anaphylaxis, it is sudden onset, airway, breathing, circulation problem. Usually they may be having skin or mucosal changes. In later slide, I will show what are the skin changes and the mucosal changes. The mucosal changes is going to be just angioedema, and skin changes is going to be urticaria or the flushing. As I mentioned earlier, 80% skin and mucosal changes alone are not a sign of anaphylaxis and may be absent in 20%. Only 80% of patients will be having the skin problems, but 20% will not have skin problems. Other thing I want to emphasize in this slide, most of the patients, they might be coming with a confusion because of this low blood pressure. They may be confused, but airway, breathing, circulation, as airway, breathing, circulations are compromised, so patient might be in confusion, agitation, like that. But please remember, generalized urticaria angioedema, and rhinitis are not considered to be anaphylaxis because life-threatening features, airway, breathing, circulation are not present. If those A, B, C are not there, so you are not going to make a diagnosis of anaphylaxis. However, if you are in doubt, give IM adrenaline. I will give the dose in next slide. You have to start an IV adrenaline because this is a life-threatening condition. The adrenaline is safe. You can give it IM 0.5 ml. So, in this slide, I want to emphasize anaphylaxis is a clinical diagnosis with some supportive history. So, in this slide, you can see that what are the airway problems, what are the breathing problems, what are the circulation problems. When you look at the airway problems, they may be having airway swelling, throat, tongue, causing various problems, upper airway problems, and they may be having hoarse voice, and there may be stridor because of this upper airway problems, obstructions. When you go to breathing, always they may be having increased work of breathing, and they may be having bronchospasm, widespread wheezing, and there may be persistent cough, patient becoming tired because of this increased work of breathing, and the saturation most of the time it is less than 94. Can go into respiratory arrest because of breathing problems. When you look at the circulatory problems, they may be having, they are pale and clammy, tachycardic, and hypotension and dizzy because of this low blood pressure, and they can go into arrhythmias and ultimately can lead to cardiac arrest. So these are the A, B, C problems. When you come across a patient with anaphylaxis, A, B, C, D, E approach should be there. All the critical ill patients, A, B, C, D, E approach. Under that, if the patient is an airway breathing circulations problem with some supportive things for the anaphylaxis, you have to manage as anaphylaxis. So, few things in addition to that A, B, C, this is the there may be some neurological problems because of this decreased brain perfusion. And there may be some, that is maybe second local allergic mediators. So because of these local allergic mediators and because of this reduced circulation, they might present with the confusion, agitation, and loss of consciousness. These are some presentation of anaphylactic patients, that is secondary to reduced brain circulation and some local allergic medications. At the same time, some patient might present as abdominal pain and incontinence and vomiting. These symptoms are more likely to indicate the anaphylaxis in the context of reaction due to insect bite, following insect bite, or following snake bite, or following stings by the bees, and after administration of IV medications. So that type of patient can present as abdominal pain or vomiting, right? You should have some idea about how they can present. When you look at this slide, this slide demonstrates what are the common skin manifestations and how it is important for you. Skin manifestations, it is under ABCDE approach under E exposure. So there are some, the first feature of the allergic reaction and present only in 80% of patients. It may be this skin manifestation, first feature of allergic reaction, and it only present in 80%. 20% will not. It may be subtle changes, or it may be a dramatic, generalized, or maybe just a patchy lesions, and may be involved in the skin, or it may be involved in the mucosa. And maybe if it is skin, it may be urticaria, what we call it as rash, wheeze, like that. When it is involved in the mucosal area, you can have angioedema. right, in the lips and the eyelids. Then always please remember in mind, skin changes without life-threatening A, B, C problems are not anaphylaxis. We know that these symptoms are more worrying for the patient and distressing for them. They always come with saying that I am having this problem is skin, but they are not the anaphylaxis. That is allergic reaction to some unknown allergen. So you can manage with some medication without going for the IM adrenaline. You can reassure the patient. Okay, right. So this is the newest guideline and how to manage anaphylaxis. When you see a patient with anaphylaxis, always you have to go for A, B, C, D, E approach. A, B, C, D approach. Then what you have to do when you come to diagnosis of anaphylaxis, then you have to ask for some help, because this is going to be a multi-team approach. You can ask for the help and you have to lie down the patient. You have to keep in a proper position, supine or lateral or left lateral or right lateral, usually left lateral and supine. Those are the two common positions. And you have to give IM adrenaline. You have to give IM adrenaline. 0.5 ml, 1 in 1000. Concentration, you have to give in the middle third of the thigh, lateral middle third of the thigh. So you make a diagnosis of anaphylaxis and you have to get some help and you have to position the patient and you give adrenaline. While doing these things, if you notice if the patient is on some blood, if you notice the patient is on some blood transfusion or any antibiotic, so that may be the reason for anaphylaxis. So please stop those things. You have to remove the triggering factors. You have to remove the triggering factors. Right? What I'm going to do, the anaphylaxis patient, ABCD approach, you have made a diagnosis of anaphylaxis. You position the patient, asking for help and give adrenaline. While doing these things, remove triggering factors. Then you have to establish the airway after giving the 1 shot of adrenaline and give some oxygen and the fluid. You can observe the patient for 5 minutes. If patient is not responding, you may have to repeat IM adrenaline after 5 minutes. Right? So importantly, ABCD need help, remove triggering factors, remove triggers, and IM adrenaline, oxygen, IV fluids, and if no response within 5 minutes, you can repeat it. Right? So IM adrenaline give as soon as possible. That is life-saving medications. So give as early as possible. You have to patient positioning. As I mentioned earlier, supine or lateral position. You remove the trigger if possible. The dose of adrenaline, 1 milligram, 1 ml. That is the normal way you can see in the ampule. So you get the 0.5 ml of adrenaline and give IM. So now you are giving the 500 micrograms IM. So easiest way to keep in mind, 0.5 ml adrenaline IM, 1 in 1000. 1 in 10,000 we are using in cardiorespiratory arrest. This is anaphylaxis. We are using 1 in 1000, 0.5 ml IM to lateral middle third of the thigh. Okay. So these are the other doses for the, depending on the age, 6 to 12, 6 months to 6 years, and less than 6 months. These are the other doses. These are the in this slide, I'm trying to tell you that what are the other supportive management during the anaphylaxis. You have to give adequate oxygen. You give highest concentration of oxygen to maintain the saturation above 94 to 98. There are various ways you can deliver the oxygen, maybe nasal prongs, maybe mask, maybe non-rebreathing bag. Beyond that, you can go for NIV, like that, various ways you can do the oxygen. However, you have to maintain the oxygen above 94, right? Because patient is maybe having the bronchospasm secondary to increased bronchoconstriction and the airway inflammation. So you have to give the fluid because patient may be having low blood pressure. You can give rapid bolus, not the infusion. You start with the bolus, then later on you can go for the infusion. Rapid IV fluid bolus, that is 10 ml per kilogram, maybe around 500 or 1000 ml of normal saline in adult patient. So oxygen and the fluid. What about this antihistamine? The most of the time we used to do this antihistamine, but you can try this antihistamine later, not from the beginning. Beginning you have to give more attention to the adrenaline, oxygen, fluid. You can see that antihistamine are not recommended as part of initial emergency management of anaphylaxis. Initial emergency management of anaphylaxis. Because it does not have any role in respiratory, cardiovascular, or of anaphylaxis. But it has some role in treating skin symptoms. Therefore, you can try this antihistamine not from the beginning, but in the latter part of your management of that patient. Same story in the steroids. The routine use of corticosteroids to treat anaphylaxis is not advised. However, consider giving steroids after initial resuscitation for refractory reactions or ongoing asthma or shock. You can try steroids later, not from the beginning. What are the problems you might encounter in managing anaphylaxis? Refractory anaphylaxis. What do you mean by refractory anaphylaxis? I told that you can try adrenaline 0.5 ml IM. You can observe and you can monitor patient up to 5 minutes. You can repeat another dose of adrenaline. Again, you can observe. If the patient is not responding, if the patient is not recover with that second dose of adrenaline, we are calling it as patient is going to refractory anaphylaxis. So that is going to be a huge problem. So patient might be needing IV adrenaline infusion and more medical care. Therefore, you have to discuss with the senior people, and you may have to go into the maybe ICU as well. What is the other problem you might encounter during this anaphylaxis is cardiorespiratory arrest. Sometimes patient might go into cardiac arrest, may go into respiratory arrest during the anaphylaxis. So if you detect with if the patient is going to cardiac arrest, you have to start on advanced life support. Whether the patient is in a shockable rhythm or non-shockable rhythm, you start the CPR as early as possible. Then you check the rhythm. Depending on the rhythm, you have to go for advanced life support protocol. So few things you can encounter during the anaphylaxis. Refractory anaphylaxis, which is not responding to adrenaline, or patient might be going to cardiorespiratory arrest. You may have to start advanced life support. Few things. What are what you call by biphasic reactions? That is recurrence of symptoms several hours later in the absence of further allergen exposure. So you might be having recurrence of symptoms even though you don't have an ongoing allergen exposure. This is known as biphasic reactions. About 50% of biphasic reactions occurred around 12 hours of first exposure. 50% of biphasic reaction will occur around 12 hours of exposure, first exposure. Right. What are the important things during pregnancy? Anaphylaxis during pregnancy is similar to that of the non-pregnant patient. So management of anaphylaxis, no differences between the non-pregnant and the pregnant. So you have to manage equal, but because of this gravid uterus, you may have to position the patient fully lateral. On discharge, you have to educate the patient about what are the causes and how to prevent it, what you should do if you develop these symptoms. And always you have to issue a diagnosis card to each and every patient. Otherwise, patient might kill in the next time. So shall we move into some case histories? I have prepared 3 case histories. 1. 37-year-old patient admitted with 3-hour history of rash which was worsening over the time. 37-year-old patient admitted with 3-hour history of itchy rash worsening over the time. On examination, there was generalized urticarial rash, but blood pressure 130/80, pulse rate 86, respiratory rate 50. Lungs, there was vesicular breathing, no any added sound. Saturation is 97. So this patient is having some skin problems, but airway is all right, breathing is all right, saturation good, and the respiratory rate 50, and the blood pressure is also all right. So ABC is all right, but patient is having a urticarial rash, which is worsened over the last 3 hours. Is that anaphylaxis? What are you going to do with this patient? This is not the anaphylaxis. You can try with some antihistamine and steroids, but this is not the anaphylaxis because airway, breathing, circulations are stable. What about this second case? Nursing officer. While you are working in the hospital, while you are doing your day-to-day work, the nursing officer inform you that bed 3 patient is confused after giving his medication. Now the patient, nursing officer is delivering daily medicines, and the patient, she has noticed that bed 3 patient is confused after giving his medication. So now you should have some thing in your mind. So patient was all right before giving the drugs. Now patient is a bit confused. What is the acute onset? In definition, what we mentioned that acute onset, airway, breathing, circulation issues. So now you have to think in mind, am I dealing with the anaphylaxis? So what is now any critical ill patients, you have to go for ABCD approach. In airway, patient is saying the inspiratory sounds, many inspiratory sounds like a stride. So increased work of breathing, that is respiratory rate 26 and saturation 84. So airway is compromised and the breathing is compromised with increased work of breathing with a respirator of 26 and saturation is dropping. Then the blood pressure is 70 and the diastolic you can't even measure. So what is your diagnosis in this type of patients? It is going to be anaphylaxis. So what you have to do is you have to call some help. At the same time, you have to position the patient. You have to stop if the patient is on any current infusion. You have to stop those things. You have to position the patient supine, and you can elevate the leg to increase the good perfusion in the brain, and you have to give IM adrenaline 0.5 ml 1 in 1000 to save this patient's life. This is anaphylaxis, which may happen at any time in your ward while you are in the ward or maybe in your small break. at your quarters. You might get a call from the nursing officer. So you have to rush to the patient always. In this type of patient, please don't take history from the nursing officer and over the phone. You have to rush to the patient. You have to rush to the patient to get the history, and you have to manage quickly as possible. Otherwise, if the things are going on, patient might go into cardiorespiratory arrest or might be having refractory anaphylaxis. In that case, you may have to start the advanced life support. This is my third case, and 32-year-old patient brought to hospital after attending to a wedding ceremony. He's a diagnosed patient of bronchial asthma and had many food allergies. Brought to hospital after attending to wedding ceremony, and he's a diagnosed patient with bronchial asthma and had many food allergies. And ARV assessment, patient is in mild angioedema, that is swelling of the lips, and some noisy sounds, that means some airway obstructions. And respiratory rate was 25, and there's a bilateral bronchi, and the saturation is around 75 to 80. So there's some breathing compromise, and blood pressure is 80 and diastolic is 50. There's some cardiovascular compromise, and patient is anxious and agitated. On E, there are some few urticarial rashes. So 32-year-old patient with a background history of bronchial asthma and many food allergies. Coming with angioedema and respiratory signs and symptoms and low blood pressure, and the patient is anxious and agitated. There are some few skin urticarial rashes. What is your diagnosis? Obviously, because of this allergy history, and he has attended the wedding ceremony where there will be large number of foods with some unknown allergies for him, so he must have taken it. So this is going to be anaphylaxis. Why I am saying that anaphylaxis? Airway compromise, breathing compromise, and circulation compromise. Any other differential diagnosis when you see this type of patient? Can it be a life-threatening asthma or acute severe asthma? Yes. The only thing against is mild angioedema. Mild angioedema. And some urticarial skin lesions. Those are not common among this bronchial asthma. They are not there. They will be having respiratory problems and blood pressure, and patient may be anxious because of this hypoxia. So get some quick history, and you have to manage. If you are in doubt, give IM adrenaline, no problem, 0.5 ml IM. Because otherwise, if you are in doubt, if you are not giving the adrenaline, you won't have a patient to give adrenaline again, because patient might go into cardiorespiratory arrest. So what are the differential diagnoses and what to do? That's what I have discussed. Anaphylaxis plus or minus bronchial asthma are the differential diagnosis. But as patient is in this urticarial lesions and the angioedema, you can ignore this bronchial asthma part, even though he's a diagnosed patient of bronchial asthma. I think I have come to the end of the presentation. I will give some take-home messages. Please remember a few things in this slide, even though you forget all the things in the past slides. So always, any critical ill patients, ABCD approaches should be there. ABCDE approach should be there. Otherwise, you might not catch the proper examination part. And you make a clinical diagnosis of anaphylaxis. Don't waste your time for various other investigations. You have to make a clinical diagnosis of anaphylaxis. Then IM adrenaline 0.5 ml 1 in 1000. IM adrenaline 0.5 ml 1 in 1000. And repeat in 5 minutes if needed. You can repeat adrenaline in 5 minutes if needed. High flow oxygen to maintain the saturation about 94 to 98. IV fluid, boluses, and on discharge, please educate the patient and issue a diagnosis card for each and every patient. Otherwise, next time, patient will not get the proper management, as everyone is going behind the digging the history. By that time, patient might go into cardiorespiratory arrest. I think with that, I will wind up my session. Wish you all the best for your intern. And if you have questions, you can ask.
Yes, sir, we can have a minute turn. There's one question to be answered. What is the role of intubation? Do we need to intubate early before it becomes difficult? Or we wait until the first shot of adrenaline given?
Roshan, that is a good question. Always, as I mentioned, everything first, IM adrenaline.
Yeah.
IM adrenaline. You have first give IM adrenaline. Later on, you can go for other things. If you are not giving the IV adrenaline, patient might go into cardiorespiratory arrest. First, IM adrenaline.
Right. Sir, can we use high flow oxygen to give salbutamol?
High flow oxygen, salbutamol. And always I am saying that these are the common questions asked from the various doctors, even in our unit. First, in this anaphylactic reaction, please believe me, you have to start only the IM adrenaline. If you start IM adrenaline as early as possible, patient will recover. You might have to think about this IV salbutamol, IV adrenaline, everything. If you are not giving this IM adrenaline from the beginning, then because you are getting late, you will get more and more problems. If you try IM adrenaline, yes, patient will be all right. He was asking about the giving high flow oxygen with salbutamol. So sometimes what we are doing is we are nebulize the patient with oxygen driven pathway. So in that case, nebulization with salbutamol we can give it, but that is not indicated here. That is not indicated here. You have to go adrenaline and observe another 5 minutes. Roshan, did I answer?
That's okay, sir. There are last question, sir. Are there any effect of giving 1 to 2 tablets of Pre-Intern or cetirizine till the patient brought to the hospital? I mean,
Sure. Nothing.
Yeah.
You can do anything because if you don't have adrenaline. But thing is, if you are given the correct information on discharge about this anaphylaxis, and they can buy this pen. We have that EpiPen, the adrenaline pen in the marker. You can give some advice to buy those pen. So if the patient is having these symptoms, you can try IM adrenaline before coming to hospital.
Yeah.
So one patient coming to hospital with that IM following IM adrenaline, patient will be all right. You can give it. The only problem is when you are trying to do this Pre-Intern blah blah blah. If the IM is not secure and patient is confused.
Aspirate.
Correct.
The EpiPen is available in private sector to buy, I suppose, so, no?
Yes, it is available. Yes, it is available.
So more people with severe allergic reaction, they can buy and keep it to themselves.
Yes.
And use it whenever it's necessary.
Yes.
Right. I think that's we conclude our session on anaphylaxis, sir.
Yes.
Thank you very much for that, giving a profound insight of how anaphylaxis works and the treatment available in a short period of time. Thank you very much for everything, sir. Thank you. Dr. Chamindu Kotegara, consultant physician. So next up is Professor Namal Vijayasinghe from KDU, Professor of Medicine, on last lecture for today is on interpretation of ECG. So, sir, you are there?
Yes,
I will go on. Yeah. Okay, sir. Over to you.
Let me allow to share my slides, Roshan.
Yeah. Okay, sir. So I think there are some basic guideline books available before internship. We'll try to circulate within a group, then you all can use it, I suppose. Published by SLMA and some institution colleges. So we'll see what we can arrange for you all to utilize before you all go to internship. Right, sir, you are ready to go.
Okay, so good afternoon. I think it's the last lecture, so you may be tired, but try to finish as early as possible. Like the last time, usually the last lecture of the course is for basic interpretation of ECGs by the internees. This is again a very important topic because when you start the internship by next month, you will be suddenly thrown into the deep end of the water, and people will ask what is there in ECG. So when we do the MBBS curriculum, we teach you about the ECGs, but at the end, we are mainly concentrating on some core ECGs, that is about 8 or 10 ECGs that every doctor, irrespective of whether you're a physician or a cardiologist or a surgeon, that you preferably should know to interpret. So during my talk here, I'm going to concentrate on more on those ECGs. I will point out this is the ECG that you must know during your internship, because you may be the first person to see that ECG, and if you miss the abnormality, then we might lose the life of the patient. So, so I will show you those ECGs, but in addition, we will show you some other common ECG abnormalities as well. So I always say that ECG is like life, right? You have to have ups and downs like waves. Otherwise, if it is a straight line, that means you are dead. Now, before I show you some ECGs, we need to know the basics of ECG and various waves and the intervals. I'm sure we know these from your physiology days, but just to completeness of sake, I'll show you that there is a P wave, which indicates the depolarization of the atria, and then QRS complexes. The QRS complex indicates the depolarization of the ventricle, and T wave indicates the repolarization of the ventricle. So these are the important waves that you should know. And in addition, you have U wave, and some people say it is repolarization of papillary muscles, and there are other explanations as well. And also some important intervals. So we need to know what is the PR interval, that is the beginning of the P wave to the beginning of Q wave, and QT interval, that is the beginning of Q wave to the end of the T wave, and the RR interval, of course, from one R wave to the other R wave, and also the QRS width. Now, when we take ECG, we need, we call it 12-lead ECG, and there are 6 limb leads and 6 chest leads. However, we attach only 10 ECG leads. We attach 6 chest leads and also 4 limb leads. But when we generate the ECG, we generate 6 chest leads from the leads that we attach, and also we generate 6 waves, L1, L2, L3, AVR, AVL, and AVF from the 4 limb leads that we attach. Now, one requirement is that we as junior doctors, you all should know how to do an ECG. That is why in the physiology also, and also during the professorials also, we want you to do ECGs on your patients. Because if you are posted to a faraway hospital and also in a place where there are no ECG technicians during odd times, you should be able to do an ECG. So please remember the way you do the ECG, and also the ECG machines may be different from place to place. So just play with your ECG machine when you start your internship and get to know about how to do an ECG, especially in an emergency. And also nowadays, sometimes we might not be able to get everyone inside the wards because of the ongoing epidemic, especially the COVID units. So you may be the person who might end up wearing the PPE and go in and do the ECG, because not everyone will be able to go in there. So as you know, using the 4 limb leads, we generate 3 bipolar limb leads. Those are the lead 1, L1, L2, and L3. We use 2 limb leads and get both electrical generations and into one wave. And also we use unipolar leads, but we call them augmented limb leads, and then we generate AVR, AVL, and AVF. So remember how you attach. I'm not going to go into details, but you can read a book and refresh your memory. I'm sure everyone has been taught about this, how to attach the leads and take an ECG the patient. Now, that is about taking the ECG, but before interpreting, there are few important things that you have to do spontaneously. That is, have to pay some attention on patient identity. Now, even on the ward, the ECGs may be filed in different patient notes, because when these ECG technicians come, they keep on doing ECGs, and they might end up filing it with this different notes. And in wards, usually they have an envelope, and when they take these ECG strips, they roll it and put it in those envelopes, and maybe wrong patient. And even when we see patients in the clinics and in the private sector, one simple question: you must be Mrs. Pereira or something like that, and you confirm the identity. Otherwise, you do a wrong diagnosis on a patient. And also, we need to pay attention on lead positioning. Sometimes, by a mistake, the technicians might end up connecting leads wrongly and take ECG. So there can be limb reversals, and also even chest leads can be reversed. I have seen all these things, and you should be able to pick that up. And best thing to do is, if there is a suspicion, you do another ECG and compare with this, then you will identify that the previous ECG has been taken wrongly. And another thing is, I'll show you an example: paper speed and the amplification. You know, sometimes people don't know much about taking ECG, especially when they come with ECGs taken in the private sector from these small dispensaries and clinics, and some trained people doing ECGs. They might end up not correcting the proper the paper speed and the amplification. You know that proper ECG, a usual standard ECG should have 25 millimeters per second paper speed and 1 millimeter per millivolt paper amplification, the electric amplification. And also sometimes there are many artifacts that were recorded at the time of ECG is taken. So you need to have some idea about the artifacts also. Otherwise, sometimes people get excited and scared and running to the hospital or to see a physician because of the same reason. So these are the 4 things that before looking at the ECG, before you try to interpret the ECG, that you have to pay attention to. Now look at this ECG. because sometimes we train our eyes to diagnose certain rhythms. Now, if you look at there are two panels. If you look at the atrial flutter that is in the upper row, you know that when you look at the ECG, this is a atrial flutter with 2 to 1 block. So we normally can identify this as a 2 to 1 block, because not only by counting the small squares or anything, but just because we have seen this and we have trained our eyes to identify. And also the second panel, the upper row, you know when you see that this is atrial fibrillation because it is irregularly irregular. And not only the QRS complexes, the rhythm, even the QRS complexes are irregularly irregular. However, the same ECGs have been taken by slowing the paper speed. So making the paper speed faster. So 50 millimeters per second. And you see that characteristic rhythm pattern that we recognize has been lost. So I have seen sometimes, but easy way to identify this is by all these rhythms. Can you see that there is a box-like thing at the beginning? So that is for us to identify easy, because that indicates that width of that box indicates the paper speed, and the height of that box indicates the voltage. So by just looking at it, you know that this is a standard ECG, and the lower one, the width of the box is twice the normal. So we know that it is 50 millimeters per second. So keep an eye down. When you look at few ECGs like this, then it will come to your the way of looking at ECGs. You will be trained to look at these things automatically. So keep an eye on that. Now this is another ECG. Now at the end of the ECG, you see that box. You can see that it is a standard ECG, that is 10 millimeters per 10 millivolts, and also 25 millimeters per second ECG. But sometimes you can see these very tall R waves in V4, V5, and sometimes in V6. So actually in V4, the QRS complex has gone above the paper, the ECG paper, into this white area. So sometimes even smart ECG technicians, people who know a lot about them, they can purposefully reduce the voltage and take the same ECG to get these into the ECG paper. Now this commonly happens when they take these ECG strips, because otherwise the QRS complex go out of the paper. So you also should be smart enough to spot that. So that is why we should pay attention to the paper speed and the voltage. Now, what do you think about this ECG? Now, this is a ECG that when I was doing my postgraduate training, this patient was sent to us for a ICD implantation, saying that this patient is having recurrent VT. But actually, this is an artifact. How we identify it is, now when you take these ECGs, you can see these QRS complexes, 4 QRS complexes in the same line, L1, L2, L3, and L2 again. All are in the same line. And this is just what one ECG complex. That is, I mean, this A4 size paper ECGs have several advantages. One disadvantage is that this ECG can record only 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12 ECG complexes only. But if you take a ECG strip, there will be about 40 or 50 ECG complexes, QRS complexes. Now, if you look at the V1, how come that L2 in the 4th row is normal and others are like BP? It can't happen because it's the same ECG complex. But if you very carefully look at it, you can see just above the QRS complexes of L2, these ECG the waves are the QRS waves, but in between are the artifacts. They are motion artifacts. The patient has moved. So I have several ECGs collected, especially when you do ECGs on Parkinson's patients, especially people who have anxiety and excited. They develop a lot of these muscle tremors. As a result, you get these artifacts. So they are normal. So pay attention to artifacts also. Now, when you interpret an ECG, one important thing is for you to identify the heart rate. Oftentimes, the heart rate is printed on the ECG in that machine interpretation. I don't normally encourage young doctors to look at the machine interpretation because that is often wrong. These machine interpretations are there for the paramedics. Those in other countries there are volunteers who go in ambulances as a voluntary work. They are not health professionals. For them to read and contact the doctor, only these machine interpretations are there. But I normally look at the heart rate or ventricular rate that is printed. It is usually correct. But if it is not there, you should be able to calculate the heart rate by looking at an ECG. We know you can start from one QRS complex. You count how many large squares are there for a QRS complex. Now, in here, you have about 4, close to 4, little less than 4. So, if there is one large square, the heart rate is 300. 2 large squares, the heart rate is 150. 3 large squares, the heart rate is 100. 4 large squares, heart rate is 75. 5 is 60, and 6 is 50. And 7 is 43, and so on. So if you know this, in many ECGs, you can roughly calculate the heart rate. So at least I can tell you that this is little less than 4, but more than 3. It is between 175 and close to 75. So I would say this is about 80. Heart rate of about 80. So one thing that you need to know when you look at an ECG is to calculate the heart rate. This method is correct provided that the patient is in sinus rhythm and the heart rates are regular. The QRS complexes are regular. So many ECGs, patients are on sinus rhythm and the rhythms are regular. So you can apply this method. But if the QRS complexes are irregular, as in atrial fibrillation, then there are other methods to calculate the heart rate. I will show you when we go there. So this is the first learning point. Then we'll talk about the sinus rhythm. What are the ECGs that you can see in the sinus rhythm? Of course, normal ECG is in sinus rhythm. And that is characterized by having a P wave. Right? Then that is why when you do a rhythm strip, you normally take L2 or V1 as the rhythm strip, because the P wave is best seen in L2 and V1. Of course, L1 and AV are also sometimes we take, but L2 or V1 are taken often because very clearly you can see the P wave in those leads. Now, this is another ECG you might see time to time. By looking at this ECG, or even when you examine the patient, you will find out that there is an irregularity in the pulse rate. The pulses are irregular. And even when you look at the ECG QRS complexes are irregular. But this patient is in sinus rhythm, and this is an ECG of sinus arrhythmia, which is a physiological condition or phenomenon. This is due to the increased heart rate during inspiration. So young people, young adults, their autoimmune systems are very effective or efficient, you can see the sinus arrhythmia. It's not a disease condition, it's a physiological phenomenon. Now, this is sinus bradycardia. Right? In an online presentation, I don't want to ask questions. I can see more than about 650 people are there, so no point in asking a question. But if you, the upper panel, if you look at what the heart rate feels like, we call it sinus bradycardia because this is sinus rhythm. You can really clearly see a PR interval and also a constant PR interval, a clear P wave. So this is a sinus rhythm. And if you look at the large waves, you can see 1, 2, 3, 4, 5, 6, 7, 8, and more than 8 is close to 9. So if you want to find out the heart rate of this patient, you divide 300 by the number of large swells. So if you divide 300 by 80, so how much it will be? It's less than 4, isn't it? Right? So this heart rate is in 30s. And even here, the heart rate is a little faster than that. But again, it's about 7 squares. So the heart rate is about 40. So this is sinus bradycardia. The heart rate should be less than 60 and the patient should be in sinus rhythm. The causes can be either eccentric or intrinsic. Usually they are extrinsic causes like hypothermia, hypothyroidism, and sometimes obstructive jaundice, raised intracranial pressure. And the commonest cause for sinus bradycardia is patients who are on rate control medication. It could be beta blockers, non-dihydropyridine type calcium channel blockers like verapamil or diltiazem, and also digoxin. And neurocardiogenic syncope and therapeutic sinus syndrome, they all can cause, they all are extrinsic causes. The intrinsic causes are the sick sinus syndrome, where the degenerative system, so the conduction system is degenerated, and also ischemic heart disease, either it's infarction or ischemia of SA node or the AV node. So these are the causes of sinus bradycardia. Sinus tachycardia is the opposite of that. Patient remains in the sinus rhythm, but the heart rate is more than 100. If you look at here, the QRS complexes are little more than 2. So heart rate is less than 150 and more than 100. I would say it is about 130 in the main ECG. And one above is also heart rate is about 130 and the patient is in sinus rhythm. So sinus tachycardia and sinus bradycardia as well as sinus arrhythmia are not pathological ECGs. They are physiological phenomena, but sometimes can be as secondary to the other systemic diseases. So again, we can sometimes people develop sudden sinus tachycardia due to anxiety, pain, fever, various infections, when they have fever due to infection, acute LVF, pulmonary embolism, and hypovolemia. Chronic causes or the ongoing causes are during pregnancy, anemia, thyrotoxicosis, as well as catecholamine excess. Now these days I see, even today I saw a couple of patients who have developed sinus tachycardia because of the anxiety. And you have to tactically handle and make them understand that this is not a heart disease, but because of the way they think. You know, heart is an organ that responds very quickly to the things that you think. For the means due to the emotions. So these days people are very anxious because of this ongoing epidemic, and they often come to see us with breathing difficulties, palpitations, non-specific chest pains, and we find them having sinus tachycardia due to the anxiety. Now, quickly, a couple of conditions that you might see often in the ECGs and important to diagnose if possible. One is LVH. Now, remember, ventricular dilatation, it's either left ventricular dilatation or right ventricular dilatation, cannot be diagnosed by doing an ECG. We can diagnose atrial dilatation, left atrial dilatation and right atrial dilatation, which I am going to talk today. But we can diagnose the hypertrophy. Hypertrophy is not dilatation. Hypertrophy is increasing muscle mass and thickening the muscle wall. So when you have ventricular hypertrophy, how we identify is finding slightly widened and taller R waves in the V5 and V6 and as well as L1 and AVL. Also deep S waves in V1 and V2. So there are several criteria. One criteria is if the R wave is taller than 27 millimeters in V5 or V6, we can diagnose LVH, or else if we add the S wave in V1 or V2 to the R wave in V5 or V6, and if it is more than 35, it is LVH, or else if you take AVL alone, if the R wave is taller than 13 millimeters, it is LVH. So if you read the book, there are several criteria, there are several names given to these criteria, like Sokolov criteria and so on. I'm not going to complicate the way you think and here, but if you are interested, you can read about it. But this is how you diagnose LVH: finding tall but slightly widened R waves in V5 and V6, and also deep S waves in V1 or V2. Now this is a real ECG of a LVH. You see that tall R waves in V5 and V6, and also deep S waves in V1 and V2, and here in V3 as well. And also together with the deep R waves, tall R waves, you also see this downsloping ST segment depression, as you can see in V5 and V6. So this downsloping ST segment depression is due to ventricular strain. Now, if you have only a tall R wave, that also could be due to very efficient electrical activity of the heart muscle. You can see tall R waves in thin people, in children, and because the leads are very close to the myocardium, you can generate a very tall or very high electrical stimulant. So that is not LVH, but to diagnose LVH, together with the electrical criteria I mentioned, that is tall R wave and deep S wave, you also have to have a repolarization criteria. That is what we call repolarization criteria for ventricular strain pattern as well. Then the specificity of your diagnosis improves. The right ventricular hypertrophy is the other side of it. You find a tall R wave in V1. Now we know that in a normal ECG, the R wave is not there. There is no positive R wave in V1 in the normal ECG. But only few conditions give rise to that, and R wave, the right ventricular hypertrophy is one of them. So slightly widened QRS complex with a positive R wave, and also as you can see that downsloping ST segment depression is there. That is due to right ventricular strain. Right ventricular strain. So as indicated in V1, to diagnose right ventricular hypertrophy, you should find upward or positive R wave in the V1 and followed by a downsloping ST segment depression. Now this is a real ECG of right ventricular hypertrophy. As you can see in V1 and V2, usually in V1 and V2 the R waves are negative and you only see a S wave. There's no positive R wave, but here you find the R wave together with the downsloping ST segment depression. And that is how you diagnose right ventricular hypertrophy. I hope you understood how to diagnose left ventricular hypertrophy as well as right ventricular hypertrophy. Another two things that I want to show you is how to diagnose left bundle branch block and the right bundle branch block. Now, you know the conduction system from the when the impulses come to AV node, there's a delay in the AV node and starts the His bundle. His bundle soon divides into two main branches. One is called the left bundle branch, the other one is called the right bundle branch. The left bundle branch then divide into left superior anterior fasciculus and left inferior posterior fasciculus. But the right ventricle, right bundle branch goes to the right ventricle, and all these ultimately divide into form the Purkinje system. So when there is a block to the electrical conduction in the left bundle, you get the left bundle branch block. How you identify is that the wide QRS complexes and a positive and wide QRS complex in the V5, V6, L1 and AVA. And they are usually bifid, meaning that it is like there's a small division, as you can see here, in the top of the QRS complex. So it is bifid QRS complexes. So, and also usually it is followed by ST segment depression. So all this is, now this ST segment depression can be seen as a ST elevation in V1 and V2. So this is how you get left bundle branch block. If you learn about how the conduction is spread to the left ventricle from the right bundle branch in a patient with left bundle branch block, you will understand how these ECG complexes are formed. Now this is a ECG of a left bundle branch block patient, and V1 and V5, L1 and AVL, you can see wide positive QRS complexes, and this is due to left bundle branch block. Now, if you see a patient with left bundle branch block, please document that, because if they suddenly come with chest pain and having this ECG, we might wonder whether this patient has a new left bundle branch block and whether the patient needs a thrombolysis. So this is a left bundle branch block. Likewise, if you see the same widen and bifid QRS complex in V1 and V2, you can diagnose right bundle branch block. So when it is in the lateral leads, you diagnose left bundle branch block. When it is in the V1 and V2, and again, this is another reason for you to have a positive R wave, and you can diagnose right bundle branch block. This is an ECG, real ECG of a right bundle branch block. Now, the first positive deflection is very thin, but the second one is little wider. But it is a bifid, widened QRS complexes, positive QRS complex in V1, V2. So you can diagnose complete right bundle branch block. Why we call complete is when the QRS complexes are not so wide, we diagnose we diagnose partial right bundle branch blocks. So usually the QRS complex is 0.04 or 40 milliseconds. When it is more than 140, we call it a wide QRS complex. Now, we talked about the heart rate measurement, and we talked about the LVH and RVH, and we talk about the left and the right bundle branch block, and let's move on to cardiac arrhythmias. Now, cardiac arrhythmias can be either bradyarrhythmias when there's an arrhythmia and the heart rate is less than 60, and also could be tachyarrhythmias when you have an arrhythmia with a heart rate of more than 100. Now, the important thing with arrhythmia is you can have an arrhythmia with no symptoms whatsoever. It can be completely asymptomatic, and the other end of the spectrum, you can suddenly die. You can have a sudden cardiac arrest and a sudden cardiac death. But in between, you can feel dizzy, you can have a lightheadedness, you can develop chest tightness, you can develop palpitation, you can go into heart failure, you can develop loss of consciousness, blackouts, and syncope. So in between, you can have several symptoms, but it could be asymptomatic as well as ended up in sudden cardiac death. Also, your symptoms depend on the underlying cardiac functions. Now, if your ejection fraction is poor, with the same ECG, the heart rate and the arrhythmia, you might suddenly go into severe symptoms and cardiogenic shock. But a young person with normal underlying heart functions might not feel that bad. Now, this is how arrhythmia can occur. That is why it is important to monitor do cardiac monitoring in acute cardiac conditions. This person was having normal sinus rhythm, but with a ST elevation, but suddenly has gone into a ventricular arrhythmia. So we have to act quickly and DC cardiovert this patient. If the patient has arrested, one could do a defibrillation. Now, out of the ECGs that I wanted you to know, these are some 4 very important ECGs. Because as house officers, you all should know how to identify the ECGs of cardiac arrest. Because I have seen sometimes when I go in to see the patient, there is ventricular fibrillation on the monitor, and the house officer was trying to put a cannula in or trying to give some oxygen, where he has to quickly start cardiac massage and arrange defibrillation. So ventricular fibrillation, look at the rhythm, always try to identify ventricular fibrillation. And asystole, pulseless ventricular tachycardia. It is nothing much different from a usual tachycardia. Only thing is the clinical manifestation, there is no pulse. So the patient technically has arrested. So the treatment is same as ventricular fibrillation. You have to start cardiac massage and quickly do defibrillation to revert the patient back to sinus rhythm. Then pulseless electrical activity, again, there are several pulseless electrical activity rhythms. So I have put 2 of them. Basically, ECG looks like normal, but you don't feel any pulses. So these are the 4 rhythms of cardiac arrest. Please don't miss them. They are important ECGs to recognize. If you miss them, you will never recover the patient. Now, if you look at the bradyarrhythmias, there are a couple of bradyarrhythmias that you need to know. When the SA node is diseased, you get 6 sinus syndrome. How it manifests is the rhythm looks normal as in the beginning of this ECG, but suddenly the SA not stop firing or stop generating impulses, and you get a pause. Now, if you look at this RR interval and see QRS complexes 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15, 16, 17, 18, 19, 20, 21, 22. 22. Now, when the 5 large squares is 1 second. When you have 22, then there are 4 to 5 second pause is there. So about 4 to 5 seconds, the heart has not contracted, has not pumped any blood. And we see patients with 7-second pauses, 10 or 11-second pauses even, rarely. So when the heart is not contracted for 5 seconds or 7 seconds, the brain doesn't get blood. And you might ended up having a fainting episode. So that is how elderly people, this happens due to degeneration of the conduction system and the SA node. And usually in elderly, and they have a fall and they might ended up breaking their hip bones and so on. When there is a disease in the AV node, you get an AV block. So there are several types. I'm not going to go into details. First degree AV block when the PR interval is prolonged, and second degree AV block when some of the P waves are not followed by QRS complexes, and when there is no connection between the atria and ventricles, when none of the P waves are followed by exactly by the QRS complexes, we call it complete AV block or the third degree AV block. I prefer the term AV block than the heart block because the patient gets scared when you tell patient that you have a heart block. The people who don't know about this get scared. So a common or a better term to use is AV node, an AV block. Now, this is a ECG of a second degree AV block. As you can see, it's a 2-to-1 second degree AV block. Now, I'm not going to go into detail because I will not be able to finish in 1 hour. But there are 2 types of second degree AV blocks, Mobis type 1 and Mobis type 2. This is Mobis type 2, 2-to-1 AV block. One P wave is followed by the QRS complex, whereas the second P wave is not followed by a QRS complex. And every second P wave is only followed by a QRS complex. So this is a second degree AV block. You should identify it's a bit of a stable AV block compared to the complete AV block. Now this is the complete AV block. As you can see, the P waves occur on their own. If you take out your divider, the dividers that we use in O-level, or else you can take a piece of paper and mark where the P waves are, and when you take the paper into the other place also, the P waves are in the same distance. And the QRS complexes are independent, but they also follow the same distance. Now, if you feel pulse in a complete AV block patient, you will feel that the patient has bradycardia, that's very slow heart rate, but the heart rate is regular. Now, you might wonder what you should do in a patient with bradycardia. If you find that the patient has bradycardia, especially a bradyarrhythmia, a sick sinus syndrome or AV block, first thing you should do is connect to the monitor, and sometimes just stopping the heart rate control drugs alone is enough if the patient is stable, and keep monitoring until the heart rate comes up. And we need to correct the electrolytes. And the medications we can try are atropine and give 0.6 milligrams IV as a bolus, setting up an isoprene infusion are sometimes helpful. So these are the things that you can do. Otherwise, you have to quickly find out someone who can put a temporary pacing wire, or else sometimes you have defibrillators where there is a external pacing facility. Then you can start external pacing. You can go up to about 40 minutes to 45 minutes doing external pacing until you find someone to pass a temporary pacemaker wire. But if it is an ongoing problem, it's a chronic problem, we have to put a permanent pacemaker. That is the ultimate treatment for bradyarrhythmia when it is not reversible. Let's move on to tachyarrhythmias. Depending on the place where they originate, we can divide them into atrial tachyarrhythmias, nodal tachyarrhythmias, as well as ventricular tachyarrhythmias. And also sometimes we, for the purpose of easy interpretation, we divide them into narrow complex tachycardias and wide complex tachycardias. Now, narrow complex tachycardias are the atrial tachyarrhythmias and the nodal tachycardias. Now, atrial tachyarrhythmias originate from the atrial syncytium. You know, you remember in the physiology days we learned that the heart is made of two syncytia. Those are the nets made by the cardiac myocytes. The cardiac myocytes are like Y-shaped structures. They divide in and each can connect with a couple of other myocytes, so they form a net-like thing. We call it a syncytium. So heart is made of atrial syncytium as well as ventricular syncytium, which is both are attached by a connective tissue cushion, which is electrical insulated. We call it AV cushion. So when it is originated in the AV syncytium, we call it atrial tachyarrhythmias. The main atrial tachyarrhythmias are the atrial fibrillation, atrial flutter, and atrial tachycardia. Usually the etiologies are also common. The conditions that make atria to enlarge, like valvular conditions or obstruction, hypertension, ischemia, all this can cause it. Now, this is another ECG that you should be able to diagnose. You diagnose atrial fibrillation by finding these small fibrillatory waves in the upper panel. In the red arrow, it has pointed to the fibrillatory waves. We call it simple F waves, and also as compared to the purple arrow indicates a P wave. So this is the ECG of atrial fibrillation, where you can find irregular QRS complexes, not only irregular rhythm, but also irregular heights of the QRS complexes. So this is atrial fibrillation with a now in these ECGs you should be able to calculate the heart rate if it is not mentioned in the ECG. How we do is we take 15 large squares. So we can take from the beginning 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15. Okay, we can take 30 large squares. 15, 16, 17, 18, 19, 20, 21, 22, 23, 24, 25, 26, 27, 28, 29, 30. So you count 30 large squares and you count how many QRS complexes are there in those 30 large squares. So here you have 1, 2, 3, 4, 5, 6, 7, 8. So you take 30 large squares and count how many QRS complexes are there in the 30 large squares. And you multiply that QRS number of those QRS by 10. So here the heart rate is about 80. If you want to be more accurate, you take 60 squares and multiply it by 5. But it is difficult. You take 30 large squares and count the QRS complexes inside it and multiply it by 10. So a couple of slides on how to manage atrial fibrillation quickly. We have a rate control option where we give rate control medication and warfarin to thin the blood and prevent the thrombosis, but give a rate control to keep the heart rate within the normal limits. Or else you can cardiovert and maintain the patient in sinus rhythm by giving an antiarrhythmic drug. You can either do a DC cardioversion or give something like amiodarone to cardiovert the patient and maintain the patient in So there are studies that have compared the rate control strategy and the rhythm control strategy and found out that there's no mortality or symptom benefit of either of these strategies. So especially elderly people with underlying cardiac problems, pathological issues in the pathological cardiac issues, best is to go for rate control. Young people and people who are symptomatic even after proper control of rate, then we go for rhythm control strategy. But the issue is we have to give antiarrhythmic medication, and those medications can cause a lot of side effects, including arrhythmias. And you all need to know the CHADS2 score when you become a house officer, and to find out the atrial fibrillation patients who need anticoagulation. So you go by the CHADS2 score. If the score is 0, they don't have to be on any anticoagulation. If the score is 1, we should give them aspirin. If the score is 2 or more, they should need warfarin. Now these are the ways that you do rate control and the rhythm control. Rate control, the rate control medications are given, or else sometimes if it is difficult, the cardiac electrophysiologist can ablate the AV node. They can destroy the AV node and put a pacemaker. So whatever the rhythm the atria has, that doesn't transmit to the ventricles, because the ventricular rate is determined by the pacemaker rhythm. Rhythm control strategies, you can do amiodarone, sotalol, or flecainide, or else now there is AF ablation. The cardiac electrophysiologists do, they ablate the atrial muscle, especially around the pulmonary origins of the pulmonary veins, and they ablate the rhythm. So I'm not going to go into details again, just highlighting what you can do. Anticoagulation is done by either aspirin, if the CHADS score is very small, or common one is warfarin, but now there are newer medications which are not available in the government sector, but you might see them time to time. They are expensive medications like the Bigetran, apixaban, and rivaroxaban. You might time to time see the patients who are on these medications. But if you know aspirin and warfarin and how to educate patients who are on warfarin and what to tell them and so on, it's good. Now, atrial flutter is also an atrial rhythm, but usually it originates around the tricuspid valve, and it always associates with some form of block. Now, in the atrial fibrillation, the atrial rate is about 380 to 400. Atrial flutter, the flutter rate is about 280 to 300. So sometimes you can have a fixed block. You can get atrial flutter with 2 to 1 block, or 3 to 1 block, or 4 to 1 block. Or else, like in ECG, now the upper panel, here, this is a atrial flutter with a fixed block, which is a 3 to 1 block. Heart rate is exactly 100. The big ECG in the lower panel is atrial flutter with variable block. If you look at here, the heart rate is about 75 in the middle, but then you can have a heart rate of about 100 and so on. So it is a variable block, and whatever it is, the treatment is almost as equal to the atrial fibrillation. Now this is another ECG. We see atrial flutter with 2 to 1 block, where the heart rate is exactly 50. It's a fixed block, atrial flutter with 50. Now the junctional tachycardia or AV nodal tachycardia, what actually happens is there is a slow pathway and a fast pathway in the AV node or adjacent to the AV node, like in these pictures. So the atrial impulses transmit to the ventricles via both these fast pathway and the slow pathway. But sometimes, if there's an ectopic cause, something like that happen, there can be a generation of a current. That means the impulses that come from slow pathway come little late, and go up again in the fast pathway when the other impulses also come in the same way. And also it forms a current and make the heart to go fast. So this is a ECG of AV-NRT type, because there are two types. I'm not going to detail again. AV-NRT type tachycardia or AV-RT type tachycardia. AV nodal re-entry tachycardia and AV re-entry tachycardia. They all usually happen in young people, and the heart rates are very fast. It can be 180 or even 200. Now here, the heart rate is more than 200. Heart is going very fast. And we have to do certain things and give certain medications to revert them back into the sinus rhythm. This is AV-RT tachycardia. How you identify is you will see an inverted P wave soon after the QR is complex. Usually the P wave is before the QR is complex, but AV-RT tachycardia, there's an inverted. Now in L5 you can very clearly see the inverted P wave after the QR is complete. But don't try to remember all these things. I just want you to know that there are atrial tachycardias, which is narrow complex tachycardia. There are nodal tachycardias, which is narrow complex tachycardia. Right? If you also want to know that there are two types, one is AV-NRT and AV-RT, that's a different thing. Even if you don't know, nothing happens because the treatment is same. So the treatment, what we do is, we'll go in there. This is another type of re-entry tachycardia, but you will very easily identify this ECG where there is no P wave, either a very short P wave or totally absent P wave, but the QRS complex starts as soon as the P wave is over. So we call it early repolarization or delta wave. This is the ECG of WPW syndrome. Again, happens for the same reason. There is an accessory pathway. So the impulses go to ventricles via both accessory pathway and the normal pathway. And sometimes there can be a start of a current or a re-entry tachycardia. So the acute management, we do various things. We do vagal maneuvers like carotid sinus massage, as you can see in the picture, or we can get the patient to do Valsalva maneuver. So I'm sure you must have seen these patients, and first try these non-pharmacological methods. Rarely they are successful. And then the two medicines that we need to know are the adenosine IV bolus. It's a fast bolus, but you have to check whether the patient has asthma and all that. And also you have to warn the patient about the side effects like flush. Then verapamil is a very slow bolus. 5 to 10 milligram is given over 5 to 10 minutes. What we normally do is we give 5 milligrams over 5 minutes. After 10 to 15 minutes, if the patient is still in this rhythm, we repeat the dose over another 5 to 10 minutes. These AV tachycardia, AV junctional tachycardias are commonly known as supraventricular tachycardias as well. Now, the ventricular tachycardia is a very important rhythm because this is sometimes can deteriorate into ventricular fibrillation, because it is not like a supraventricular tachycardia. So narrow complex tachycardia, ventricular tachycardias can put you in cardiogenic shock, and also it can deteriorate into ventricular fibrillation, ended up in a cardiac arrest. And sometimes ventricular tachycardia per se can cause pulseless ventricular tachycardia, causing a cardiac arrest. But if the patient is hemodynamically stable, now same tachycardia, same ECG, one patient can come with minimum symptoms and patient is hemodynamically stable. Patient can say, I have some palpitations, I have some chest tightness, and the blood pressure is 130 by 80, and have ventricular tachycardia. Those patients, we can try the amiodarone or lignocaine pharmacological methods to revert them back to normal. But some patients may be very symptomatic. They are drowsy, they are feeling lifeless and having palpitations, and the blood pressure is low. hemodynamically unstable. The blood pressure is 90/60. So those patients cannot wait for the medicines back. You have to do a DC cardioversion. Another person can present with a cardiac arrest. They don't have central pulses. So that is what we call as pulseless tachycardia. Same ECG, but in a different way. There you have to start CPR, and as quickly as possible, you have to give a defibrillatory shock. Now this is the ECG of multifocal ventricular tachycardia, a different type of tachycardia. You can see the QRS complexes or the abnormal wave cells as spindles. That is why they are called Tosardi pointies. It is a type of ventricular tachycardia, and this is also, I want to tell you, this is not ventricular tachycardia. This is called idioventricular rhythm. Idioventricular rhythm is a wide complex rhythm. Usually heart rate is within the normal range, or sometimes there's a rhythm called accelerated idioventricular rhythm where the heart rate is about 110 or 120. But you need to know what this rhythm is. This is not ventricular tachycardia. This is not ventricular tachycardia. This is the rhythm that takes place when the ventricles are recovering from myocardial infarction. The ventricles have started generating electrical impulses to maintain their own rhythm. That is why it is called idioventricular rhythm. There is no impulses coming from atrium. So treating this rhythm is an issue. It can cause harm. So when you see this rhythm, don't try to control the heart rate. Because if you try to control the heart rate, the patient might end up having a systole. So know about idioventricular rhythm also and read about it more. Now see, someone has taken this ECG without knowing that the patient has ventricular fibrillation. And you wouldn't do a 12-lead ECG in a ventricular fibrillation. As soon as you see this, you have to jump onto the chest and start cardiac massage and give a defibrillatory shock. But at least I have the ECG to show you. This is ventricular fibrillation. That is exactly how you identify VS. But as soon as you see this, don't take a ECG, but jump onto the chest and start CPR. I hope you all are conversant with CPR and ALS. So you will have to do it many times during your intention. Now, the next very important ECGs are the ECGs of ischemia. Now, I showed you important, I showed you ventricular tachycardia. I showed you, so those are all important ECGs. But here, non-STEMI or unstable angina is identified by these ST segment depressions, as indicated by the QRS. So these some of these arrows. ST elevation MI is identified by these ST elevation, but this is something you should never miss. Now this is the ECG without QRS complex for your comparison, but look at the V2, V3 and V4 and also V5. Look at the ST elevation. Please don't miss. And also by looking at the ECG, not only you will diagnose the ST elevation MI, you know exactly which part of the heart is being damaged. This is in this ECG is anterior septal septum and the anterior wall, anterior septal wall is getting damaged. And also you can guess which artery is occluded, which is important for the cardiologist when we do a primary angioplasty. This is another anterior ST elevation MI. We call it extensive anterior MI because V2, V3, V4, V5, V6, L1 and AVA, all the leads are both anterior septal wall and the anterior lateral wall are affected. So this is another anterior STEMI, extensive anterior STEMI. A big area of the anterior wall is affected. Now you should never miss this one. I don't know whether this patient survived. Huge ST elevation in V2, V3, so V1, V2, V3, V4, V5, V6, L1, AVL, and reciprocal changes in the inferior limbs. So this is an extensive, massive infarction, maybe a clot in the left main or so. This is another anterior STEMI, where we should not miss these ST elevations. Inferior ST elevation MI, you see ST elevation in the inferior leads L2, L3, and AVF. Finally, the other important thing that you can find out from the ECG is electrolyte abnormalities. You can find out evidence of hypokalemia, hyperkalemia, hypocalcemia, hypercalcemia, hypomagnesemia, and hypermagnesemia. Out of that, the most important ones are the hypokalemia and the hyperkalemia. And that also there is no one particular ECG. Depending on the serum levels of that electrolyte, the ECG can change. Now see, in hypokalemia, with early changes, when the potassium is 2.8, ECG looks almost normal, but the QT interval gets prolonged, T wave becomes flattened when it is 2.5, and see what happened in 2 and 1.7. Likewise, hyperkalemia also, when it is about 6.5, the QRS complex start widen, you will see a tall and tented T wave. But then slowly the QRS complex get widened, T wave get flattened, T wave also get flattened, and ended up in a sine wave pattern when the serum potassium is more than 90. Now this is a ECG of hyperkalemia. That's another very important ECG that you have to know, because in this ECG, as you can see, tall and tented T waves, especially in V2 and V3, V4 and V5. Look at those T waves, and the QRS complexes also have started widening. And you can't see much of T waves. So you should quickly identify this ECG as an ECG of hyperkalemia. Now, if you see this, the first treatment that you should do is giving calcium gluconate, IV bolus, and then look for causes and treat the hyperkalemia accordingly. Okay, with that, I'm going to stop there, and because it's extensive presentation, there was a lot of things that we have to tell, but I wanted to finish as quickly as possible by showing these important ECGs. Thank you very much.
Right, sir, few questions to end up. How can we manage sinus node arrest?
Now, sinus node arrest, again, as a house officer, there's nothing much we can do. So quickly put the patient on a bed, strict bed rest, connect the patient to a monitor, and try to, and also you look at the drug chart and stop all the medicines. But it takes time for the heart rate to come up. But in the meantime, try to give other medicines, like you can try atropine, which might not help, and also isoprene infusion, salbutamol, and also, but if these symptomatic poses are coming frequently, then we have to quickly think of getting a temporary pacemaker in until we arrange a permanent pacemaker implantation. Then I can see one question. Sir, could you please explain how to differentiate ST depressions in a non-STEMI and a reciprocal changes in a STEMI? Sometimes it's very difficult, but in a non-STEMI, what we normally see is either a flattened ST segment depression, and or T inversion. But a similar sort of change can be seen as a reciprocal change also. But then what we will do is we look at the other leads of the ECG, and you will clearly see the ST elevation. So, but I have seen occasionally that the reciprocal changes are more prominent than the ST elevation, especially in the inferior infarction, where you see ST elevation of like 1 millimeter, but you can see a very clear reciprocal change. Sometimes it is difficult, but one clear answer is when you look at the whole ECG, there should not be any ST elevation. So if there are no ST elevation, if you see only ST depression, that can be either non-STEMI or unstable angina. We collectively call it non-ST elevation acute coronary syndrome. But having said that, for both ST elevation and ST depression, there are multiple other causes. Now, for ST elevation, there are about 10 or 15 causes. I told a couple of them during the presentation. I told in this one branch block, aneurysms, early repolarization, Brugada syndrome. Likewise, there are about 10-15 causes. Likewise, for ST depression also, it's not only reciprocal change, there are several other causes as well. So you have to couple the clinical history and the evaluation of your clinical evaluation with the ECG to come to a final diagnosis. Any other questions?
I think that's all, sir. One more. So can you please explain about Q waves and joint J point?
J point elevation. Now J point is where at the end of the QRS complex, where it meets the isoelectric line. So that is how we, like classically, we diagnose ST elevation. When the J point is elevated, we call it the pathological ST elevation. The Q waves are formed. Now Q waves are there in normal ECGs also. Now even in if you take V5 and V6, we start with a very small S wave, R wave, and then a very small Q wave. But when these become pathological Q waves, they are more deeper, and that depth can be varied from lead to lead, and also it is little wider than it should be. So then we call it a pathological Q wave. So again, when you keep looking at the ECGs, and you can't look at one place and make a diagnosis. If there are pathological Q waves in 2 or 3 adjacent or contiguous leads, you can assume that there had been a previous or old myocardial infarction. Sir, it is normal to get right bundle branch block in some people, yes, with normal hearts, because the right bundle branch block is associated with certain congenital anomalies and also right heart enlargement and so on. We normally end up doing an echo just to exclude anatomical problems, but I have seen enough patients, it just has happened, even young patients, they are all normal function, having functionally and structurally normal hearts. So in which lead I have, so in which lead T wave inversions are normal, and how it changes in children. Now, especially in females, in the anterior V1, V2, V3 can be normal. And of course, in AVR, it is always normal in normal ECGs. But in V1 to V3, now, especially in females, a great percentage of T waves are inverted in V1, to a lesser percentage in V2, and even a lesser percentage in V3. Those are the usual T wave. Now it is like this. Now say there are about 500 people here, and we take 500 ECGs on all of us, and we see and we say that all ECGs are normal. But do you think that all the ECGs are identical? They are not identical. Therefore, when you keep reading ECGs, you get some experience, and that is why sometimes the patients come to us, and when they have gone to see their GP, they have said, okay, this ECG is not normal. You better see a cardiologist or a specialist. So when they come to see us, we have to explain them, okay, there are small things, but there can be a normal variant. So the T inversions are also like that. Sometimes T inversions can be normal in many people, and also sometimes tall people have T inversions. You go to the internet, put causes of T inversion, you can find so many normal causes. That is why sometimes we do an ECG when we lie down, and also standing up before we start the exercise ECG, because sometimes their T inversions get inverted when they stand. Third, to say the ST elevation or depression is significant, how much height there should be in elevation, and how much leads elevation should appear. I have seen some. Yeah, now you need to know, that is one of the major things that you need to know, the indications for thrombolysis. Now, to say that the ST elevation is significant, it has to be 2 millimeters or more in the chest leads and 1 millimeter or more in the inferior leads. Less than that is not an indication for thrombolysis. But still, you can admit the patient, observe the patient, and treat with enoxaparin. For ST depression, again, 1 millimeter, 2 millimeter depressions can be significant. Were there any missing questions?
I think that's all, sir. Yeah.
Now, the accessory pathway, what is the first choice of drug? Now, this treatment is doing an ablation, because you can completely cure the condition, failing which we can give like verapamil. Now, junctional tachycardia, the drug of choice is verapamil. Okay, let's stop there, Roshan.
Okay, sir. Right. Thank you once again, Professor Nama Vijayasinghe, Professor of Medicine at KDU, for that in-depth analysis and interpretation of ECG.
Now,
Thank you so
Roshan,
much.
if
Yeah.
they are still there,
Yeah.
someone is asking how, could you repeat how to calculate the heart rate? What you have to do is, when you take a rhythm strip, you take 30 large squares from one point to the other point, 30 large squares, and count how many QRS complexes are there in those 30 large squares, and multiply those number of those QRS complexes by 10. For example, you count 30 large squares, and you count how many QRS complexes are there. There are about 11 QRS complexes are there in this 30 large squares. You multiply that 11 by 10, so the heart rate is 110. Okay, thank you. Okay, Roshan, thank you.
Right, sir. Thank you very much. Okay. So before we wrap up, tomorrow will be another interesting training programs, that is by College of Medical Administrators and Chief Consultant JMO Dr. Ajit Tendukon will be conducting tomorrow's lecture. So all disciplinary procedures and leave particulars and curative and preventive aspects will be discussed tomorrow. So I have put the link on this chat box. So please do share with your friends of the link. So I'll share it again. So that's a Zoom link. So remember the meeting ID and the passcode will be 12345. So just share with your friends. Please log in by 8 a.m. tomorrow, and we'll be finishing around 12:30. So this is also one of the main areas that you'll need to know when you work in the boards, all the litigations, how to document, and all important things. And plus forensic and toxicology, one of the best person in the country, Dr. Ajit Tendukar, will be doing the lecture as well. So please do participate by tomorrow, 8 a.m. Right. I'll share the link again. So it's like this. So somebody's asking what are the topics. So we are starting with welcome by Dr. G. Vijay Surya. He's a Deputy Director General of Medical Services 2. Then Dr. Dilanda Dharmagunawardena, Director Medical Services on administrative aspects. Then we have medical legal aspects by Chief JMO. Then disciplinary procedure by Senior Assistant Secretary of Medical on disciplinary procedures, Mr. Rohana De Silva. Then basic of preventive medicine by Dr. Buddhika Pahesh. And then NCD aspects by Deputy Director General of NCD, Dr. Champika Vikramasinghe, and Introduction to Primary Healthcare by Dr. Priyan Tattapat. So that's all the lineup for tomorrow. So share with your friends and join. Right. Tomorrow we'll start by 8 a.m.
Recording stopped.